I think we are live.
Hey guys, welcome back. I hope the exam was good. So here I'm with Dr. Santosh and Dr. Sandeep and Dr. Sirasa will be joining us soon. They are from the centers and we are getting good reviews from the students that the exam was doable. Mixed reviews actually. Some of them say that there's a good number of PYTs. Some of them say there are not good number of PYTs. How was it, guys? Hello, Dr. Ra Pratod. Yeah, we started already. So first we'll have a quick discussion of how the exam was, and then we'll start with pathology recall, right? Santosh, what was the student saying? What was the first response of students once the exam got over? It's an exhaustive exam for two
Yeah.
sessions. So what is the
Oh,
exact review?
okay, so most of the students rated it as either easy or moderate. And of course, I would expect students to be ready for
Santosh, I
the.
think you're on mute.
No, I'm not mute. I'm not mute. Yeah. So most of the students rated it as easy or moderate. And of course, we do expect students to be ready for moderate level exams. So I would rate it as a doable exam. And then you were talking about the representation of PYQs or PYTs. I don't know about the other subjects, but when I interacted medicine wise, it's mostly based on previous year topics. So medicine, definitely I would rate it as easy rather than even moderate. Medicine this time it was easy, and I hope students will get good score on medicine. So how was it for paths?
The questions, whatever I got from pathology, seemed decent. I think hematology was a little bit of less representation, or students are not able to exactly recall. Most of the questions are like tiny clinical scenarios. Rather than asking a simple fact, they are put in the form of a tiny question, and then they are asked what's the diagnosis or how do you arrive to a diagnosis of that sort. Bulbul Q has said the first part was difficult, second part is easy. Again, there are. It's always that. Recalls also we will get more for the second half of the exam because that's fresh from their mind, and we don't know how was the first part of exam. There are two three images which are standard images which are the previous two topics. One of them a little bit looks maybe like a, kind of a controversial thing, but we'll definitely discuss with the students and we'll know that whether it was the right language of the question which can help us easily take the answers, right? So what do you think will be the because the burning question is the pass percentage, right? How do you think the students will fare this time? Will they be able to get a better score than the previous time, or do you think it will be the same way or the less?
Looking at the clinical questions, I'm sure they're going to do well on the second paper. I think some of them are commenting that the first part was a bit difficult. So I don't know how the first paper was framed, but the second paper seems to be easy. And I do believe that many of them will be able to get some extra marks to compensate for the marks they may be losing on the first paper. So I'm hoping for a better result this time compared to the previous, because previous exam, the result was good compared to the previous exams, but still many found especially surgery and OBG difficult on the previous paper. So this time everyone is saying that it was, sir, easy. So I'm hoping for a better result.
That's great. Hopefully, whatever the efforts they have put has must have been translated in the exams, and they have gone through a extensive exam. Like Bharat has said, first paper was like this, and second paper was different. MedPlay Farm, we will definitely start the recall very soon. We're just gathering questions from the students because they are just given the exam and they're on the way back. We'll be able to give an decent number of questions, at least the exact topic. With the help of you, we'll be building the questions more during the discussion as well. And then we'll come up with a better solution PDF for you soon. Fine. So PYT was less as compared to the previous year exams. That's Dr. Prince's opinion. So what is your take? Like, see, if we consider pathology per se, the questions that have been asked are the same thing, like basal carcinomas, the squamous cell carcinomas, or the meningiomas. It's the same thing with respect to pathology. What do you think is, does medicine include? I think you also said that medicine had quite a few questions from the PYTs, right?
So medicine was quite on the predictable lines. Like generally, the important topics that we read includes JVP, hepatitis B serology. When it comes to ECGs, either arrhythmias or AV blocks. So like there was a question on atrial fibrillation, quite predicted. There was a question on first degree AV block, quite predicted. Hepatitis B serology, questions were there. JVP, questions were there. These are all previous year topics. Of course, the depth of the questions may vary with time, but at least this time they were quite superficial, not very deep. So if you know a little bit of the topic, you should be able to deal with it. Those were the kind of questions.
Siddharth sir, we are also waiting for you. Sir, sir has also commented there. Sir is stuck in between reaching the studio. Sir will reach the studio soon because sir was there in the exam center getting real-time feedback from the students. Sir will definitely join us very soon, hopefully. And he also will give his inputs on how it was. Yes, Bharat, the language of the questions is what the only place where the examiner, I think they can trick them in the future. Because you guys are very well prepared. You have prepared all the necessary PYTs from the past 5-10 years. Most of the topics which is required from an MBBS student is sorted already. So the only way they can make it difficult is put double negatives or ask a very twisted sentence or a big sentence, a big clinical sentence. That's the only way I think it will go ahead in future. What's your take on that, Santosh? The language of the questions were horrible as per Dr. Bharat. Hi, Dr. Choice.
Yeah. As you said, the testable topics are kind of exhausted. Now, going into a very rare, not so important topic is counterproductive for the even examination authority. So all they can do now to keep the results low is try to play with the language. So with time, students also should learn the language of the examiners. And as the language changes, our approach should also change for preparation. But today, I personally, at least whatever I have recalled so far from medicine, language was not a barrier. The exam questions were framed the way routinely the questions have been framed all these years. But I don't know about other subjects. The other subjects' language might be very tricky.
True. Anush, definitely we'll discuss the questions. Questions discuss करूंगी. 10-15 minutes. Just give us like we'll definitely start the discussion because we are just getting the recollection of the questions from the students. So on the note, like what's your other take? Like anesthesia has no very less questions as per Prince on malignant hypothermia and a few things. And Bulbul Cute says that many famous questions from minor subjects have been removed. I'm not exactly understanding what's removed. Maybe the representation was less. That always changes. You take NEET PG exam, INICT exam, or FMGE exam, any exam, it will not be exactly as per the blueprint. It will sway here and there. That's great, your talk of choice. Hopefully, you'll get good rank. We are happy as well. Fine. Okay, so what's your take on that, Dr. Santosh? Like, should it always be as per the blueprint what FMG gives that, okay, ANAT should have 17 questions, Pharma should have 20 questions, or it'll differ?
No, I think the blueprint only exists on paper. So whatever previous exams, blueprint was never followed. One of the other subjects ends up getting more weightage and one of the other subject ends up getting lesser weightage. So students should not expect the board to stick to the blueprint. That's the basic learning point of observing the exam for over many years. And I think most of the students are also aware now that be prepared for a googly. Don't expect them to ball on the expected lines, at least with respect to distribution of questions.
Okay, great. So MedLife Perm, few tips for December 25 aspirants. We a bit early now. I will definitely take care of the recall first. I feel that you guys deserve a very well-deserved break and you will definitely clear this exam and we'll see how to go for the internship and rest. For December 25, we'll definitely come up with a better schedule for you guys to take care of it. If you have not given this exam, just listen to the recall. Look at how the questions have been there. Has it changed? Has it not changed? That will be the best thing for you, which you can do on today. Any tips from you, Santosh, on December 2025 aspirants?
Well, I would still say stick to the basics. If you know the basics, even this exam, if you had done the previous year topics, you could easily get the pass marks. See, we can argue saying that there was representation for PYTs less or more, but nonetheless, if you're thorough with the PYTs, reaching the pass mark is not difficult. After that, if you have done extra topics, you can score brownie points over and above the pass marks. So at least PYTs you should be able to do multiple times before you approach the exam, and whatever extra time you have, spend it on individual subjects depending on how well prepared you are currently and how much more you want to add to your current knowledge. One question I have to you, Dr. Ranjit. Like the pathology or the second year subjects or the first year subjects, there's a separate paper. Of course, the representation will be appropriate between pre-para and the clinical subjects. So it's well divided, but within the first paper, Was there any discrepancy in the distribution of questions?
Generally, I would say that pathology will have path and pharma will have quite a good number of representation the first year thing, and this year I feel that path is a little bit less, or I am not sure that students are not yet gone to the level of complete recall yet. Generally, we used to get easily 20, 25 plus questions, plus or minus. Some will be like a scenario which might overlap with pharmacology, sometimes a little bit with microbiology, immunology questions. But this time I feel that hemat per se, they have reduced a substantial number of questions, very few of them from hematology. The standard ones from hematology, like vacuotinous, there's been no questions from vacuotinous or lymphomas, leukemias. The predicted ones, they have not come. But so obviously, when one reduces, the other one gets a little bit of more advantage. The same thing, like Dr. Prince was saying, uh, anesthesia was not there, short subjects was not properly represented. That will obviously go and fall on to medicine, surgery, OG, and pediatrics. The same thing will happen here. So we have a couple of more superstars here with us. So they both were in the center. Hello, Sirat sir. Hello, Sandeep sir. How are you guys? So
Hi,
what's
Rajit sir.
your
Hi,
opinion
Santosh
on
sir.
how the exam was?
Right.
Yes.
Okay. No, no.
Please.
Okay. We had like we do our rituals. We continue to visit our students at the center. So today we had tons of students coming in, flocking Shiraj sir. So there's a lot of huge crowd. So see, initially what we got to know from the exam center is there are 6 different sessions, and each session was a mixed bag, and there's a lot of mixed response that we get. We were listening to you guys. Santosh was saying medicine was easy. Surgery, on the other hand, was slightly more trickier. Yes, the questions were, in a clinical form. So you take the lead. क्या लग रहा था?
यस मुझे भी देख के ये लगा कि अब पूरे 300 क्वेश्चन को इन्होंने डिवाइड किया था, जैसे पार्ट 1 में कहीं पीडी आ रहा है, कहीं बीच में सर्जरी आ रहा है, राइट, एंड देन देयर वाज पीएसएम इन द पार्ट 1 आल्सो, देन देयर वाज पीएसएम इन पार्ट 2 आल्सो. सेम गोस फॉर फार्माकोलॉजी और मेडिसिन के इंटीग्रेशन जो क्वेश्चन जो आ रहे थे. तो अगेन जो 300 क्वेश्चन था, पहले जो पैटर्न फॉलो हो रहा था दैट दे विल बी आस्किंग पेपर 1 में एनाट फिजियो बायोकेम पैथोफार्मा माइक्रोफोरेंसिक, वो चीज नहीं फॉलो हो रहा है. अब क्या है, 300 क्वेश्चन है, उसमें जो क्लर्क लेवल पे जो लोग हैं उनको बता दिया गया कि भाई इस 300 को जंबल अप कर दो, डू द जंबलिंग अप एंड देन मेक 50-50 का 6 सेगमेंट एंड देन गिव द पेपर.
Sir, we've been telling students also ना
Right,
कि mixed bag practice करना है. संतोष सर, we had that session, उनमें सर ने भी बताया था कि we need to do mixed bag. मतलब you can't expect you'll do anatomy, then you get physio biochem. No, you have medicine integrated with physiology, pharma integrated with physio biochem, path with surgery, micro was tossed in. So yes, it was a mixed bag. But overall, students were quite satisfied because yes, there were PYTs were there. I wouldn't say exact PYQs.
PYTs थे सर, लेकिन उसमें क्या हुआ, इस बार वाले पेपर में यूजुअली क्या होता था कि देयर वर लॉट ऑफ PYTs, बट इस बार प्रीवियस ईयर को कम करके देयर वर अ कपल ऑफ न्यू क्वेश्चन एज वेल. अब जो न्यू क्वेश्चन थे क्या थे, जो बच्चों को नहीं आ रहा है वो बच्चे, उनको लग रहा है कि यार ये तो बहुत ज्यादा हो गया. जो आ रहा तो वो भूल जा रहा है. जैसे इमीडिएटली एक लाइन का क्वेश्चन आया, दे नो द आंसर. फॉर एग्जांपल दे आस्क अबाउट माउंटेन सिकनेस की विच साइड पे ट्यूब्यूल की किस साइड पे काम करेगा, तो पता चल रहा है बच्चों को. देन दे मार्क सर ड्रग ऑफ चॉइस सर्वाइकल कार्सिनोमा क्वेश्चन आया, देन ईएनटी में क्वेश्चन ऑन नेसोफेरेंजियल कार्सिनोमा, बर्न में जो आपका क्वेश्चन आया था. तो जो इजी वाले क्वेश्चन थे बच्चे मार्क के आगे बढ़े. Whatever they got tricky, वहां पे they got stuck a couple of times and then they made, I mean some of them are thinking कि बहुत सारे थे, लेकिन अराउंड 50 क्वेश्चन जो बच्चों ने बताया, a couple of students हैं कि सर 50 प्लस क्वेश्चन ऐसे थे जो एकदम नए थे, जो बिल्कुल भी देखे नहीं गए थे. Which we also say the same.
Usually what when we relate with FMG exam ना, हमारा ये होता है कि एटलीस्ट 40 से 50 आपको इमेज बेस्ड क्वेश्चंस मिलेगा.
इमेज बेस्ड क्वेश्चन ऑन द स्लाइड कम था हाँ ना, इमेज बेस्ड क्वेश्चन कम थे, दैट्स व्हाट दे सेड.
यस,
क्लिनिकली इंटीग्रेटेड थे. एंड अगेन पहले पार्ट में ऐसा नहीं कि वन लाइनर नहीं था, देयर वर वन लाइनर्स आल्सो. एट द सेम टाइम इन सेकंड पार्ट देयर वर क्लिनिकल्स आल्सो. स्टूडेंट गॉट वेरी हैप्पी आफ्टर पेज 2. पेज 1 के आई मीन phase 2 part 2.
Siraj sir had the privilege of attending both the sessions, so he went in the lunch break also. So to boost up the morale and all, that time the students were at a lower key.
मतलब उनका चेहरा देखने लायक था कि they were like, मैंने कहा कि यार डरावना चेहरा है बच्चों का, रहते हैं. मैंने कहा आराम से पढ़ाई करो.
ये डरावना चेहरा भी ना probably वो expect नहीं कर रहे थे कि पहले सेशन में उनको क्लिनिकल मिलेगा.
राइट.
तो उसकी वजह से it's not the questions were not difficult. It was they were taken up by surprise. They started to integrate from question number 1 itself, right? So Santosh sir and Saranjit sir, your take on time management and mixed bag management is what I think is more important key.
So before going there, so that's why your chemo man helped them a lot. This is the comment I was just reading, and there was a very random thing. All murmurs what Santosh sir talked in cardiology came. And
Right.
Dr. Anubhav said that he is hoping to score about 200, all the very best and above. We're also expecting to
Crazy,
talk to
crazy.
you after that.
That is
So
well.
results, Prince, they'll announce the results. You know about NB, whatever they say date, they'll never do it on time. So we'll just wait for them to announce. One fine day, your friend will message results aa gaya, and you'll have a PDF. You'll find your name. That's all. End of story. Don't worry about the results. Fine.
एंड बाय नाउ सर अभी तो मैं स्टूडेंट से ये बोलना चाहूंगा कि देखो यू हैव गिवन द एग्जामिनेशन, कंधे पे जो लोड था ना कम हुआ, रिलैक्स फील कर रहे हो ना, देखो कंधे एक बार रख करके देखो, आर यू फीलिंग रिलैक्स्ड और नॉट। अब इस रिलैक्स एनवायरनमेंट में एंजॉय करो। देखो कल से क्या होगा, यू इवन इफ यू वांट टू एंजॉय यू वोंट बी एबल टू एंजॉय, बिकॉज अब तक क्या था, देयर वाज अ प्रेशर, उठना है, पढ़ना है, रिवाइज करना है, जीटी देना है, जीटी पढ़ना है, ये नोट्स पढ़ना है, वो नोट्स पढ़ना है। अभी क्या कोई काम ही नहीं है,
हो गया काफी है।
जॉबलेस
No.
है ना।
ना भाई देख,
स्टूडेंट्स विल फील लाइक दिस।
आई नो, मतलब सी जितना आपने डालना था एफर्ट हो गया,
हाँ,
ठीक है।
बस ये रिलैक्स करो अब यार।
आज सोना है, मतलब घोड़े बेच के सोना है, ठीक है। फॉरगेट अबाउट एवरीथिंग सर, दे डिजर्व इट ना। आज आराम से चिल कर।
वेल अर्न्ड, वेल अर्न्ड। लेकिन प्रॉब्लम ये है कि इनको दिया भी जाए तो दे विल स्क्रॉल ऑन द रील, है ना, जो कि महीनों से जो नहीं किया अब वो करेंगे। एनीवे दिस इज योर टाइम, यू गाइस आर गोइंग टू एंजॉय। अपने हिसाब से अपने टाइम को लो, सोना है सो, रील देखना है रील देखो। अब जो कुछ भी के लिए मैंने बोला था पहले, हम सब ने बोला था इफ एनीथिंग कैन वेट पुट इट ऑन वेटिंग लिस्ट। अगर आपने वेटिंग लिस्ट पे जो भी डाला था, नाउ इट्स फ्री टाइम फॉर यू टू डू, है ना। 2-3 दिन तो लगेगा कि कुछ जॉब नहीं है, लेकिन 2-3 दिन बाद एवरीथिंग विल बी फाइन। हाँ, एट द सेम टाइम जैसे कि रिकॉल देखेंगे बच्चे, एंड सम क्वेश्चंस विल बी लाइक मिस इंटरप्रेटेड, है ना।
that's a very
तो
common.
वहां पे क्या होगा कि डू नॉट फील लो कि नहीं मेरी तो जिंदगी खराब हो गई, मैं तो अब ये गलती कर दिया, मैं सिली मिस्टेक कर दिया। इट्स बाउंड टू हैपन। 20-30 recall, I mean 20-30 silly mistake in the recall. If you are going to find 20-30 mistakes while watching the recall, absolutely fine, ये normal है, सभी के साथ होगा।
Or
Right?
yeah,
It's
as a
fine.
disclaimer from all the teachers also that we want to put up,
Right.
the recall that we do, is it the exact, it's not the exact question.
No, not at
We get a first hand information कि what topic had come, so that you know that, you know, when you
आने
when
वाले टाइम में
हाँ,
क्या
जब हम
पढ़ना है।
recall कर रहे होंगे तो उनको question सारा better interpreted हो जाए।
बिल्कुल।
And as we go, we can continue to, you know, get better at the question. Recall का objective ये नहीं है कि आपको डराना है।
हाँ।
Recall का objective ये है that you know that you have done well. ठीक है, ये टॉपिक आया था, इसका ये आंसर है, अगर आपके क्वेश्चन में फिट हो रहा है, दैट शुड बी द ऑब्जेक्टिव।
बाय द वे, एट एनी पॉइंट ऑफ टाइम अगर स्टूडेंट्स को लगता है कि सर दिस वाज नॉट द एग्जैक्ट लाइन, बिकॉज देखिए जो बच्चा देख के आया ना वो टीचर को बताएगा।
हाँ जी।
नाउ टीचर मे टेक इट समवेयर किसी और तरीके से, मे बी टीम कोई और तरीके से लेगा। सो क्वेश्चन जब तक आता है और जब तक आपको प्रेजेंट किया जाता है ना, तो आया रहता है किसी और फॉर्म में और जाता है किसी और फॉर्म में, तो ये हमेशा का रहता है। तो आपको पैनिक नहीं होना है कि नहीं ये आया था और ये इन्होंने कैसे पढ़ा दिया। इट्स एब्सोल्युटली फाइन।
पैनिक वाले दिन गए, खत्म हो गया, चल ठीक है।
Right.
So that was, you know, we wanted to gush this out. We just ran from the center and I drove at a very crazy pace. So this is what we wanted to convey to you. Over to Santosh sir and Ranjit sir.
Okay, so I think Dr. Ranjit will take a break for a few minutes. He will join us once he's ready with the questions. So meanwhile, I have a few points to gather from you guys. So like many students are telling paper one was tricky. So one thing I understood that the trickiness was from the clinical questions coming into paper one. But beyond that, what else was tricky? Was it the language or the topics on which the questions were asked were tricky? What was it?
सर एक्चुअली जो मुझे जो समझ में आया बच्चों से बात करके, अर्लियर दे यूज्ड टू आस्क डायरेक्टली, लाइक डायरेक्ट क्वेश्चन, लेट्स से देयर इज अ पैरासिटामोल पॉइजनिंग, व्हाट इज द एंटीडोट, देन दे आस्क कि एंटीडोट दिया गया, व्हाट विल इट रिप्लेनिश। नाउ इट इज टोटली मोर टू द क्लिनिकल लीनियंसी, है ना, कि पैरासिटामोल पॉइजनिंग का केस आया, यू हैव गिवन एनेस्टाइलसिस्टीन, अब इसमें क्या ट्रू है या क्या फॉल्स है। फॉर एग्जांपल लीवर फेलियर विल ऑकर इन दिस मेनी आवर्स, सो स्टूडेंट हैड टू बी क्लिनिकली साउंड। और जो रटिफिकेशन वाला जो समय था कि एक पढ़ लिया, एंटीडोट पढ़ लिया, लिस्ट पढ़ लिया, उससे हो जाएगा, नाउ दैट इज समथिंग दैट इज नॉट वर्किंग। आई मीन अ कपल ऑफ क्वेश्चन, कई जगह पे तो सेम क्वेश्चन है। जैसे मैं अपने सब्जेक्ट की बात करूं तो अगेन पल्मोनरी फाइब्रोसिस कॉज बाय ब्लियोमाइसिन, वो क्वेश्चन आ गया, सिस्प्लेटिन कॉजिंग नेफ्रोटॉक्सिटी, वो क्वेश्चन आ गया, राइट, ड्रग ऑफ चॉइस फॉर सर्वाइकल कार्सिनोमा। कुछ क्वेश्चन ऐसे थे जो डायरेक्ट आ गए, जैसे बोटुलिज्म टॉक्सिन का मैकेनिज्म ऑफ एक्शन क्या है, दैट इज गोइंग टू इनहिबिट द रिलीज फ्रॉम द प्रीसिनेप्टिक न्यूरॉन। तो कुछ क्वेश्चन डायरेक्ट भी थे। At the same time, there were few questions that was little tricky. उसको क्लिनिकली फॉर्मुलेट किया गया, एंड एग्जामिनर इस बार ऐसा लगा कि एग्जामिनर ने बच्चों को सेल्फ मेड, हैंड मेड इमेजेस भी दिखाए, राइट, सो दैट यस देयर वर हैंडमेड इमेजेस, जैसे हम लोग क्लास में ड्रॉ करके पढ़ाते हैं ना, तो वैसे दे ड्रॉ द हैंडमेड इमेजेस एंड देन दे हैव गिवन इट, इट्स नॉट अ गूगल इमेज, गूगल से नहीं लिया गया।
एनबीए ने मेरा ट्रिक पकड़ लिया I
Yes,
always have to
yes.
tell them how to reach out to what images NVA picks up, कि हाँ
हाँ
गूगल में सर्च कैसा करना है और कौन से पेज वाले इमेजेस वो क्वेश्चंस में यूज करते हैं. एंड मेनी टाइम स्टूडेंट्स वर टेलिंग सर आपने बताया था कि ऐसा ही मेथड फॉलो करते हैं एंड सेम इमेजेस वी आर गेटिंग इन द क्वेश्चंस. बट नाउ गया if they have started making sketches. Okay, so that also means that students have to study it.
सर बैलेंस पेपर था एक्चुअली इस मामले में. जैसे कि ईएनटी के कुछ टॉपिक हैं वो यूजुअल हैं. नेज़ोफेरिंजियल कार्सिनोमा का क्वेश्चन है वो आएगा ही आएगा, राइट. देयर वाज अ क्वेश्चन, देन देयर वाज अ क्वेश्चन आल्सो ऑन द ग्राफ वाला जो क्वेश्चन आता है, करहार्ट्स नॉच वाला जो क्वेश्चन आता है, राइट. देन देयर वर क्वेश्चन, कुछ ऐसे क्वेश्चन थे जो हैंडमेड थे, मतलब सारे ऐसे नहीं थे, बट एट द सेम टाइम पेपर डुएबल था फॉर दो स्टूडेंट जिन्होंने फर्स्ट ईयर से लेके पढ़ाई करी है, जिनको कॉन्सेप्चुअल बेसिक कॉन्सेप्ट जिसके क्लियर थे. जैसे पेपर 1 के बाद सबको शॉक इसलिए लगा था बिकॉज उसमें बेसिक कॉन्सेप्ट की बहुत ज्यादा जरूरत थी. उसमें ऐसा था कि अगर आपने बेसिक कॉन्सेप्ट नहीं है तो यू वॉन्ट बी एबल टू डू दैट. ये कंफर्म था, फैक्ट था. लेकिन पेपर 2 देने के बाद से स्टूडेंट्स वर रियली हैप्पी, है ना. उनके फेसेस पे स्माइल था कि यस नाउ देयर इज अ होप दैट डेफिनेटली वी आर गोइंग टू गेट थ्रू दिस. और लेट्स होप फॉर द बेस्ट रिजल्ट एंड सी व्हाट हैपेंस. लेकिन हमारा जो असेसमेंट
Basically,
Santosh
so
sir, I just
basically
want to
ये
address one
हाँ.
issue that is going on the chat box. I mean, एक question को related है अक्लेसिया कार्डिया को लेके. I mean, Rishabh sir will jump in, you can jump in. I also see the same. बेटा question for अक्लेसिया कार्डिया, you have to see कि question कैसे frame था. अगर it was a radiological image, अगर उनने filling defect word use किया है, filling defects are usually seen in mass lesions, they're not seen in अक्लेसिया कार्डिया. अगर वो सिर्फ स्मूथ फिलिंग दिखा हुआ है, डिफेक्ट नहीं है, इट कुड बी आइदर यू कैन हैव अ पेंसिल टिप अपीयरेंस, अगर वो ऑप्शन में था, और यू कैन हैव अ बर्ड बिक अपीयरेंस और शॉर्ट रैट टेल अपीयरेंस. अगर ये दिया है एंड डिस्फेजिया मोर फॉर लिक्विड्स व्हेन कंपेयर टू सॉलिड्स दिया हुआ है, then the answer will be of Ecclesia cardia. Don't worry, as we continue to go with the recall, we'll try to construct this question even better way. So इस पे ज्यादा दिमाग लगाने की जरूरत नहीं है. Dysphagia more for liquids when compared to solids, it's a progressive dysphagia. और अगर इमेज दी है और इमेज में अगर वर्ड है स्मूथ फिलिंग, then the answer goes in favor of Ecclesia cardia. ठीक है?
Right.
So yeah, more liquids, then see more. बेटा rat tail appearance अगर वर्ड दिया हुआ है, you can still consider that with Ecclesia cardia, short rat tail. Yeah.
Exactly.
नहीं, एक misnomer ये भी ना कि सर if there is a continuous rat tail, that goes in favor of defect filling defect malignancy.
लेकिन हिस्ट्री में दे रहा था ना कि देयर वर डिफिकल्टी फॉर लिक्विड मोर.
हाँ बस
लिक्विड मोर तो एक्लेशिया है, इसमें आपको फिर इसमें कंफ्यूज नहीं होना है.
सागर से बेटा स्मूथ है तो इट इज गोइंग टू बी इन फेवर ऑफ Ecclesia. डोंट वरी अबाउट इट. ठीक है, चलो.
Asif also says more liquid than solid. It's going to be same.
Sorted.
Ecclesia.
Right. So see, this time you can see that they did not ask the question directly on Ecclesia. So they gave all the details and they said what is the possible, the finding that you are able to see in that. So the questions were more of that sort. Disease नहीं पूछा था क्या? Zakir, can you just expand? ठीक है, we'll see as we go on to the recall. ठीक है, don't worry about it.
एक एक करके रिकॉल में देखते जाइए. बाकी अगर आपको कहीं पे भी लगता है कि ये रिकॉल एग्जैक्ट नहीं है या इसमें कुछ एरर है तो डेफिनेटली यू गाइस कैन पुट योर थॉट इनटू इट. एंड अगर आपको कुछ याद आता है तो यू कैन पुट इट इन कमेंट बॉक्स आल्सो एंड आवर टीम विल पिक फ्रॉम देयर एंड विल कम बैक विद अ बेटर वर्जन ऑफ द रिकॉल. वेरी सून वी आर गोइंग टू स्टार्ट द रिकॉल एज वेल. अगर आपके और कुछ डाउट्स हैं, अभी के लिए बस मैं ये बोलूंगा यार कि डाउट क्या ही रखोगे. अभी थोड़ा सा फेज आपका ना थोड़ा सा रिलैक्स करने वाला फेज है कि ठीक है, थोड़ा एंजॉय करो कि भाई कंधे का जो बोझ था ना वो खत्म हुआ है ना. अब तैयारी करो, निकाह की तैयारी करो है ना. अब देखो जिसका इंतजार था वो होने वाला है, तो इस बात के लिए खुशी करो, शॉपिंग करो कि हाँ भाई ठीक है, पापा लड़की देखना शुरू करो या है ना उनको बोलिए कि पापा है ना शौहर देखना शुरू करो. जो भी है ना, देखना एक मतलब ख्याली पुलाव बनाओ अपने, है ना. बिकॉज अभी लेट्स नॉट गो इनटू दैट कि क्या मैंने गलत कर दिया और उसको लेकर के ये मोमेंट मत खराब करो. जो हो गया दोबारा जाके हम सही नहीं कर सकते.
करके खुद पछता रहे और उनको बोल रहे हो पछताने के लिए. अभी चिल करो, रिलैक्स.
जरूरी है मैं बता रहा हूँ.
बाद में रिलैक्स, बाद में देखेंगे.
Ortho faculty is also live.
I have not said anything.
She is listening.
नहीं बिल्कुल करिए आप लोग और एकदम करना है ना. संदीप सर ऐसे ही आप लोग को भड़काएंगे लेकिन भड़कना नहीं है.
I am taking an exit.
वैसे तो फार्मा कैसा था दिस टाइम, बिकॉज स्टूडेंट्स के लिए वो हाईली स्कोरिंग सब्जेक्ट है.
सर फार्मा से यूजुअली 25 से 28 मार्क्स आते हैं. इस बार भी करीब 20-25 क्वेश्चन जो हमें अभी तक आए हैं हमारे पास, 20-25 क्वेश्चन तक तो आ गए हैं मोस्टली. तो वो क्वेश्चन जो भी थे डुएबल थे। जैसे कि मैंने बताया था कि कीमोमैन जो मैं पढ़ाता हूँ यूजुअली हर रिव्यू में या रेगुलर क्लास में, कीमोमैन से डायरेक्टली 2 क्वेश्चन आ गया। देन वो माउंटेन सिकनेस वाला क्वेश्चन डायरेक्ट ना दे करके इन्होंने इनडायरेक्टली पूछ लिया, बोटुलिज्म टॉक्सिन का मैकेनिज्म ऑफ एक्शन पूछ लिया। बाकी जो भी टॉपिक्स जो क्वेश्चन आए थे थोड़े कॉन्सेप्चुअल भी थे, जैसे एएनएस के क्वेश्चन थोड़े कॉन्सेप्चुअल बेसिस पे थे, तो क्वेश्चंस वेर सच की डुएबल थे। मतलब मैं अगर बताऊं एक लाइन में बोलूं तो 80% ऑफ द क्वेश्चन वेर इजीली डुएबल। अगर आपने रिव्यू क्लास करी है तो या कोई भी रेगुलर क्लास करी है तो 80% ऑफ द क्वेश्चन, इनफैक्ट मोर देन 80%, मैं सिर्फ फार्मा की बात कर रहा हूँ, अपने सब्जेक्ट की बात कर रहा हूँ कि माई सब्जेक्ट में मोर देन 80% ऑफ क्वेश्चन वाज इजीली डुएबल। मतलब ऐसा था कि आप क्वेश्चन देखोगे और रिफ्लेक्स से आंसर आ जाएगा आपका।
सर एक और चीज दैट वी शुड एड्रेस नो
हाँ।
अबाउट द डिस्टेंस ऑफ द सेंटर दे वर अलॉटेड।
हाँ, ये इस बार थोड़ा सा पंगा ये हुआ जो कि मैं काफी वरीड था और काफी बच्चों ने मुझे बोला, तो मैं पहले से ही बोलता आ रहा हूँ कि इफ योर सेंटर इज बियॉन्ड 2.5 आवर या 2 to 2.5 आवर, रीच 1 day अहेड। काफी बच्चों को मैंने पर्सनली एडवाइस भी किया था। इस बार क्या हुआ कि काफी सारे सेंटर बहुत दूर थे, जैसे दिल्ली के काफी सारे बच्चों का आगरा सेंटर था।
हाँ।
अभी उसमें दिक्कत क्या हुआ कि बच्चे पूरी रात तो सोए नहीं, 1 बजे 2 बजे आके बस में बैठ के बस वहां से 3 बजे निकली, तो सोचिए पूरी रात सोए नहीं, बस में 2-3 घंटा जो सो पाए वो सो पाए। And then 6 o'clock they reached to their centers, right? Some of the students were at my center in Aligarh also, some of them were in Agra also, है ना? तो अब उसमें क्या, पूरी रात खराब हुई है बच्चों की। द प्रॉब्लम इज जो बच्चे कल रात में चले गए थे उनके साथ भी इशू हुआ। ऐसा नहीं कि वो जाके वहां शांति से सो गए, वहां पे भी एक एंग्जाइटी मोड था कि कल क्या होगा, कल कैसे होगा। तो ये एक थोड़ा सा गड़बड़ी ये हुआ है एग्जामिनेशन का जो मैनेजमेंट है उनके पॉइंट ऑफ व्यू से, कि बच्चों को जो इन्होंने पहला सेंटर डाला था, यूजुअली हम लोग के टाइम में जब हम लोग कभी भी नीट पीजी या आईएनआईसीटी का सेंटर डालते थे तो सर हमें पहला सेंटर यूजुअली अलॉट होता था 90% टाइम में, राइट। लेकिन अब वो नहीं हो रहा है। जैसे अभी मुझे एक स्टूडेंट मिला था, वो कोलकाता से आया हुआ है। आप सोचो कोलकाता से अर्ली मॉर्निंग की फ्लाइट लेके स्टूडेंट आया हुआ है और पूरी रात कहाँ सोया होगा, राइट। एयरपोर्ट पे धक्के खा रहा है, फिर आके सेंटर पे अपना बड़ा सा लगेज लेके आया, सेंटर के सामने बैठा हुआ है। तो दिस वाज समथिंग व्हिच वाज लिटिल सैड एंड एट द सेम टाइम लिटिल कंसर्निंग, बिकॉज डेफिनेटली सर अगर बिना सोए जाओगे दिमाग क्लाउडेड रहेगा, रिजल्ट पे इफेक्ट तो आएगा ही। आपका वहां पे जो कैपेसिटी है, क्वेश्चन सॉल्व करने की कैपेसिटी है, सब कुछ कॉम्प्रोमाइज होगा।
दैट वाज देयर, मतलब दैट्स समथिंग दैट इवन द एग्जाम बॉडी शुड कंसीडर, है ना। विंटर का टाइम है, ट्रैवलिंग इशू है, बच्चा का अटेंशन स्पैन हैम्पर होता है। I mean, that was one of the common grievances that we heard today. Again, it's NB.
I mean, depriving someone of sleep is inhuman.
No, sir, it's NB, sir. It's not inhuman. It's NB.
NB human. Okay, so Dr. Sandeep, surgery is doing rapid revision enough to get 70% questions?
Sir, that I have to see with the recall. I didn't have the exact the time to look onto the recalls per se. जो भी मुझे देखने को मिला है whatever questions जैसे अक्लेसिया कार्डिया और let's say burns हो गया, or we have the question on swelling in the forearm. So all these we had already discussed in our जो अभी हमने FMG decoded किया था on our channel itself. But then I have to go see what are the other context of the questions, because surgery now is getting more hidden. I got one question where it's about breast cancer operative. There was an image and there was a muscle that was marked. So we have to see what muscle did they mark. Did they mark pectoralis major, minor, or serratus anterior? So based upon the imaging that you have to see. So yeah, more or less it is covered. See, FMG does not give you huge surprises. Either it gives you the 10% extreme bounces and 90% of them stay within the bounds of the subject and the topic only. So I'm not expecting a big major shift. So it could be in that context.
सर आपका बताइए मेडिसिन का कैसे रहा, बच्चों का क्या रिस्पॉन्स आ रहा है मेडिसिन को लेकर के? मेडिसिन से काफी क्वेश्चन थे। बच्चे काफी हैप्पी थे मेडिसिन को लेकर के कि सर मेडिसिन डूएबल था। आपका क्या रिस्पॉन्स?
I got decent number of questions so far. तो सारा predictable topics के ऊपर ही था, nothing googly. जो predictable PYTs हैं, it was all based on that. And जो clinical STEM होता है, that was also on the standard lines, कि वहाँ पे ज़्यादा confounding factors या tricky lines नहीं थे. So most of them got the STEM right. They understood what is the disease that question is talking about. And उसके आगे का जो last closing statement था या question था, those were also on the predictable lines. Like जो predictable topics है, JVPO या arrhythmias, atrial fibrillation, first degree AV block, everything was on the predictable line. So medicine this time was high scoring subject. So those who have done even the rapid revision should be able to get 70% questions right.
कुछ स्टूडेंट का पहला क्वेश्चन ही मेडिसिन था, पेशेंट आता है हार्ट ब्लॉक के साथ और पूछा कि क्या क्या ईसीजी चेंजेस आएंगे. I think a degree of heart block was also given. Then they asked what are ECG changes we are going to see. PR interval पे क्या आएगा, है ना, और बाकी सारे सेगमेंट्स दिए हुए थे. तो कुछ स्टूडेंट का पहला ही क्वेश्चन था. That's what I got to know कि फर्स्ट क्वेश्चन हमारा मेडिसिन का क्वेश्चन आ गया. मेडिसिन फिजियोलॉजी इंटीग्रेटेड.
So RG says INI-CT का पेपर लग रहा था. So what's your view on that?
Sir, I would, yeah, well, like, see, we've been seeing FMG exam been evolving over a period of time. I mean, you're bound to expect कि हर session, especially if you see, जो हमारा fresh session होता है, उसका level of question थोड़ा high है, repeater में थोड़ा कम रहता है, but then again the matching. See, what I see from here, I've told in the last session also, आगे जाके अगर next का forset है ना, so they're trying to get all the exams at the same level. चाहे वो FMG हो, NEET PG हो या INI-CT हो, so they're equalating. That's what I
सर
feel.
एक्चुअली एग्जाम बॉडी सेम है ना. बार बार मैं क्लास में हमेशा ही बोलता हूँ कि योर एग्जाम बॉडी इज सेम. फॉर एग्जांपल मैं और सर एग्जामिनर हैं और हमें बता दिया गया कि आपको 10th का एग्जाम सीबीएसई बोर्ड का लेना है, 10th का एग्जाम आईसीएसई बोर्ड का लेना है, राइट. ऐसे करके दो अलग अलग एग्जामिनेशन है. अब अगर हम दोनों मान लीजिए फॉर एग्जांपल बायोलॉजी के टीचर हैं, तो बायोलॉजी में जो एरिया है, जैसे मान लीजिए सर का फेवरेट एरिया फर्टिलाइजेशन है, मेरा फेवरेट एरिया अगर सेल है ना, तो फर्टिलाइजेशन के सर ने जो क्वेश्चन पहले बनाए हैं उसी के आसपास क्वेश्चन रिवॉल्व करेगा, चाहे वो किसी भी पर्टिकुलर एग्जामिनेशन का हो. तो नेम चेंज है, एग्जामिनेशन का पैटर्न इज ऑलमोस्ट सेम. और ये जो भी आपको बता रहा है कि ये एग्जामिनेशन अलग हो जाएगा, ये एग्जामिनेशन अलग है या इसका लेवल है, देखिए आपको टॉपिक देखना है. आपको कल कोई ये नहीं पूछेगा कि आप एफएमजी पास करके आए हो या नीट पीजी पास करके आए हो. आप कल अगर किसी मर्मर को आइडेंटिफाई करके पेशेंट को ट्रीट करोगे ना, तो यू विल बी ट्रीटेड एज अ रेस्पेक्टेबल डॉक्टर ओवर देयर. तो आप ये समझ के चलिए कि आप एज अ डॉक्टर बन रहे हो, एज अ टॉपिक पढ़ रहे हो, ना कि आप एग्जामिनेशन वाइज पढ़ रहे हो. टू डिफरेंट एग्जामिनेशन नेम बट एग्जाम बॉडी सेम. तो डेफिनेटली इट इज गोइंग टू बी दैट लेवल का पेपर. माइंडसेट समझिए एग्जामिनर का.
Dr. Ranjit is ready with the recalls. So
Done,
shall
sir.
yeah.
We'll give the stage to
some students were saying कि सर कब स्टार्ट होगा. देखिए अभी बच्चे आप लोग ही से हमको सवाल मिलने वाला है ना, या जो भी आपसे बातचीत होगी. तो जब हम लोग एग्जाम से सेंटर से निकले तो स्टूडेंट्स वर आल्सो लिटिल स्ट्रेस्ड और कुछ बच्चे हैप्पी थे. सो वंस दे स्टार्ट गिविंग अस सम इंफॉर्मेशन, देन ओनली द टीम विल बी मेकिंग इट एंड देन ओनली द टीचर्स विल बी कमिंग फॉर यू.
Ranjit sir is ready with few questions.
Ranjit sir is ready and we are going to start in just next 4 to 5 minutes. If you guys are ready, just start commenting on the recall session. और जहां पे भी लगे ये एरर है या इसमें कुछ करेक्शन चाहिए, feel free to message in there and enjoy your recall session. All the very best to all of you.
all the best, guys. Sleep well after this and then forget about until you get the results. Bye bye.
Bye guys.
See you again.
Dr. Ranjit, over to you.
Thank you, Santosh. Thank you, sir. Just give me a second, guys. Okay. Hey guys, am I audible and visible? If so, say me yes or no. Definitely, PG Live will give you a PDF of all the questions, answers exactly after we frame the appropriate questions after the discussion. Fine, we'll definitely share it all of you guys. Don't worry about it. So if I'm audible, if I'm visible, let's start. Perfect, great. Thank you guys. So I think pathology this time or part 1 paper this time itself was a little bit of googly. You had medicine questions, surgery questions in part 1, pediatrics, PSM also in part 1, right? So a little bit of less representation from pathology as it used to be in the previous FMG. The overall first thing is like, how many of you guys say that hemat was less? Definitely the question of hematology was a little bit less compared to last previous years of paper. They didn't give much emphasis on hematology. Little bit of emphasis came on systemic pathology with the help of scenario-based questions. So I'll be going with a few recollection of questions, whatever you guys said. If there is any error in the framing of the questions, in the options, do let me know. We'll correct it. And like NEET PG Live asked for, we'll definitely circulate a perfect answer with a question with 4 options PDF to you guys, fine? So this was the first question which came. Similar, because see, the age, the gender, everything, I've just added to make it a scenario-based question, that's all. It's a young child present with the OPD with the history of obesity. Which of the following genetic alteration will be in the patient? Was there any other inputs here? Was there any other inputs here? Or this should be more than enough for you to come to a conclusion. Child obesity with paternal maternal relations, everything. The diagnosis here is Prader-Willi syndrome, okay? So there's a Prader-Willi syndrome, it's a diagnosis. If there is any other extra inputs in the question stem, please put in the comment box. I'll definitely add on to it. Fine. Okay. Angelman was one of the options. Okay, great. We'll keep it as Angelman rather than having maternal deletion. I'll put it as an Angelman for sure. Okay. So the answer diagnosed here is Prader-Willi syndrome. If it's Prader-Willi syndrome, what will be the appropriate answer? Anyone? It is a simple diagnosis of Prader-Willi syndrome. Great. So Prader-Willi syndrome is going to have paternal deletion of chromosome 15, right? So Angelman syndrome will have deletion of the mother, and Prader-Willi syndrome will have deletion of the father, right? Or the paternal deletion. Just give me a second. Okay. Perfect. Great. Nice. Let's go to the next question. I hope this was a simple question. Okay, great. Nice. So was this a question? I'll come to it, Phoenix. I have that in the last, a little bit later, the 𝐒𝐿 thing. Okay, well, just the diagnosis, it has to be Prader-Willi syndrome. That's as simple as it. Okay, Navina. Fine. Okay. So 45-year-old person with a headache, operated and microscopic examination showed world appearance in some of my bodies. Was there any other findings or was it an image-based question? I don't think so. It was an image-based question. It is a simple question with a CNS tumor with some of my body, right? These were the clue points which students said that a CNS tumor with some of my body, obviously the diagnosis was simple. It is perfect. It is meningioma, right? Okay, the answer is meningioma. Was there an image-based question? Okay, if it's an histopathological image, I think you must have seen the old appearance in the some of my bodies there. Akshat, if you had a childhood obesity patient, the answer would be Prader-Willi syndrome, not an Angelman syndrome. Fine. Okay, great. Fine. Ewing's was not the answer. Okay, Ewing's is not the answer. Any of the CNS tumor is not the answer. If it's world appearance, some of my body CNS tumor, the answer is to be as simple as meningioma. That's all. Okay, perfect. Great. This also is right. This question was there. This student said that it was an image-based question, a breast mass with an image-based question. What was it? Okay, Ashdad, I'll definitely recollect it soon. It's a breast mass in a person, so-and-so age, microscopic appearance, had lots and lots of clear areas. All these clear areas are mucinous. Okay, so if it was a similar image, lots of mucin secreting areas are there, the answer is going to be mucinous tumor or a mucinous carcinoma of breast. Phyllodes will not have these amount of mucinous spaces. Phyllodes will have the leaf-like arrangement, and phyllodes will be a very huge, like 15-20 centimeter lesion in the breast. You think of phyllodes. Okay, if this was the image, is the mucinous carcinoma of breast. It's not the phyllodes. If you guys say phyllodes was the answer, I need more inputs from you, because phyllodes will have a leaf-like arrangement. Okay, fourth option was phyllodes. Fine. Leaf-like arrangement will be the phyllodes, and the size of the tumor will be very huge was the phyllodes. Fine. Okay, Akshat. If there is any other image which you feel like it was, how many of you say this mucinous carcinoma of breast? Because quite a few students said that it's mucinous carcinoma of breast. So I put a representative image there. If it had lots of empty spaces, clear spaces, it is mucin. It is mucinous carcinoma of breast. If it is a leaf-like arrangement, it's phyllodes tumor. Fine. Okay, 60-year-old. Great. We'll change that as well. Okay, so these are the possibilities. Leaf-like, it'll be phyllodes. Lots of empty spaces, it'll be mucinous carcinoma of breast. Okay, great. Okay, this question again, there are two versions here. This was a lesion in the medial canthus of the eye. Fine. Some of the students say that keratin pearls were there. Some of the students say that it showed peripheral palisading with nesting appearance. So I'll leave it to you. What was the exact thing? Was it keratin pearls, or these two are two different questions? Medial canthus of the eye, or in the nose, whatever area, the first thing, clinical possibility, nodular lesion is going to be in basal cell carcinoma. Fine. Nodular lesion, medial canthus of the eye, first possibility is basal carcinoma. If keratin pearls was there, then I would think of a squamous cell carcinoma. Okay. And if it's palisading, I'll think of a basal cell carcinoma. I've given you both the possibilities because, again, it's a mixed opinion which is coming from you guys, and it's very early now. So we are just collating more appropriate recalls from you guys. Fine. If it's a keratin pearl, histopathology answer is going to be squamous cell carcinoma. That's no doubt in that, right? If keratin pearl is there, it is thing. Fine. Okay, if the question was a pearly white lesion like what Nabin says, okay? See, if it's a pearly lesion or a pearly white lesion or a pearly nodular lesion, then I would still say microscopy, if it's palisading, the answer should be a basal cell carcinoma, because the pearly white lesion grossly could be basal cell or a squamous cell. Keratin pearls is different from pearly nodular lesion grossly. Fine. It is a two different thing. If it's pearly nodular clinically and microscopy is palisading, answer is basal cell carcinoma. If microscopy is keratin pearls, answer has to be squamous cell carcinoma, right? You are the right person to judge it. If microscopy had this word, the answer has to be a basal cell carcinoma, not a squamous cell carcinoma. Squamous cell carcinoma will not have peripheral palisading. Fine. Okay, just give me a second. Okay, great. Fine. Was this the right recall? Was this the appropriate question? There might be a few changes in the wordings. Ignore that alone. Which of the following is the timing of triphenyl tetrasodium chloride to elicit the diagnosis of MI? Pearly papule in forehead. If microscopy was palisading, I would still say it's basal cell carcinoma, not a squamous cell carcinoma. Fine. Okay. Triphenyl tetrasodium chloride is a gross finding. Okay. So I'll tell you what exactly it is. Options you guys have to give. Yes, obviously triphenyl tetrasodium chloride will have brick red color. That is not the concern. If the question had anything between 2-3 hours or above, this will be the answer. Because a gross staining of triphenyl tetrasodium chloride cannot be elicited before 2 to 3 hours. Because gross changes in the heart will not happen before 2 to 3 hours. Brick red color, gross examination of triphenyl tetrasodium chloride. If anything was there in that ballpark, that will be an appropriate answer. What was it? 2 to 3 hours will be the answer. If the answer was there, 2 to 3 hours, that should be the right answer. Rest of the options I've just added to make it sure. It will not be seen within 1 hour, within 30 minutes, it will not be seen. It should be a minimum of 2 to 3 hours time. Only then the gross staining of triphenyl tetrasodium chloride will elicit some findings. The brick red color, the finding will be seen later only, or the pale color finding will be seen later only. Fine. Okay. See, Nabin, if it's 3 to 6 hours, yes, I'll definitely see the finding. Anything after 2 to 3 hours, I will see finding. So it doesn't make sense for a person to give a 3 to 6 hours and 2 to 3 hours. If 2 to 3 hours is the answer, I would go 2 to 3 hours as the final answer. Fine. Okay, perfect. Great, Shubham. Fine. This question, was this the appropriate one? I don't know what is the fourth option. If you guys can fill me the fourth option, we can come to the answer. Which of the following changes are the changes in an irreversible cell injury? It's a very basic question from cell injury chapter. Bleb formation can be seen in reversible, right? Amorphous densities of mitochondria. If it was large amorphous densities, irreversible, small densities, reversible. So I'll put both irreversible and reversible here. It's based on if it's reversible, if it's a small flocculent densities. If they are large flocculent densities, it will be an irreversible thing. Fine. Clumping of chromatin with the nuclear change is almost always a finding of irreversible cell injury. If you had clumping of chromatin as the option, I would go with clumping of chromatin as the last answer. But I would still want option D. Can anyone pick up option D here? Amorphous densities, Vijayalakshmi is a very different thing. If you have to see if it's a reversible, small or large, based on that, it differs because amorphous can be seen in both, myelin figures can be seen in both, right? If these were the options, and if I'm not able to pick up the fourth option, I would say clumping of chromatin as a better finding for an irreversible cell injury. Okay, great, Jack. Okay. Next, a question on mitochondria. If you have carrier Dr. Beast, I would say karyolysis will be the best answer. Mitochondrial inheritance, was it a pedigree-based question or was it just a written one that most of the kids of the mom affected had the disease? Whatever it is, there's a question on mitochondrial inheritance, right? So mitochondrial inheritance, mom affected. If all the children are affected, it is mitochondrial inheritance. Okay, it is just written. Okay, fine. I think this is a very simple question. You might have not made any of the error there. See, if clumping was not there, and if something related to karyolysis was there, that will be an appropriate answer than your amorphous densities or myelin figure. Fine. Okay, great. 𝐶/MYC gene. What is the question regarding 𝐶/MYC gene? What's the question on which tumor it is involved? 𝐶/MYC is mutated in case of an Burkitt's lymphoma. If it is a simple one-liner question, the answer is as simple as Burkitt's lymphoma. Okay. If it was an NMYC, you could think of a neuroblastoma. 𝐶/MYC is for a Burkitt lymphoma. Was it just okay? 𝐶/MYC, it is present in chromosome 8. Okay. Fine. Let's not argue on which is present, which is not present. It's based on the recall. Like I'm giving the most appropriate answer for you. Clumping or nuclear changes will be a better answer for irreversible cell injury. Fine. Perfect. It's a one-liner. Okay. This, I want a little bit of more inputs from you because students said that histopathological finding of a thyroid cancer with pink eosinophilic cytoplasm. Was that the only thing? Any other information which could help us to come to a diagnosis? Follicular cells, pink eosinophilic cytoplasm, was there any other information to come to a conclusion? Because the answer is going to be based on what you guys are going to tell me. Okay, Nabil, got it. Thank you. See, if was the word orphan Annie in the question, like Dr. B says, if the word orphan Annie was in the question, my answer would be a simple papillary tumor. That's all. Okay. If orphan Annie was a simple papillary tumor. If the cytoplasm was pink eosinophilic color, still I can go for a simple papillary tumor. Papillary tumors also will have eosinophilic cytoplasm only. But if the question was implying that there was an eosinophilic material outside, which is equating to amyloid. Okay, if it's an eosinophilic material in the background, then it's equating to amyloid. If that was the word of the question, then I would go for medullary carcinoma of thyroid. I'll ignore this. If orphan Annie is not there, it's gone. Extracellular eosinophilic material, undoubtedly the answer should be medullary carcinoma of thyroid. Eosinophilic cytoplasm or orphan Annie, I'll go for papillary. Fine. If these two were there, they were extracellular eosinophilic material, then I would say the answer would be in medullary carcinoma thyroid, because extracellular eosinophilic material means amyloid, and only thyroid cancer which will have amyloid is medullary carcinoma thyroid, right? So we'll fix on medullary carcinoma thyroid because most of you guys say that will be a most appropriate one. Extracellular outside was there and has to be medullary carcinoma thyroid, not a papillary carcinoma. If orphan is not there, I would not think of a papillary carcinoma thyroid. Fine. Okay. Few more questions. Can anyone tell what is the question on von Willebrand factor? I was just told that there's a question on von Willebrand factor, and one student said that it is not von Willebrand factor, it was on GP1B9. Can anyone recollect the question which came on von Willebrand factor? Was it a diagnosis question? Was it just asking the inheritance? Okay, von Willebrand binds to. Perfect. If the question was von Willebrand binding to, the answer is simple, GP1B9, right? Glycoprotein 1B9 is something which von Willebrand factor will bind to. That's a very straightforward, simple one-liner question. I don't think so. This might be this is the only representation which has come from hematology, unfortunately, this time. Fine. It binds to glycoprotein 1B9, which is the initial step of addition for the clot formation cascade. Fine. Okay. So though this question is understood, Akshat, we'll take the nodular mass, slow nodular mass, next center mass, everything. We'll definitely add on to the recall which we give finally. This was one of the microscopic finding. There were two histological images. One histological image was of an elastic or an hyaline cartilage. I'll leave Dr. Pradeep to talk about it. Second was an lymphoid structure with an overlying epithelium. If it's an overlying epithelium and if it's something of a lymphoid structure, I would think of an tonsil. Because students said it was a tonsils microscopic image. Exact image, you're not able to source it as early as now. We'll definitely get the exact image soon in the PDF recall. So if it is in tonsil, you'll have the microscopic, all these nodules of lymphoid tissue and overlying epithelium will be there. That is the easiest way to identify tonsil. If it is thymus, okay? If it is thymus, you will have a structure called as Hassel's corpuscles. You will have still the nodules of lymphoid tissue, and you might have also had a pink structure like this of an Hassel's corpuscles. If you have seen Hassel's corpuscles, it will be a thymus. Only nodular structure with an overlying epithelium, it has to be a tonsil. Fine. Okay, spleen. I'll add to what Anna said. If spleen was there, the only way to identify spleen is we will have the lymphoid architecture here. These are the lymphoid structures, which is common for all. Spleen will have center blood vessel. If the center vessel in the center of the B lymphoid tissue, nodular tissue, then I'll go for spleen, right? Spleen in the center will have a blood vessel, Hassel's corpuscles for thymus, overlying epithelium for tonsil, right? Whatever came in your exam, that will be an appropriate answer, fine? Lymph node will have nothing of these. We'll have only the overlying capsule and you'll have all the lymphoid architecture. In between, you have the parafollicular areas as well, fine? If there is a center blood vessel, undoubtedly it is spleen. No other lymphoid tissue will have center blood vessel, fine? Okay, great, fine. Few more questions. I don't know what is the question on pheochromocytoma because students couldn't get anything apart from what is on pheochromocytoma. And then this was also a question. A raised alpha fetoprotein is seen in which of the following? We had few options because there's a little bit of confusion in the options. So I want more refined answer with you. Yolk sac tumor was one of the option. Hepatoma was one of the option, right? Because if it's an alpha fetoprotein, it will be elevated in both of them. Hepatoma is the older name for hepatocellular carcinoma. It's not an hepatic adenoma. Hepatocellular carcinoma's older name was hepatoma. Yolk sac tumor, non-seminomatous germ cell tumor was also, you'll have elevated alpha fetoprotein. If both the options were there, the question would have been, which of the following is elevated? All except question, right? If it's not, I would still prefer hepatocellular carcinoma because an alpha fetoprotein of more than 1000, the first diagnosis has to be in hepatocellular carcinoma. Fine. Okay. Okay, lung cancer, it will not get elevated. We'll ignore lung cancer. Lung cancer is an odd man out here. We'll ignore that. Fine. But both hepatocellular carcinoma, hepatoma, or an 𝐒𝐿-𝐶 tumor will have an elevated alpha fetoprotein. Fine. Okay. 𝐒𝐿-𝐶 tumor is not the option. The answer is very simple and straightforward. The answer is to be hepatoma check. Fine. Thank you for that. So this was also one question. Micrognathia, microcephaly in the clinical scenario. What is the genetic change? See, if it's a microcephaly, micrognathia, they are pointing towards your Pateau syndrome, your Down syndrome, in those categories, right? So most likely it should be a chromosomal disorder, or it could be a chromosomal aneuploidy. If you can give me more extra information on this, I'll definitely take care of it. Okay, microcephaly and sensory neural hearing loss. Then I would leave it to the pediatrician to come to a syndrome, because if it's microcephaly, sensory neural hearing loss, micrognathia, most likely it's like it looking like an Edward Pateau. I'd go for chromosomal disorder or an aneuploidy as the diagnostic thing. Fine. Okay, there's no question of pheochromocytoma. Great, we'll strike it off. Fine. So these are few questions which you have recollected from pathology. I'll just quickly go through it. I've taken your inputs. We'll definitely give and refined with more for appropriate answers, and we'll go for it. Prader-Willi diagnosis, a simple, straightforward one. Meningioma with a microscopic submember body appearance. This is a confusion between a clear appearance and a sarcomatous change of an Phyllos tumor. I'll put both the options. We'll leave it to you. Okay. And pearly nodular clinical peripheral palisading has to be a basal cell carcinoma. I think students have confused the pearly nodule with keratin pearls. Fine. Okay. Here, brick red gross 2 to 3 hours will be for triphenate tetrasodium chloride, and clumping of chromatin or any nuclear event will be the answer. Amorphous density is not the answer, because amorphous density can be seen in both. It's a clear-cut one-liner question where you have mitochondrial inheritance, Burkitt's lymphoma for 𝐒𝐿-MYC, and extracellular eosinophilic material in a thyroid tumor has to be a medullary carcinoma thyroid, and one Wilbur factor binds to GP1B9. Most of you said for this lymphoid structure with a central vessel has to be a spleen. Fine. And hepatoma for your alpha fetoprotein, and microcephaly with more information will come to a right answer. Fine. Okay. Okay, Nabin, then the answer would be in hepatocellular carcinoma and hepatoma. Fine. So that's all with pathology. I think the next person is online, and we will start the recall of the next subject. Izaz, I think your surgery questions, Dr. Sandeep will definitely come and discuss about it. Over to you, sir.
Thank you, Ranjit sir. So hello students, कैसे था anatomy? काफी कम questions आए मैंने सुना. Am I audible?
Yes, sir. Yes, sir.
हाँ, yeah. So काफी कम questions आए, integrated questions थे. But ठीक है, whatever that we have got from the recall, I've put it on the slide. Let us discuss. अगर कुछ उसमें additions है, तो you can always put it in front of me. Okay? Chalo, we'll start with the MCQs. Yeah, this was the question. Identify the type of cartilage. Clear, students? What do you think is this? Yahi tha na? Identify the type of cartilage. You can see large chondrocytes, right? Bade chondrocytes dikh rahe. Perichondrium is seen. Large chondrocytes, single large chondrocytes. If the chondrocytes are in a group, then that becomes a hyaline cartilage with perichondrium, of course. Yeah. So this is perichondrium present, large chondrocytes, single large chondrocytes. So what do you think is this? This is an elastic cartilage. And yes, you get fibers here. You can see this fibers here with a special stain there. These are the elastic fibers, right? So this is an elastic cartilage. Elastic hai bacha, ye hyaline nahi hai. This is an elastic cartilage. Large chondrocytes. Had this been an hyaline cartilage, you would see chondrocytes in a group, cell, nest. And the matrix would be amorphous, glass-like appearance, right? So this is more of elastic cartilage. Fine? Okay. So ये MCQ था. 4th and 5th digit, was it with respect to claw hand of 4th and 5th digits? So which muscles are involved in this claw hand of 4th and 5th digits? The lumbricals, the last two lumbricals are involved. So you get a claw hand of the last two digits. Or was it the skin over the 4th and 5th digit is supplied by what? So that would be the superficial branch of ulnar nerve. राइट? क्लॉ हैंड था ना? यस, वेरी गुड, क्लॉ हैंड था, यस, इलास्टिक कार्टिलेज था, क्लॉ हैंड था। वेरी गुड. So last two lumbricals, number 3 and 4, is supplied by the ulnar nerve. First two lumbricals are supplied by median nerve. So paralysis of lumbricals lead to claw hand of the last two digits. Very good, very good. Okay, so that was claw hand. हाँ, claw hand. Claw hand का एक ulnar nerve injury था. Okay, एक palatine tonsil का slide था. And what does the palatine tonsil rest upon? What is this fascia on which the palatine tonsil is resting? Any guesses? क्या लिखा है बच्चों? एनाटॉमी तो कब आया कब गया पता ही नहीं चला. ओके, इतना कम था एनाटॉमी. बट ठीक है, जो भी था वो इंपॉर्टेंट था. सो दिस टॉन्सिल इज लाइंग ऑन व्हाट? दिस टॉन्सिल इज लाइंग ऑन द फेरिंगोबेसिलर फेशिया. फेरिंगोबेसिलर फेशिया, बराबर है. तो ये पहला होगा फेरिंगो, ये पेरिटॉन्सिलर वेन आ गई, तो दैट्स द फेरिंगोबेसिलर फेशिया. फिर ये आएगा मसल. व्हाट इज दिस मसल? दैट्स द सुपीरियर कंस्ट्रिक्टर मसल. एंड फिर बाहर की तरफ आएगा बक्कोफेरेंजियल फेशिया. बक्कोफेरेंजियल फेशिया, राइट? सो द टॉन्सिल इज लाइंग ऑन व्हाट? द फेरिंगोबेसिलर फेशिया. फेरिंगोबेसिलर फेशिया, एग्जैक्टली एग्जैक्टली. फिफ्थ डिजिट का स्किन भी होगा तो अल्ना नर्व ही है बच्चे, राइट डॉक्टर? इवन इफ इट इज फिफ्थ डिजिट का फिंगर का नर्व सप्लाई तो भी अल्ना नर्व है, क्लॉ हैंड है तो भी अल्ना नर्व है. सो इट वाज अल्ना नर्व. ठीक है, ओके, वेरी गुड. Yes, so that's about the tonsil which is lying on the pharyngobasilar fascia. This was the third question. Something about the bulbar urethra tha. Bulbar urethra. Tip of the fourth and fifth fingers are supplied by, again, superficial branch of ulnar nerve hai, bacha. Dr. Phoenix, it's superficial branch of ulnar nerve, right? Something about the bulbar urethra. We know prostatic urethra, that's in the prostate, 4 centimeters long. The second one is membranous urethra, which lies in the deep perineal pouch, that's 1.5 to 2 centimeters. And then comes the penile urethra, 15 to 20 centimeters. The dilatation of the penile urethra is known as the bulbar urethra. अगर rupture होता है bulbar urethra का तो urine is collected where? हाँ, yes. Bolo, if there's a rupture of bulbar urethra, the urine will be collected in the superficial perineal pouch. Superficial perineal pouch. Agar membranous urethra ka rupture hai, so the urine will be collected in the deep perineal pouch. Deep perineal pouch. Where does hematoma come from? Perineal bleeding stored. Injury to bulbar urethra. Yes, injury to bulbar urethra will cause extravasation of urine in the superficial perineal pouch. Abhi question was with what respect? I've not yet got that, but yes, it would be that. Falling from a height, bulbar urethra is ruptured. Yes, agar bulbar urethra ruptured hota hai, to superficial perineal pouch mein extravasation of urine hoga. And the urine will collect in the scrotum, the penis, and it will go in the anterior abdominal wall in that space which is known as superficial inguinal space. The urine will also try to go down in the thigh, but ek line hota hai, that's the Holden's line. Abhi, with what was this MCQ asked? I've told you everything, the relevance of it, so you can understand it. ठीक है? Okay, falling from a height था ना? ठीक है, that's bulbar urethra. Fine बच्चों, ये था सवाल. Was this the question? अभी रंजित सर ने बोला ना, ये lymphoid tissue without any lymphoid follicles. What's that? Thymus. Was thymus there as one of the options? Thymus था बच्चों. Thymus में क्या होता है? Thymic lobules होता है, capsule होता है. Capsule से you get septa here. These are the septa. And this septa will divide the thymus into lobules. Thymic lobules. हर एक lobule का अपना बाहर cortex होता है, अंदर medulla होता है. And in the medulla you get these structures. What are these structures? Hassel's corpuscles. Hassel's corpuscles. ठीक है शुभम, हाँ एक मिनट. So Hassel's corpuscles are characteristic of hyaline cartilage. अगर lymphoid follicles are absent, so it is thymus. How do we confirm this thymus? Because of Hassel's corpuscles. अगर lymphoid follicles दिख रहे थे आपको in that slide, so it would be either spleen, lymph node or tonsil, which just रंजित सर ने बोला. तो tonsils आपको crypts मिलेंगे, crypts and stratified squamous non-keratinized epithelium, oral epithelium. If it is a lymph node, you get a capsule, and just below the capsule is a space, that's the subcapsular sinus, correct? And agar wo kya bacha hai, spleen hai to red and white pulp, and you get an artery within the white pulp, right? So this is thymus, correct hai na? So cortex, medulla, thymic lobules hai, bahut sare aise lobules hote hai, thymic lobules. हर एक lobule का अपना बाहर cortex होता है, अंदर medulla होता है, and in the medulla we get Hassel's corpuscles. Hassel's corpuscles. स्प्लीन था विथ सेंट्रल ब्लड वेसल. हाँ, तो जो भी है अभी ट्राई टू कोरिलेटेड हमने बोल दिया आपको, ठीक है? क्रेनियोरेचाइसिस, बट इंस्टेड ऑफ दैट दे गिव न्यूरल ट्यूब डिफेक्ट. यस, एस्प्लीन. So neural tube defect, you know neural tube, पहले neural tube is open, ectoderm से form होता है वो neural tube is open at the head end and the tail end. The anterior open end को क्या बोलते हो? Yes, the cranial neuropore. The posterior open end को क्या बोलते हो आप? The caudal neuropore. The cranial neuropore closes by 25th day, caudal by 28th day. अगर ये close नहीं हुआ तो anencephaly, अगर caudal close नहीं हुआ तो spina bifida. So if the entire neural tube doesn't close, so you get this craniorachitis. ठीक है, meningomyelocele. Little finger nerve supply वही है बच्चा, ulnar nerve ही है. That's ulnar nerve. Little finger का nerve supply is ulnar. फिर एक क्वेश्चन था pouch of Douglas पे. I got this at the last moment. Pouch of Douglas पे कुछ क्वेश्चन था बच्चों. The recto-uterine pouch, that's the pouch of Douglas, and this is the most dependent part of the body in standing position in females. That's the pouch of Douglas, the recto-uterine pouch. कुछ क्वेश्चन था इस पे, recto-uterine pouch पे, superficial and infragastric. बोलो बच्चों. Pouch of Douglas, the recto-uterine pouch, that's the most dependent part of the body in standing position in females. And in supine position क्या है? Hepatorenal pouch of Morrison's pouch. ठीक है. और एक सवाल था cerebellum. दोनों खुले थे. Okay, fine. एक cerebellum का slide था. I just got this at the last moment, so I couldn't incorporate it in my slide. So cerebellum का histology का slide था जिसमें आपको दिखता है outer मॉलिक्यूलर लेयर, बीच में ऐसे फ्लैश शेप्ड सेल्स दिखते हैं, पर्कंजी सेल लेयर, एंड इनर होता है मॉलिक्यूलर, इनर होता है ग्रैन्युलर लेयर. सो आउटर मॉलिक्यूलर, बीच में पर्कंजी सेल लेयर, एंड इनर इज द ग्रैन्युलर लेयर. अगर ये तीन लेयर्स आपने देखे हैं, यू सीन फ्लैश शेप्ड पर्कंजी सेल्स इन द पर्कंजी लेयर, दिस वुड बी द स्लाइड ऑफ सेरेबेलम. सेरेबेलम. अच्छा, वेरी गुड. सिर्फ नेम करना था पाउच ऑफ डगलस. ओके, वेरी गुड, वेरी गुड, वेरी गुड. मेल था, क्या बोल रहे हो? मेल था. मेल था तो रेक्टो यूट्राइन पाउच होगा, फीमेल है तो पाउच ऑफ डगलस होगा. टेरिस मेजर सुप्रास्पाइनेटिस, ये क्या है? टेरिस मेजर, विघ्नेश, टेरिस मेजर और सुप्रास्पाइनेटिस के बारे में क्या था? एनीथिंग अबाउट दैट? टेरिस मेजर सुप्रास्पाइनेटिस क्या नर्व सप्लाई था या और कुछ था उसका? एनीथिंग एल्स वाज देयर? तो दिस आर द क्वेश्चंस बच्चों. ये हम ओनली सुपरफिशियल रिकॉल कर रहे हैं. डिटेल्ड सॉफ्ट कॉपी ऑफ एफएमजी बुकलेट विथ प्रॉपर क्वेश्चंस, options and correct answer will be made available to you in some days, in the coming days. Okay, so ये superficial recall है, जो भी हमको मिला है options, उससे we have done this. Okay, Morrison's pouch, that is hepatorenal pouch of Morrison, that's the most dependent part of the body in supine position. मेल का पिक था तो वो रेक्टो यूट्राइन पाउच नहीं होगा ना, रेक्टो वेसाइकल पाउच होगा. अगर मेल का पिक्चर है तो इट इज रेक्टो वेसाइकल पाउच. फीमेल्स है तो द डीपेस्ट इज पाउच ऑफ डगलस. लैटरल बॉर्डर ऑफ ब्रेस्ट, ब्रेस्ट सर्जरी का लैटरल बॉर्डर कौन सा मसल? लैटरल बॉर्डर पेक्टोरलिस मेजर है वो, पेक्टोरलिस मेजर, या सेराटस एंटीरियर होगा. मोर लैटरल इज सेराटस एंटीरियर. ठीक है. ओके, आई होप दिस आर द क्वेश्चंस दैट आई हैव गॉट फॉर रिकॉल. Will definitely come with a booklet for you. Okay, thank you my dear students, thank you to all of you, thank you. Who's the next one? The next faculty, please. Tingling sensations or index finger, middle finger and third finger, तो वो median nerve है बच्चे. Sumukhi, tingling and numbness on middle finger, index finger, third finger, that is median nerve, that is Tinel sign. हाँ, median nerve है वो, median nerve. Median nerve. ठीक है, fine. The next faculty, please join in. I'm done with my questions. Hi, Dr. Mamta. Hello.
Thanks, sir.
You can please join in. Thank you, my dear children. Thank you. Mamta, you can start. I'll stop.
Hi, everyone. Good evening. Good evening, everyone. So microbiology was pretty easy, touch wood. Although I have not been able to gather all the options of all the questions, but today's paper again is a testimony to the fact that you need to do all the PYTs very, very well. So let me start with the first question, and a humble request to all the students watching this video to please help me out with the options, which, as I said, I have not been able to get for quite a few questions. So guys, I was told there was a question on treatment of cryptococcus. And probably there was one more question on cryptococcus. Is it so? Please help me out with this question. Was this a question? If yes, can anyone please recall the options? All right. Fluconazole and amphotericin B were in the same option. Iraz? Anyways, so this topic was there. Cryptococcus treatment was asked. Okay, I think this probably was a separate option, amphotericin B, or in the same option only. So you all know cryptococcus treatment without CNS involvement. Without CNS involvement is fluconazole. Okay? And in HIV infected individuals with CNS involvement, it's the most common cause of meningitis in immunocompromised population. That is the HIV patients who have progressed to develop AIDS. So in this case, in HIV infected people with CNS involvement, a 2-week treatment of an induction phase is there for 2 weeks with amphotericin B and flucytosine, and then it is followed by the oral fluconazole therapy till the CD4 count rises to more than 200 per microliter for 6 months. So this question was simple. Okay, flucytosine. I think the second option was flucytosine, as quite a few of you are mentioning, and amphotericin B. So one option was fluconazole plus amphotericin B, and the second one was flucytosine plus amphotericin B. Were these the two options? Flucytosine and amphotericin B were together. Okay, then one option was amphotericin B alone. What about fluconazole? Was it given in combination with amphotericin B, or was it a third option? Anyone, if can please help with this question. Fluconazole was not separate. So I think whatever I wrote previously was right only. Okay. What about third and fourth options, anyone? So one option was fluconazole plus amphotericin B. Second option was flucytosine plus amphotericin B. Third and fourth options? Anyone? All right. Third option was amphotericin B alone. Alone. ठीक है. Last option. चलो कोई नहीं. So यहाँ पे अकेले फ्लूकोनाजोल तो दे नहीं रखा था, तो हमारा आंसर फिर क्या बनेगा यहाँ पे? एम्फोटेरिसिन बी प्लस फ्लूसाइटोसिन. चलो फिर आगे बढ़ते हैं. नेक्स्ट क्वेश्चन वाज अगेन ऑन फूड पॉइजनिंग. क्वेश्चन आया था एक फूड पॉइजनिंग पर. अ पेशेंट कंज्यूम्ड फ्राइड राइस एंड प्रेजेंटेड विद वॉमिटिंग आफ्टर 6 hours. Food poisoning के questions I always say are very, very scoring. You just need to know the symptoms, what the patient ate, and the incubation period. ठीक है. तो Bacillus cereus, Shigella dysentery, Escherichia coli, Clostridium botulinum. सीधा सीधा आंसर है क्या? Bacillus cereus, जो 2 तरह की फूड पॉइजनिंग कॉज करता है, एमिटेड टाइप एंड डायरियल टाइप. ठीक है. एमिटेड टाइप में द इंक्यूबेशन पीरियड इज इन द रेंज ऑफ 1 to 6 hours. डिसेंट्री एनीवेज क्या करेगा? Dysentery cause करता है. Most severe shigellosis is by dysentery. E. coli, there are different diarrheogenic E. coli, you all know. Then Clostridium botulinum तो खैर बिल्कुल भी नहीं है. So यहाँ पे आंसर क्या है? Bacillus cereus. ठीक है. Again a very important PYT. चलो आगे बढ़ते हैं. Causative agent of prosthetic valve endocarditis. I was told that this was a one-liner, and these were the options which I got from the students. Staph aureus, Staph epidermidis, and viridans. D last option किसी को याद है? Okay, Jack is commenting incubation period is 2 hours. Are you sure? Now, if anyone can please recall the fourth option in this next question, prosthetic valve endocarditis पे जो था. So, see, prosthetic valve endocarditis occurring after cardiac valve replacement. तो ये दो तरह से हम classify कर सकते हैं, early और late. Early occurring within 12 months of the valve replacement, और ये generally nosocomial होता है, and results from some intraoperative contamination of the prosthesis या फिर कुछ post-op bacteremic complication की वजह से ये होता है. तो early में क्या options, क्या causative agents है? Cons and staph aureus are the most common agents. और लेट जो कि कम्युनिटी अक्वायर्ड होता है, दैट इज कॉज्ड बाय विरिडेंस यूजुअली. एंड ओवरऑल अगर बात करें, ओवरऑल कॉज ऑफ प्रोस्थेटिक वेल्व एंडोकार्डाइटिस रिगार्डलेस ऑफ द टाइम ऑफ ऑनसेट आफ्टर द सर्जरी, कॉन्स इज द मोस्ट कॉमन कॉज. सो कीपिंग दैट इन माइंड, आवर आंसर इज गोइंग टू बी स्टैफ एपिडर्मिडिस. किसी को याद आ रहा है लास्ट ऑप्शन इस क्वेश्चन में? ऑल राइट, एंट्रोकोकस वाज द फोर्थ ऑप्शन. So our answer is staph epidermidis. ठीक है, चलो next question. Question on toxoplasma gondii was asked or was not asked, if you can please tell me, because I've been repeatedly asking this. Two students had commented, had told me that this was asked, but they were not really able to recall the question. If any of you can please help me with this question. Was this question asked? If yes, what was it? What was asked? ओके, भरत, कैन यू प्लीज रिकॉल क्या एग्जैक्टली इसमें पूछा था टॉक्सोप्लाज्मा के बारे में? शुभम, एक ही क्या था? ओके, इंट्रासेरेब्रल कैल्सिफिकेशन. दिस वाज मेंशन्ड इन द क्वेश्चन. What else? Chalo, please try to recall this and I'll come back to this in case any of you is able to recall the keywords. Then I think एक क्वेश्चन कुछ acute meningitis की मैनेजमेंट पे भी आया था. This probably will be discussed in medicine. ठीक है, बट ये क्वेश्चन आया था meningitis पे. probably दो questions थे. Am I right? One was this, asking the management, and this was one of the options, ceftriaxone and vancomycin. Can anyone recall other options in this question and the stem of the question? All right, ceftriaxone plus acyclovir. Okay, this was given 80% neutrophils and decreased sugar. Okay, so these are all the buzzwords for toxoplasmosis. They had asked you about the organism. So these were the features in some patient, and what was the organism? Was this the question on toxoplasma? All right, तो यहाँ पे rifampicin plus something. Chalo, anyways, answer is ceftriaxone and vancomycin. So you should be familiar with this topic also. And another question was there where it was given that the patient presented with some lesions after rose thorn injury. The organism is found to spread through lymphatics. And this was mentioned in the question, I was told. ये lymphatics वाला sentence. तो ये था तो sporotrichosis. और options याद आ रहे हैं किसी को इस question के? Not just the options, अगर question में भी कोई help कर पाए तो. All right, rose thorn was definitely mentioned. और क्या ऑप्शंस थे इस वाले क्वेश्चन में स्पोरोट्राइकोसिस में? अगेन देखो, बहुत इंपॉर्टेंट टॉपिक है. माइकोलॉजी वैसे ही बहुत स्कोरिंग है, छोटी सी है, तो इसको बिल्कुल भी नहीं छोड़ना चाहिए. ओके शुभम, और ऑप्शंस किसी को याद आ रहे हैं? प्लीज ट्राई टू रिकॉल ये वाले ऑप्शन स्पोरोथ्रिक्स वाले क्वेश्चन में. अच्छा, रूमेटिक हार्ट डिजीज पे क्या आया था कुछ या नहीं आया था? Please try to recall this one also. I just got to know some question was there on rheumatic heart disease, but क्या पूछा था, क्या options? ये भी जरा please try to recall. And there was some question on culture media, and I'm not sure if there were 1 or 2 questions. Was it an image based or not? Because as far as this question which I have put up, as far as this question is concerned, the question mentioned that some green pigment was seen on some culture media, and then options में pseudomonas दे रखा था, or options I could not gather. So please clarify if there were 2 questions on culture media or not. If yes, was one image based, other one was not. ऐसा कुछ था क्या? Okay, it was image based. साई सूर्या फायर फाइटर स्मोक इनहेलेशन, ये आप इसी क्वेश्चन की प्रोबेबली बात कर रहे हो. सो कल्चर मीडिया से 2 क्वेश्चंस केम, राइट? सुमुखी, लीनियर लीजन्स, आर यू टॉकिंग अबाउट स्पोरोट्राइकोसिस? Gram negative, oxidase positive, it was mentioned in the question. All right, so going more in favor of pseudomonas, gram negative, oxidase positive, producing green pigment. All right, Klebsiella pneumoniae was another option kya? In this question only. स्ट्रेप्टोकोकस एक एलेक्शिये, शुभम आप किस क्वेश्चन की बात कर रहे हो? All right, E. coli was one option. तो देखो, पिगमेंटेड बैक्टीरिया, स्यूडोमोनास नहीं भूलना है, सेरेशिया नहीं भूलना है, स्टाफ ऑरियस नहीं भूलना है. कोई फंगस प्रोड्यूस करता है पिगमेंट? पेनिसिलियम मार्निफाई भी प्रोड्यूस करता है. ठीक है, तो देखो सिंपल क्वेश्चंस पूछ रहे हैं. कल्चर मीडिया अगेन वन ऑफ द वेरी बेसिक टॉपिक्स. इफ एनीवन कैन प्लीज रिकॉल द 4th ऑप्शन आल्सो. ओके, फायर फाइटर. ओके, फायर फाइटर मैन के बारे में और क्या मेंशन था? Okay, if anyone can please recall more on this. And अच्छा, विडाल टेस्ट की सिग्निफिकेंस पे कोई क्वेश्चन आया है क्या आज? If anyone can please help me out with this question also. Again देखो, विडाल even though not recommended by WHO, फिर भी देखो एंट्रेंस में अभी भी पूछ रहे हैं ये. ठीक है, the gold standard for diagnosis of entry fever is blood culture. तो there are still some topics being asked जो शायद उतने अच्छे टेस्ट तो नहीं है, बट उन पे क्वेश्चंस आ रहे हैं, तो आपको इसके फंडे विडाल की भी क्लियर होने चाहिए एकदम. Some titer was given in as one of the options. I'm not very sure. That's why I've not written it. Anjali, are you saying yes to the Vidal wala question? So question तो आया था, कुछ लोग आप में से कुछ कह रहे हैं, like Medico is commenting O and H. ऐसा कुछ तो, कुछ ये वेग सी चीज है, इसका कुछ मैं ऑप्शन क्या ही फ्रेम करूं. इफ any of you can please recall these options in the previous questions, please get in touch with me. Either you comment in this video in the comment section of this video only, or you can DM me on Instagram. ठीक है? All right. अच्छा, HBV की सेरोलॉजी पे क्वेश्चन आया हुआ है. ये भी बिल्कुल भी आश्चर्य की बात नहीं है, बहुत इंपॉर्टेंट टॉपिक है HBV की सेरोलॉजी. एक तो शायद यही आया था कि IgM एंटी HBC इज एसोसिएटेड विद व्हाट. 2 ऑप्शंस इस प्रकार से थे, एक्यूट इन्फेक्शन, क्रॉनिक इन्फेक्शन. C और D मुझे नहीं पता चले. तो अगर यही था क्वेश्चन में, यही लिख रखा था IgM एंटी HBC, तो ये क्या है? एक्यूट इन्फेक्शन. विशाल, साल्मोनेला या टाइफॉइड वाला ऑप्शन आप किसके लिए कह रहे हो? Yes, Medico, even I got to know कि 2 questions were there on hepatitis. दूसरा शायद ऐसा कुछ था, a patient sample is positive for IgG anti-HBC, ये था क्या? चलो, थैंक गॉड, एक क्वेश्चन तो ये बराबर से मिल गया हमारे को. तो ये तो सिंपल क्वेश्चन है. दूसरा वाला जो HBV सेरोलॉजी पे आया, क्या वो ऐसा कुछ था? a patient serum sample is positive for IgG anti-HBC. अच्छा, HbE पॉजिटिव भी मेंशन था पहले वाले क्वेश्चन में। HbE ऑल्सो वॉज पॉजिटिव, तो मतलब हाई इन्फेक्टिविटी। जैक, ऑप्शंस टाइफी पैराटाइफी वाले जो आप कह रहे हो विडाल टेस्ट के लिए आप कह रहे हो। अच्छा, तो इस वाले क्वेश्चन में आईजी में एंटी एचबीसी में HbE पॉजिटिव ये भी मेंशन करा हुआ था, ठीक है। तो एनीवेज हमारा आंसर एक्यूट इन्फेक्शन ही बनेगा इस वाले क्वेश्चन में, विच यू आर सीइंग राइट नाउ ऑन द स्क्रीन। इसमें और क्या दिया हुआ था? अ पेशेंट सीरम सैंपल इज पॉजिटिव फॉर IgG एंटी एचबीसी, और कुछ था और इसके ऑप्शंस? मेडिको विडाल टेस्ट, विडाल के मतलब अगर फंडे क्लियर है ना तो आई एम श्योर आंसर हो ही जाएगा, बट प्लीज हेल्प मी आउट विद द क्वेश्चन, ठीक है, तब मैं उस आपकी और सहायता कर पाऊं। तो HbS एंटीजन कृष्णा, किस किस क्वेश्चन की बात कर रहे हैं आप, इस वाले की? HbS एंटीजन पॉजिटिव इस वाले में दे रखा था 11वें क्वेश्चन में। अगेन देखो, अगर फंडे क्लियर है सेरोलॉजी के तो चाहे कुछ भी लिखा हो तो क्वेश्चन बन जाना चाहिए, आंसर आ जाना चाहिए। सो जो सेकंड क्वेश्चन था उसमें ये क्वेश्चन क्वेश्चन इस प्रकार से था कि हाई इन्फेक्टिविटी इज इंडिकेटेड बाय विच मार्कर, एम आई राइट? हाई इन्फेक्टिविटी इज इंडिकेटेड बाय, तो एक ऑप्शन एंटी HbS एंड एंटी HbC, इज इट सो? चलो ठीक है, ये तो क्वेश्चन हमारा बन गया, हाई इन्फेक्टिविटी पूछा तो उसमें से एक ऑप्शन था एंटी HbS एंटी HbC पॉजिटिव, एंड HbE मेंशन था क्या किसी ऑप्शन में? HbS एंटीजन पॉजिटिव प्लस HbE पॉजिटिव, अगर ये दोनों ही एंटीजन पॉजिटिव हैं इंडिकेटर फॉर हाई इन्फेक्टिविटी अगर पूछा और अगर एक ऑप्शन ऐसे दे रखा है HbS प्लस HbE, तो यही आंसर है। क्या अलग से भी कुछ ऐसे था, HbS अलग उसमें दे रखा हो और HbE अलग से दे रखा हो? एक ऑप्शन चलो IgG एंटी HbC, अच्छा दैट मींस जो मैंने क्वेश्चन में लिख रखा था IgG एंटी HbC वो वन ऑफ द ऑप्शंस था ना, तो ये तो खैर आंसर नहीं है। खादिम एंड नैंसी, यू आर सेइंग नो टू व्हाट, क्या नहीं था? हैव आई रिटन द करेक्ट ऑप्शंस ऑन द स्क्रीन ABCD? पहले चलो एक एक करके चलते हैं। पहले ऑप्शन में एंटीबॉडीज थी क्या दोनों के दोनों एंटीजेंस के अगेंस्ट, एंटी HbS एंटी HbC, ऐसे था कुछ? Was one option like this, second option HbE alone given as an option, yes or no? एंटी एंटीबॉडी अलोन, शुभम आप किसके बारे में स्पेसिफिकली कह रहे हो? एंटी HbE आर यू गाइज मेंशनिंग एंटी HbE? अगर ऐसे ही दे रखा था, अगर यही ऑप्शन थे जो आप स्क्रीन पे अभी देख रहे हो, तो फिर आंसर हमारा C बनेगा, HbS प्लस HbE। इज दिस करेक्ट? इज दिस आर ऑल दीज ऑप्शंस करेक्ट? करेक्ट मी इफ आई एम रॉन्ग। ओके अयान, यू आर सेइंग HbS प्लस HbE, ये ऑप्शन पक्का दे रखा था, ठीक है। D तो बिल्कुल ही नहीं बनता है, और एंटी HbE तो बल्कि इंडिकेट करती है लो इन्फेक्टिविटी, ये भी हट गया, तो पहला ऑप्शन भी हट गया, ठीक है। तो ये तो भाई सिंपल है, HbS प्लस HbE अगर ये ऑप्शन में दे रखा था। मोस्ट इंपॉर्टेंट मार्कर फॉर इन्फेक्टिविटी बाय द वे इज HbE ओनली, ठीक है। तो दो क्वेश्चन देखो, HBE, IgM was first. That means anti-HBE, this was IgM. Okay, Khadim, you are saying one option was anti-HBS antibody plus IgM antibody against HBE. Am I right? तो मैंने अपना ऑप्शन अब ए वाला चेंज कर लिया है, तो वो तो फिर बिल्कुल ही हट गया, मतलब ये आंसर नहीं है, ठीक है ना? All right, so 2 questions on serology, HPV serology I got. ठीक है, एक विडाल पे आया था. If anyone again, as I'm saying, अगर किसी को याद आए तो please let me know in the comment section, or you can DM me on Instagram mj.micro, या फिर आप इसी कमेंट सेक्शन में आप पोस्ट कर सकते हो. ठीक है, तो सारे देखो डुएबल क्वेश्चंस थे. रूमेटिक हार्ट डिजीज भी, इस पे भी मुझे कुछ मिला नहीं है. अगर कुछ याद आए किसी को तो प्लीज लेट मी नो. Leptospirosis was asked, really? Because I could not get anything on this, anything about leptospirosis. Was leptospirosis also asked today? Because ये मैं फर्स्ट टाइम अभी सुन रही हूँ मैं. लेप्टोस्पायरोसिस पे तो कुछ भी नहीं किसी ने कुछ बोला है. ओके मोनिका, यू आर सेइंग यस टू लेप्टोस्पायरोसिस क्या? ओके, माइक्रो एग्लूटिनेशन, विच बाय द वे इज द गोल्ड स्टैंडर्ड. पूरी बैक्टीरियोलॉजी में यही एक ऐसा डिजीज है जहां पे गोल्ड स्टैंडर्ड टेस्ट ना कल्चर है, ना ही कोई न्यूक्लिक एसिड एम्प्लीफिकेशन टेस्ट है. रादर इट्स अ सीरोलॉजिकल टेस्ट, दैट इज मैट. तो क्या पूछा था इसमें? Okay, fantastic. This is a very important topic. Leptospirosis, most common zoonotic disease on the earth. Food poisoning we already have discussed. Exact question क्या था? Okay, microagglutination. So this was the question. Microagglutination is used for. तो ऑप्शन एक हमारा ए लेप्टोस्पायरोसिस हो गया. बी सी डी ऑप्शंस किसी को याद है? यस शाहिद, वी ऑलरेडी हैव डिस्कस्ड चाइनीज फ्राइड राइस वाला क्वेश्चन. Any other option, any other options which you can recall for this question, leptospirosis wala? Okay, Khadim, then I think this would be discussed in medicine or peds. Yes, Shahid, we already have discussed pseudomonas also. Farmer, okay, so this was a clinical vignette. Leptospirosis पे जो आया है, farmer को लेकर कुछ clinical vignette दे रखा था. Then they asked कि what should be done for diagnosis. Is it so? Jack, probably you are referring to this question only. Leptospirosis, farmer के बारे में कुछ दे रखा था. Okay. और क्या मेंशन था? एनी बज़वर्ड्स इफ यू कैन प्लीज रिकॉल. और क्या मेंशन था? कुछ सिम्टम्स दे रखे थे, कुछ और फार्मर के बारे में. Okay, Monica, okay, you are saying it was a one-liner. I hope you guys are not confusing two separate questions. Krishna, influenza virus पे क्या question था? Really question वो came on influenza? क्योंकि recall के time, recall करते समय I did not get any information about influenza. Was there any question on influenza, guys? Kindly try to recall. Okay, Monica, noted. So आप कह रहे हो कि लेप्टोस्पायरोसिस पे वन लाइनर ही था. ओके ओके, नोटेड. चलो ये फार्मर वाली इसमें नहीं था फिर, ठीक है. इन्फ्लुएंजा के बारे में इफ यू कैन प्लीज रिकॉल, कुछ था, आया था इन्फ्लुएंजा से कुछ आज? Okay, maybe I think some people are getting confused between two questions. Okay, yes, Monica, I also got to know about that question that probably will be discussed in OBS Gynae. You all know live vaccines are contraindicated in pregnancy. Influenza pe, who had mentioned, by the way, influenza? Krishna. Okay, yeah, even I wanted to ask you all कि Shankroid पे कुछ question आया है क्या आज? Genital painful ulcer with painful lymphadenopathy. Okay, options in this question? Okay, you are influenza पे question नहीं था, you are talking about that vaccine वाला question. Okay, got it. अच्छा, options क्या थे इस वाले question में फिर genital ulcer वाले में? अगर पेनफुल था सिफिलिस ऑलरेडी रूल्ड आउट. ठीक है, गोनोरिया इज डिस्चार्ज कॉजिंग एसटीआई. ठीक है, सो प्रोबेबली इट वाज एलजीवी ओनली. ठीक है, सो अगेन देखो ये सारे एसटीआईज पे भी काफी क्वेश्चंस आते हैं. अगेन रिपीटेड टॉपिक ही है. So again, the take-home message from this exam also is that you should be familiar with all your PYTs and not just the PYQs. Okay, अब चलो डिबेट हो रही है पेनलेस था पेनफुल था. जो भी था आई मीन सी अगेन ये कोई ऐसी नई चीज उन्होंने नहीं पूछी है. ठीक है, पेनफुल सिंगल अल्सर विद पेनफुल जेनाइटो पेनफुल lymphadenopathy, so should be Shankroid. ठीक है. Okay guys, so that's about Microbiology recall. Once again, a humble request to all of you, please get in touch with me if you are able to recall more questions and the options of whatever questions I have discussed. So thank you very much. So guys, am I audible and visible? Can you all see me, hear me?
Hi, thank you, ma'am, for the wonderful micro insight. Welcome to Orthopedics Recall. I think I'm not visible. Team, anyone can help me with this? Ma'am is ready, I guess.
Yes, sir.
Alekia, ma'am, I hope you're ready.
Yes, sir. Yes, sir.
All right. So I think we can proceed with orthopedics then.
Yes, sir. Sure. Yeah.
Yeah,
Thank
please
you, sir.
proceed.
Yeah. So guys, how are you all? Hope you're tired. Okay, let's start the FMGE recall for ortho. So the first question which I want to start is, yes, is as abduction and external rotation of the shoulder, that is regarding the shoulder dislocation. I'll just come in the next question. So the first one which I got to know is this splint. Yes, is the image right? The same image was shown or anything different? So this, if it was shown, this is called the BB splint. So it was actually used for immobilization of fractures such as femur and tibia. Walkman splint is completely different. Krishna Veni. Yeah, Walkman splint is completely different. This is BB splint, Bodler Brown splint. So we have already discussed this in our FMG class. So this was the image which was given. And for this, whenever there is a femur fracture or tibia fracture, if the patient is unfit, or if you want to take time for the patient, for getting operated, we use this splint for immobilization. Okay, there are 3 pulleys. Okay, it was in the option. Okay, Walkman's was in the option. Yes, thank you for that. So the answer is BB splint. Hope everybody have marked it right, because we have done it in the recent FMG class, right? Right, guys? Anything you want to add on this? Yes, Monica, very good. So all those have marked it right. Very good. So the second question was regarding this. It was a 17-year-old male with some clinical scenario was given, and the specific word which was mentioned was sunburst appearance. I know it is a very, very easy question for you all. And we have dealt in detail about osteosarcoma also. This was done in the TND discussions. So this was all the options given, and it was osteosarcoma, right? Sunburst appearance, the same option, right? And this is the image was not given, maybe. Yeah, image was not given. It was a clinical scenario. So if the image was given, it would be like this. But here, because of the word of sunburst appearance or sun ray appearance, which we have learned, the answer would be osteosarcoma, right? So down with 2 questions. One is the BB splint and the second one is the osteosarcoma. Yes, okay. And the third one was, yes, this was your dislocation. So this was the image, probably it was given. So this also we have dealt in the TND. Yes, the Carpenter knee was given, right? Some patellar issue. I'll come to that also. So this was the anterior dislocation and this is the posterior dislocation. I hope the option was anterior dislocation of the shoulder. The image which was given was regarding the anterior shoulder dislocation. Was image space or anything was mentioned? So it was the image of posterior dislocation. So if it is posterior dislocation, so I've put both of them for you, both the images, both of them we have discussed in detail in the TND. So for this, you have to remember the mechanism of the injury, right? If it is abduction and external rotation, then it would be anterior dislocation. So RTA with abduction and external rotation, you will have anterior dislocation, adduction, internal rotation, mechanism of injury. Adduction and internal rotation will result in posterior dislocation. So now can you make it more clear for us? If the mechanism of the injury was abduction and external rotation, then it would be anterior dislocation. If it is adduction and internal rotation, then it would be posterior dislocation. Okay, if it was imaged based, then you have to look at the image. Probably it will look like the light bulb sign as we have discussed. So this is the image of the posterior dislocation, and this is the image of your anterior dislocation, right? Okay, Monica has also come to in terms for anterior dislocation. Okay, so most of them have told me that is anterior dislocation. So I will leave this to you. Yeah, abduction and external rotation. So anterior dislocation. This also we have discussed, right? And then there was a question of patient with RTA, and a very, very classical question. Usually whenever we ask in the exam or TND also, we frame it the same way, that there would be an RTA with femur shaft fracture. And after 24 hours or 48 hours, if the patient lands up with respiratory distress or cyanosis or any neurological symptoms such as irritability. And one more thing, what is to be mentioned, the petechial rash, right? So this is a triad. So this triad is for, very good, it is for the fat embolism syndrome. I'm very happy everybody have done it right. Okay, this is the fat embolism syndrome, right? Anything else they have added for it? So usually respiratory distress after 24 or 48 hours and especially whenever it is associated with a long bone fracture, and that would be femur usually, and in the male patients, after 24 to 48 hours, this would be a fat embolism syndrome, right? Yes. Okay, the answer was fat embolism syndrome directly. It is also a type of easy question. So this we usually discussed with the complications of fractures, such we started with the compartment syndrome, and then we discussed with the fat embolism, right? So in that chapter, we have done this. And then fourth and fifth finger involved, something was asked, and there was a image-based question. Again, this was also an IBQ, right? Yeah, probably this is the image which we have done, which was mentioned in the exam. And you can see all sort of tingling and numbness in the little finger, in the ring finger. So this is nothing but your ulnar nerve, partial claw hand, and the answer would be the ulnar nerve. Yes, it is the ulnar nerve. Okay. And we have done in detail about the nerve injuries, ulnar nerve, medial nerve, and radial nerve. This was done both in your T&D discussions and your FMG class, right? So FMG decoded, we have done a class. So this is a picture from that class itself. So everything was detailedly written here. Yes, fifth finger tip tingling and numbness. This is an autonomous zone for the ulnar nerve. So the answer would be definitely ulnar nerve, because whenever they mention about fifth finger and that too at the tip. So this is called the autonomous zone for the ulnar nerve. So this is the ulnar nerve, right? So the answer here is the ulnar nerve. Yes, I'm coming to the traction epiphysis. Epiphysis, yes. And whenever they mention about the tip of the thumb, then it would be your median nerve. So this is your tip of the ulnar nerve, autonomous zone. And if they mention similarly the tip of the thumb or the dorsal aspect of the thumb is your radial nerve. And for the ulnar and for the median nerve, it should be the tip of the index finger, right? So that will clear the nerves for us. So all the three nerves. So first ulnar was fourth and fifth, the claw hand, tip of the little finger. And if it was median nerve, it would be tip of the index finger. And something related to thumb would be a radial nerve, right? So anything you want to add? Yes, hypocalcemia also called tingling, but it would not be so specific on the little finger, right? Little finger is usually for the ulnar nerves, right? Right. And regarding the rickets and vitamin D deficiency, there was a Bowlegs which was shown. So most of the people have been confused between Bowlegs and osteogenesis imperfecta. What you have to remember is whenever they mention the bone is brittle, that means there is some problem with the collagen and they will result with the fractures. And in the rickets, it is the deficiency of the vitamin D, and now the bones become soft, right? And now they tend to bend. So whenever they give you clues like bending of the bones, it would be rickets. Whenever they give you clues of fractures of the bones, then it would be OI. Yes? Yes, Bowleg's image was there, but I heard few of them got confused between Bowleg's and OI, because in OI also we see those deformities and all, but the softening of the bones is the clue. So whenever there is a mention of softening, it goes for the Bowlegs, that is the rickets, right? Hope you have all done right. Yes. So done. And now coming to the carpenter's knee. So the first thing what I want to tell you is carpenter's knee, usually this is pre-patellar bursitis, right? So the some inflammation of the bursa which is present in front of the patella, the pre-patellar bursitis is the carpenter's knee, but still we are not very sure about the question. So it can also sometimes be chondromalacia patellae. So I need little bit of information regarding this question. So this is not very clear, but usually the pre-patellar bursitis, another name is your housemaid's knee or the carpenter's knee. So image was given. MRI? Yeah, so there is a confusion between, so I have to get the image for more clarity. So we'll see whether Rishabh sir will take up this question, the image of the MRI, if at all he has that MRI image. So usually chondromalacia patella is, you will have this theater sign. Theater sign, what is that? So if the patient sits for a long time and then tends to stand up, that will result in pain on the anterior aspect of the knee, right? Housemaid's knee is the pressure, right? So whenever there is an inflammation of the bursa due to pressure, because they continuously kneel down for wiping the floor, so that is called the housemaid's knee. So for this, we need the MRI image. Yeah. Okay, so it was not infra or pre, it was mostly the calcified option of the chondromalacia. So let us wait for the image, not just jump into the conclusion. So we'll just put this question on the hold. So this was also discussed, like it was just, I have mentioned the names of it. So bursitis is one of the important options for them to ask you. So it could be housemaid's or clergyman's, pre or infrapatellar. And there was one more question on TB spine. So the question, yeah, if it is behind the patella, then it would be chondromalacia patella. So what is chondromalacia patella? Is the between the patella and the patellofemoral arthritis. It is usually. So if something is there behind the patella, then it would go for chondromalacia. But if they have mentioned something related to carpenter's, because this word specifically, the word carpenter's knee is also in synonyms with the housemaid's knee, right? So let us wait for that. Okay. Don't worry, we'll come up with a detailed recall. This is just a superficial recall, okay? Next, what is the question regarding the TB spine? So we all know this TB spine, usually the question would be, yes, it is night sweats and present with the cough sometimes. Yeah, if carpenter is present, I think it would mostly be prepatellar bursitis, okay? And presence of cough with night sweats and evening rise of temperature. And here also I've not got any image of the spine, but we have discussed this in our FMG decoded. I put up the MRI image as well. So you will see there is a lot of destruction, right? Destruction of the vertebrae, and it would be usually the paradiscal, right? Above the disc and below the disc, the two vertebrae gets involved. So if this was the image given, same image, okay, then good. Thanks to me, right? So this was the image if this was put up, and yeah, if this was the image which was given, the destruction of the both the vertebrae above and below with some, pus formation anteriorly or posteriorly, and specifically if they mention that it is related to night sweats or evening rise of temperature and history of cough, and not to forget loss of weight and loss of appetite. So these are all which will guide you to lead to the diagnosis to the TB. And in the investigations, yes, it is raised ESR and raised CRP. And usually the ESR levels are very much raised. It could reach up to 100. Yes, weight loss was there. Yes. So it is TB spine, okay? So we are done with this question. So TB spine was the answer. Fine. Yes, then come to the epiphysis. So there are 4 types of epiphysis, So this joint forming epiphysis is the pressure epiphysis. Why it is called the pressure? Because this epiphysis will bore the weight. So it takes up the weight and it forms the shape. So usually the femoral head, if you see the head of the humerus, humeral head. So these are the examples for your joint forming epiphysis or pressure epiphysis. Then what is traction epiphysis? Traction epiphysis is your greater and lesser trochanter. GT and LT are called the traction. They don't involve in formation of joint, but they are attached to the tendons, right? That is the example of traction epiphysis. And you have aberrant epiphysis and you have atavistic epiphysis. Atavistic example is your coracoid process, right? There are some extra projections of the bone. And aberrant is, they are just present. They are not involved anywhere. They don't do anything. They are just present like that. These are called aberrant, usually find in the metacarpals. Right? Yes, if it is given due to the pull of the muscle, tibial head or something related to muscle or the tendons, then your answer would be traction epiphysis, something related to muscle or the tendon. If it is something related to joint formation, then it is your pressure epiphysis. lower end of the radius was marked on the X-ray. So it is joint forming, right? Distal fibula was shown. Okay, so distal fibula doesn't form the joint. So, okay, decide by yourself. So pressure epiphysis is joint formation. It involves in joint forming. Take the example of the femoral head or head of the humerus, and traction is your GT and LT, for example, whenever it is associated with the muscle or the tendon, right? Right, so that's it from the orthopedics point of view. How was the overall exam? I think it is somewhere related to mild. Yeah, pressure atavistic. So I think from orthopedics point of view, I think it is really relatively easy questions, and most of them are from your TND and FMG decoded.
Right,
I hope
ma'am.
all
Right, ma'am.
students have
Thank you
done
very
well.
much, ma'am. It was really nice.
Yeah, yeah.
And I think our next faculty is also ready to take over.
Yes. One minute there. The depressed fracture that would be taken by next Rishabh sir.
Yes, ma'am, I'll take that. Thank you, ma'am.
Yes. Thank you, sir. Bye.
Rishabh sir, over to you.
Guys,
I
bye.
think you're ready with the radiology.
Yes, sir. Yes, sir. I'm ready, sir.
Right,
Thank
right.
you, sir.
Please go ahead, sir. We are running, we are lagging a bit, no,
Okay, sir.
away
10
from
minutes.
time.
10
minutes.
questions,
So
10
please
minutes.
proceed with the radiology, and let's see if our next faculty is also ready. Thank you very much, sir.
Yes, so thank you, sir. We'll start with the radiology discussion. Now, what I got recall from radiology, around 10 to 10 questions were from radiology. A good decent chunk was from radiology. So I say this to all the students. Radiology को आप लोग ignore कर देते हो. आपको लगता है ना radiology तो बाकी subjects में cover हो जाएंगी. But radiology को आप एक तरह से revision subject समझो. So you revise all the images with the help of radiology. When I take offline classes of radiology, I finish all the spotters of all clinical subjects. तो आपके सारे क्लिनिकल सब्जेक्ट्स एक तो कवर हो जाते हैं. सेकंड, यू गेट 10 to 12 क्वेश्चंस फ्रॉम रेडियोलॉजी. ठीक है, 2 days 10 क्वेश्चंस इज नॉट अ बैड डील, राइट? So you should attend radiology seriously. Now, what I got from students regarding the FMG exam is that it was not a very easy exam. From FMG point of view, yes, the questions were PYQs, but PYT is more than PYQ. So we'll go ahead and discuss all the questions that I could gather from radiology. Now, I don't have the exact question and the options. The aim is just to, tell what topics were asked and what is the correct answer. So question, topic and answer, that is how we'll go through. So first question, if I'm not wrong, was regarding Holman-Miller sign, right? There was a image. I think if this is the similar image which was given, we have covered this image in the class videos itself. I've taken this snapshot from the class videos. The sign was Holman-Miller sign, and where is it seen? We all know it is seen in JNA or juvenile nasopharyngeal angiofibroma. The image was given, and you were asked which is the disease. No, it is not nasopharyngeal carcinoma. Monica, it is nasopharyngeal angiofibroma. JNA. Nasopharyngeal carcinoma is different. Yes, it is nasopharyngeal angiofibroma. JNA. Okay. Now, next question. Image of pot spine was given. If I'm not wrong, this was the image which was given. You can confirm. Sorry for the poor quality of image. But yes, there was a paradiscal infection in the lung. A history of fever, weight loss was given. Back pain was given. And the answer was pot spine. Yes, TB. Good. Right. Now, another question came. Another question on sigmoid volvulus came. Typical favorite of examiners, beat INICT, FMG, NEET, PG. Where is it seen? Direct spotter, sigmoid volvulus, coffee bean sign has been covered in the class videos very well. Sigmoid X-ray was given, Monica. Good. Yes. Okay. Then another question came on congenital diaphragmatic hernia. So clinical scenario was given of a newborn child with respiratory difficulty. The doctors evaluated and found that there was a posterolateral defect on the X-ray. So you were already given that X-ray was evaluated and a posterolateral defect was given. So even if you did not see the image, you know that diaphragm posterolateral defect is what type of hernia? It is Boctelic hernia. Posterolateral defect is Boctelic hernia. Right? So this is also covered in our class videos. Now, depressed skull fracture, if I'm not wrong, the language of the question was somewhere like a construction site worker, a colleague incidentally threw a hammer on the head of another colleague, and the X-ray, the CT scan was given, a depressed skull fracture. So I'm not sure if the same image was given. Depressed skull fracture usually have a fracture segment which is displaced internally into the cranium. Okay, so this was depressed skull fracture. Other options which were given were diaphragmatic and linear. So linear fracture, you see there is no displacement of fracture fragment. Okay, how would a linear fracture looks like? So this is how a linear fracture looks like. I have already covered it in my class notes. This is a linear fracture, no displacement of the bony fragments. In a depressed fracture, there is displacement of the bony fragments. Right? What is a diaphragmatic fracture? So this is fracture which happens which results in suture widening. Diastasis is widening. So suture widening is diaphragmatic fracture. Right? So the answer here is depressed skull fracture. Now, teardrop sign orbital blowout fracture was asked. Image was given. So this is the teardrop sign in which, there is fracture of the orbital floor. There is fracture of orbital floor and the orbital contents herniate into the maxillary sinus like a teardrop. This is the teardrop sign. Question can be asked in the next time, which is the most common nerve involved, or sorry, most common muscle involved, not the nerve. It is the inferior rectus. So if the questions are wrong, tell me what was the correct question. No. They asked the sign, they gave the image. Fauzi Talkie, if you are saying the questions are wrong, then tell me what are the right questions. I want you to tell me what are the right questions. Okay, so we'll continue. Now, if I'm not wrong, pneumoperitoneum chest X-ray was given. Maybe a question was like people went on a party and after that had a binge of alcohol and developed severe pain in the abdomen. A chest X-ray was given, and if I'm not wrong, air beneath the diaphragm was given. Air under the diaphragm was given just above the liver, and you were asked what is the likely cause. So answer was hollow viscous perforation, hollow viscous perforation. Okay, so this is pneumoperitoneum, which we also, sir, question like friends went to a party, drank alcohol. Yes, yes. So that was the question, and hollow viscous perforation was the correct answer. Now, another question on 𝐒𝐿-𝐂𝐈𝐀 came. Now, if I'm not wrong, this was the image which was given. Okay, there was a smooth narrowing. So, and the question had mentioned dysphagia to liquids more than solids. Now, bird beak, as my juniors told, were not given in the options. Bird beak appearance was not given. You were given rat tail sign, smooth tapering, irregular tapering, and corkscrew appearance. Now, tell me if the image of the barium swallow had a smooth bird beak like appearance, right? Had a bird beak like appearance, but it was not given. Now, then what is the best answer? Now, we know that dysphagia to liquids more than solid points to achalasia cardia, right? And in achalasia cardia, there is no malignancy. So it will have a smooth tapering. I've covered this in my class. I've told you that rat tail appearance is seen in esophageal carcinoma, in which there is irregularity. Okay, so rat tail and irregularity are similar things, so they will not be the option. They will not be the answer. Now, corkscrew we know is seen in diffuse esophageal spasm, and it presents with dysphagia plus chest pain, right? And the appearance is very typical. It has a corkscrew appearance of esophagus. So the answer correct is smooth tapering of esophagus seen in 𝐒𝐿-𝐴𝐶𝐈𝐀 cardia. 𝐒𝐿-𝐴𝐶𝐈𝐀 cardia. ठीक है, so the correct answer here is smooth tapering, not rat tail sign. Don't mark rat tail sign as the correct answer. It is smooth tapering. Now, if I'm not wrong, a question regarding temporal lobe abscess was given, an image was given, and you were asked what is the diagnosis. I don't know the stem of the question, or neither do I know the option. So please help me recall the stem of the question and the options. ठीक है, so temporal, if this was the direct image, maybe a history of ear discharge in the past was given, a hearing abnormality was given. I don't know the stem of the question, but if this is the image, the answer is temporal lobe abscess. Okay, ear infection. Okay, ear infection with this image. Yes, the answer is temporal lobe abscess. Okay, ear infection, pain and discharge. Okay, yes, the answer is temporal lobe abscess. Later, headache, nausea, vomiting. Okay, ear infection, history of ear pain, ear discharge, and okay, chronic ear infection. Chronic ear infection, and later developed headache, nausea, and vomiting. All right. Okay, answer is temporal lobe abscess. These are findings of raised ICP, which happens in any intracranial space occupying lesion, right? Now, I'm not sure what was the exact question regarding the bone tumor. Yes, I'm coming to the lung X-ray, don't worry. I just want to cover this brain tumor once. So students have told me that there was question had mentioned patient has vestibular schwannoma. Patient has vestibular schwannoma and now developed another tumor in the sphenoid having psammoma bodies. Having psammoma bodies. And I think this was the image which was given. Image of a meningioma was given. Image of meningioma given. Right? Patient had a vestibular schwannoma already, that was given, and another tumor now developed in a sphenoid bone having a psammoma bodies on histopath. So now psammoma bodies, these are what are known as psammoma bodies, which are very typical of meningioma. Okay, image was not given. Okay, no image given. Image was not given, so only pathology was given, psammoma bodies. So mainly sort of a pathology question, not a radiology question. Okay, just history. Okay. So meningioma is the answer. Now, as told by a student, so there was an image of lung abscess. 30-year-old patient was there. He is a smoker and he had history of sputum. Now, this was a lesion which was given, if I'm not wrong. There is a cavity in the left lung having air fluid levels. Having air fluid levels. So this is lung abscess. Okay. Sputum pus. Okay. Right. This is a lung abscess which we covered in our class. Now, any other radiology question? Now, 𝐒𝐿𝐾𝐄 ma'am mentioned about prepatellar bursitis, and students commented that MRI image of a prepatellar bursitis was given. So just tell me whether this was the image that was given, whether this was the image, or this was the image. Which was the image which was given? So you tell me one or two. Which was the image which was given? One or two? One. One. Somebody saying two. Somebody saying one. Okay, so let me just break it down for you. If the abnormality, if the hyperintensity or the brightness is anterior to patella, I'll mark the patella. This bone right here, this is our patella. If the hyperintensity was anterior to patella, then this is prepatellar bursitis. Prepatellar bursitis, also known as housemaid's knee or carpenter knee. But if it is posterior to patella, this is my patella. Again, this is my patella. If the pathology is posterior to patella, so you can see there is defect here. There is defect in the cartilage of the patella, this defect. Okay. Similarly, here you can see there is defect in the cartilage of patella. This is what is chondromalacia patelli. So I don't know which image came. If it is posterior to patella, between the patella and the femur, this is my femur, this is my patella. If the pathology is between them, chondromalacia patelli. If it is anterior to patella, it is housemaid's knee or prepatellar bursitis. Okay, there was a question, carpenter's knee. Okay, then the answer is carpenter's knee. Okay. All right. Okay. Anterior to patella था, ठीक है, फिर carpenter's knee mark करेंगे. Sir, after first trachea shifted, after fight, okay, there was history of fight. Trachea shifted to the left side. Trachea shifted to the left side. What is the cause? Right pneumothorax or traumatic consolidation? Please tell about this, sir. Okay, अगर after a fight हुई है and trachea shifted to the left hand side, there is history of if this is the chest X-ray, this is the heart, this is the trachea. Now, if the trachea is shifted to the left hand side like this, right? So you know that there is some mass effect which is causing the trachea to shift. Now, is it consolidation or is it hemothorax? So it is hemothorax. Consolidation will have midline trachea, even if it is traumatic consolidation. Hemothorax will have contralateral mediastinal or tracheal shift. ठीक है, अब यही हीमोथोरैक्स भी हो सकता है, ये न्यूमोथोरैक्स भी हो सकता है, कुछ भी एयर हो फ्लूइड हो डजंट मैटर. हीमोथोरैक्स और न्यूमोथोरैक्स कैन बी ईदर. After fight, SOB later, traumatic right pneumothorax. Option was like that, traumatic pneumothorax. Trachea opposite to the side and findings in the left side. Yes, so if अगर ट्रेकिया लेफ्ट साइड है तो फाइंडिंग राइट में होनी चाहिए, अगर ट्रेकिया राइट साइड है तो फाइंडिंग्स लेफ्ट में होनी चाहिए. Okay, no image was given, just it's given as case. Okay. कोई क्वारल विद बार अटेंडर, हाइपर रेजोनेंट. ओके, हाइपर रेजोनेंट दिया है, एब्सेंट ऑफ ब्रेथ साउंड दिया है. तो अगर न्यूमोथोरैक्स है भाई, न्यूमोथोरैक्स है तो क्या होगा? कॉन्ट्रालैटरल ट्रेकियल शिफ्ट, इप्सिलैटरल एब्सेंट ब्रेथ साउंड्स ऑन ऑस्कल्टेशन, इप्सिलैटरल हाइपर रेजोनेंट ऑन परकशन. तो परकस करेंगे तो हाइपर रेजोनेंट आएगा, अगर ऑस्कल्टेट करेंगे तो एब्सेंट ब्रेथ साउंड्स होंगी. ठीक है, कोई कंफ्यूजन नहीं है इसमें, सिंपल है ये क्वेश्चन. सो दैट इज ऑल फ्रॉम रेडियोलॉजी. अराउंड 10 to 12 questions have come from radiology, and over to the next teacher. For one question, that a lady is taking therapy for breast cancer, later there is some mark on the left lung and person having SOB. So case of radiation pneumonitis in patients with breast cancer. अच्छा इसकी इमेज भी दे रखी थी क्या? रेडिएशन न्यूमोनाइटिस का जो क्वेश्चन बोल रहे हो इसकी इमेज भी दी हुई थी क्या? X-ray was given. So X-ray of radiation pneumonitis presents like a pneumonia, right? It presents like a pneumonia, and most commonly it is on the upper lobes and the right middle lobe. That is where the pneumonia is. Okay, I'll cover the X-ray. Let me just get the X-ray. Mostly consolidation होता है upper lobe and right middle lobe का. I'll get the X-ray and we'll give you a proper recall once the proper image is given to us. Okay, Monica. Okay, Rishabh, Lokmanya. I'll get back to all of you. Monica, ठीक है.
Right. Thank you very much, sir. Thank you very much for this wonderful insight on radiology. I hope कि students के कुछ query जो भी थे वो clear हुए. And once we are done with this recall, we'll come back again with a much better version of the same for all our students. And rest assured that all the students will also be getting a PDF of the same. I think, Sir Jagdish sir, I think you are ready. Can you proceed?
Thank you, Dr. Siraj. So ENT guys, कैसा था? I think FMG वाले examiners ज़्यादा मेहनत नहीं करते ENT में. Like they use pretty much everything has come either from the PYQs, PYTs, and everything has come from what we covered in our FMG decode. This
Right,
question
sir.
of
Over to you.
nasopharyngeal carcinoma comes every time, at least for the last 4 times in a row, something or the other. तोड़ मरोड़ के, when something on nasopharyngeal carcinoma, they kept asking that Trotter's triad, you know, where the nasopharyngeal carcinoma enters the space of Morgagni and all of that. This time they've asked for somebody with mass in the neck and glue ear. So nasopharyngeal carcinoma, someone saying more than mediocre you felt. ENT was more than medicine. Yeah, there are a lot of ENT questions. ENT was there everywhere. ENTs are also everywhere. Nasopharyngeal carcinoma also asked every time in FMG because neck nodes are there. So that's why you see a neck mass in nasopharyngeal carcinoma. If it was a child for 12, 13 years old or 7, 8 years old with glue ear, then we think about adenoids. But if they say there's a mass in the neck, then there is going to be, glue ear because it presses the eustachian tube. So here the correct answer will be radiation therapy. I don't know what the exact options kya the, but I think with this grommet insertion and all don't have a role in this particular condition to do the thing. And grommet insertion follow for 2 weeks option will not make sense in this case. It will be radiation therapy. Options are not same. So Monica, what are the options? Was the neck dissection option was there? Rishabh is saying same option and Monica saying no. Okay, so even if neck dissection, generally for nasopharyngeal carcinoma, we will do radiation therapy only. No wait and watch. Wait and watch, so ऐसे डाल दिया, we don't know what it is. So instead of leaving it empty, we put wait and watch so that some student, if we wait and watch, they will tell us the correct response. Okay. So this is grommets with steroid. So radiation therapy, guys, nasopharyngeal carcinoma, that is very, very straightforward. Tuning fork question, very basic question, asked, right side René is negative and left side René is positive. What was the diagnosis? ऐसे ही था question. Was it like this? What about Prozac space was asked, Hasnain Varsi. So Sumuki, grommet is not the answer. Grommet steroids are not the answer. Those may be the options. The option will be radiation therapy. If that option was there. If radiation therapy option was not there, then maybe neck dissection. But this one, René's negative is right. Conductive hearing loss. René's negative means that the ossicular chain is dysfunctional, but the cochlea is working fine. So that is right. Conductive hearing loss. So this is also very straightforward. So no problem. This image-based question was there, guys. This is a target sign in CSF. Always asked many times. I don't know. There was a question on beta transferrin, or was it this? So Rishabh is saying, sir, right side René is negative. If René is positive and Weber's is deviating to better ear, so Weber's component also they had told. So if right side is negative and the Weber's is going towards the side of the negative, that goes towards conductive, hearing loss. The question that they gave was all Renes-Weber's bone conduction, answer negative. Yeah, so anyway, all of that is pointing towards conductive hearing loss. Dr. Lokmanya, what was the question asked related to beta transferrin? I did not get that very clearly. But did they ask diagnosis, or did they ask what is going to be found, or will beta transferrin be positive? Handkerchief sign, sab pucha tha. Those were options. One of the options were, the option was double target sign. So they told you to identify the sign. They just gave the image and they say, ask the sign. Okay, so in that case, the double target sign would be the answer. So that is also very, very straightforward. Okay, so ABC was also asked, and ABC, absolute bone conduction, is basically measuring the cochlea function. So the cochlea function will be the same in the patient and in the doctor, because in absolute bone conduction, you close the ear. So the conductive component will not play a role. If it was Schwabach's test, then there would have been a problem, because then the Schwabach's test will be shortened when there is a conductive deafness. So if ABC is the same, then that would also point towards conductive hearing loss. The examiner is just trying to say that cochlea theek chal raha hai, the cochlea function is fine. Okay, they gave the same image, asking what it is. All right, so this we got. This is Horman-Miller sign. Dr. Rishabh has already covered it, seen in juvenile nasopharyngeal angiofibroma. We see the posterior wall of the maxillary sinus is pushed forward in the this thing. Same question, everything, but answer is right, conductive hearing loss. All right, Monica, got it. That is correct, conductive hearing loss. Now, this question, was this image there? Dr. Rishabh has also covered it. This is Horman-Miller sign, juvenile nasopharyngeal angiofibroma, celebrity question, especially FMGE mein, nasopharyngeal carcinoma and juvenile nasopharyngeal angiofibroma aata hai. Usually adenoids also comes. This time adenoid did not come. One more normal CT image they gave and asked the structure. Yeah, I have that. I think that is for maxillary sinus, and I think they pointed at the osteomeatal complex. I didn't know what they were pointing at, but there is some reference image which I have, I think, of maxillary sinusitis. This is an anatomy question. I think they asked you to point at the pharyngobasilar fascia. I don't know if this was the image or something like that, but this is covered under anatomy also, as well as pharyngobasilar fascia is a very important fascia, which is there over here. So that's there is a question on atrophic rhinitis. I could not get what the question on atrophic rhinitis was. Was it crusting roomy nasal cavity, or was it about Young's operation? What was the question on? Was it just a clinical vignette? So okay, so that image. Okay, let me go to that question. Then there was maybe a CT scan like this. And I think they had asked you to point at the osteomeatal, complex. Maybe an arrow would have been something like this, telling which is the draining path for the, maxillary sinusitis. So we'll come to that also. Atrophic rhinitis, what was asked? Anosmia. Girl with a crusty anosmia. So they just basically asked you diagnosis. They gave you a clinical vignette. So they said there is a female, which is very common to see atrophic rhinitis in female with crust in nose and merciful anosmia. And your answer was atrophic rhinitis. Yeah. Usually, yeah, green, black, roomy nose. Okay. Fine. So that is also a very common topic, atrophic rhinitis aata hai. I was also told that there was an image, hand-drawn image of tympanoplasty, and you were asked to identify which tympanoplasty it was. Monica saying no, black, only green is mentioned. See, crusts can be black, brown, or green. I think the reason why they said green is because if the moment they say black, it can confuse with mucormycosis. So green crusts are also seen in atrophic rhinitis. The keywords are roomy nasal cavity, and merciful anosmia. All right. So here type 2 and type 3 were there in the option. I think the image that was given was for type 3, where the graft is placed on the stapes suprastructure, right? So that is the one, which is this type 3. It is called myringostapedopexy, where the graft is placed on the suprastructure of the stapes. So type 3 was there. That is also, we have covered it in our FMGE decode. They gave options. So in this, they gave options of allergic rhinitis, atrophic rhinitis. Okay. Only type 3 was asked in this, right? So there was an image. Okay, for type 1, type 2, type 3, type 4, and you are supposed to find out which tympanoplasty image is the answer, and the answer will be type 3 tympanoplasty, correct? Yeah? All right, Dr. Lokmanya, thank you. And this, again, Dr. Rishabh has covered, there's a temporal lobe abscess, and I think you already clarified that there was a history of somebody with a discharging ear, and it's a complication of, CSOM. So it is a temporal lobe abscess. I think child also had some fever or seizures or something like that. So this has already been covered by Dr. Rishabh. There's an overlap, radiology and ENT, especially nowadays image-based questions are also asked in ENT. So wo images can be pathological or radiological. So sometimes there will be, this thing. Krishna Pasi saying there's neck dissection instead of radiotherapy. If there is no radiation therapy, then the next answer that is possible is radiotherapy, is a neck dissection when it comes to the nasopharyngeal carcinoma question, because I'm not sure if radiation therapy was there or not there. But if it is not there, then and neck dissection would be the next closest option. Now, history of headache, ear infection, Sumukhi is saying, yeah. So then that basically they're trying to say it's a complication of CSOM, which is brain abscess. All right. Now, there was a audiogram or a PTA image was given. I don't know what was given. This is some student said that एक audiogram bhi pucha gaya tha. Was there an audiogram or a graph shown? Pure tone audiometry graph was shown. AB gap was there, Monica Chaudhary is saying, okay. So they showed something like this. Audiogram minus 10, 0, 10, 20, 30, 40, 50. And this is 250, 512, 1K, 2K, 4K, 8K. So you're saying that there is a tympanogram and PTA. And Weber's was, both images were there in the same question. So there was a tympanogram. So a tympanogram was there and a PTA was there. Both were there in a single question, and Weber's is lateralizing to the left ear. Okay. Weber's is lateralizing to left ear. And what they asked you the diagnosis, or they asked you what was the type of the curve or finding? At 2K, there was something at 2K. So you're saying that there is an airborne gap. Was it a right ear or a left ear? See, right ear, you take the symbols from right and left. So right ear, air conduction will be 0 and bone conduction will be triangle. So it looks like R. And left ear, air conduction without masking will be X, and with masking will be a square. All right. So this is without masking and this is with masking. So they had said red line, so right ear. So right ear, airborne gap. So right ear, they would have shown either a circle like this. And for bone conduction, there is usually only two symbols. If it is without masking, it will be like this, and with masking, it will be like this, and they will have dotted lines. So that is how you come to know. So 0 with red line. All right. So you had 0 with red line. Okay. So you had 0 with red line, and then there would have been a bone conduction like this with dotted line. Right. Pointing towards the right side. And then that means that there is a airborne gap. So there is some conductive hearing loss. And the tympanogram was showing a flat curve, which most likely will be B-type curve. So that typically means that there is some fluid in the middle ear. And that's why it is showing this. So it would be conductive hearing loss of the right side, if that is the diagnosis asked. I don't know. But it sounds like it is right conductive hearing loss with this kind of tympanometry and audiogram. Type B tympanogram was in question. Okay, so they were asking what is the kind of tympanogram, and the flat tympanogram is type B. And because you can see that there is conductive hearing loss over here, and that conductive hearing loss is because of the airborne gap being more than 20 decibel. But option was not there. Okay. So the examiner wanted you to tell what is the tympanogram type, and it was type B. And to support that, they also gave you a pure tone audiometry so that you have no confusion that there is some middle ear conductive problem because, okay, so that is there. Oropharyngeal cancer, nasopharynx also was there in the history. Then it is also possible, again, pointing towards nasopharyngeal carcinoma. If nasopharyngeal carcinoma is there, then you can have conductive hearing loss because eustachian tube is blocked and it can give a type B tympanogram. But sometimes with blockage of eustachian tube, it can also give type C tympanogram. But if in type C tympanogram, it will look like a peak, but the peak is in the negative side. So that will be a C-type curve. So here it looks like that. Sir, what may be the cause? Option are oropharyngeal cancer, nasopharyngeal cancer, and two more. Yeah, see, Dr. Rishabh, if they gave this scenario and asked you what will be the cause, it has to be something in the nasopharynx, okay? Because something in the nasopharynx is one that is going to block the eustachian tube, which then starts causing buildup of fluid inside the middle ear. So it can be adenoids, it can be nasopharyngeal carcinoma, it can be juvenile nasopharyngeal angiofibroma, any mass inside the nasopharynx. So if your options or a nasopharyngeal carcinoma is there and no other option from nasopharynx, then that will be the answer if that is asked. Monica is saying, but B-type curve was given for sure. Either ways, guys, I think you have understood. So this is what it is. एक कोई tracheal foreign body पे question था. Somebody has written that the tracheal foreign body पे भी question था. I don't know what it was. Was it an X-ray? Was it a bronchoscopy image? Was it just history? Was it about Heimlich's maneuver? Anything? What was there on the tracheal foreign body? Monica saying yes, there was a question on tracheal foreign body. X-ray was there. All right, so it was an X-ray. Was it like a coin? Was it a coin or something? History, presence of bruit. Okay. Two questions were there. Okay. On the X-ray with a foreign body. Heard sound. No. Total 3 questions, type 4. Kya bol rahe ho yaar? Okay, fine. I'm trying to understand. So there was a question on tracheal foreign body. There was an X-ray question with some history. Krishna Pasi, you are saying graft was placed at stapedius. That question is over. That is type 3 tympanoplasty. Okay, next step was asked. All right, next step was asked. What were the options? One, X-ray showing total white ring on the right side. Mother is feeding and fruit and seed went in respiratory distress and palpable. Okay. Okay, thanks, Monica. That is helpful. Groundnut, not able to cough and dry. Okay, so mother feeding and then some groundnut goes inside the right bronchus or something, bronchiole. Oh, it is in the trachea of the child. Okay, it's not in the bronchus. It is in the trachea. It is in the trachea. Okay. And they will ask, what is the next step? Okay, what were the options? Heimlich's maneuver was there or bronchoscopy was there? Okay, apple and its seed. Apple plus seed. What were the options given? Oh, there are two questions. One was a groundnut, which is for bronchus, and other was fruit seed. Okay. I would come under ENT, so I'm more interested in the trachea question. Bronchus question can go to, probably surgery. But I think here it would be a foreign body in the trachea. And if Heimlich's maneuver was there, then the option answer would be you do the Heimlich's maneuver. If Heimlich's maneuver is not there, then maybe the next option could be bronchoscopy and removal. Okay, in case of apple seed, only its location was asked. Okay, so if its only location was asked, then that becomes straightforward. So there seems to be two questions, and that is why we're getting two different types of responses. One is a groundnut which enters the bronchus when the mother is feeding. Another one is an apple and its seed getting stuck in the trachea, and location was asked. So then it seems like it was a simple answer. Jag Vigyas is saying the tympanogram is not flat. What kind of tympanogram was it? There can be only 3 types of tympanograms that were asked in the previous question. Either it can be like this, or it can be like this, or it can be like this, but on the negative side. It will be helpful for everyone, guys, that if you're talking about a particular topic, we can comment about that particular topic. Otherwise, you have to keep going front and back. Monica is saying type B only 100%. Okay. Hemlix was there for one question. Then Hemlix is the answer for the tracheal one. For bronchial, for foreign body stuck in the bronchus, we will not do Hemlix maneuver. All right. Steeple sign is seen in laryngotracheal bronchitis. ये बहुत time से आ रहा है, same image आता है, and your pediatrics faculty will also talk about this. Laryngeal croup, we won't spend too much time on this. Maxillary sinusitis ka image question aa gaya, and that yeah, acute laryngotracheal bronchitis, Monica, you're correct, also called as laryngeal croup. And this maxillary sinusitis, I think they wanted you to tell the drainage pathway, and that is the osteomeatal complex. Sir, I marked epiglottitis. Epiglottitis will have the thumb sign. Okay, there will be side view X-ray, and it will show the thumb sign, and patient will have inspiratory stridor. Whereas in laryngotracheal bronchitis, it will start with inspiratory stridor but become biphasic. So generally seeing a biphasic stridor in a child with steeple sign. Steeple sign is like the church steeple. That's how the name comes. You know, it becomes like this, like the church steeple. So it is called steeple sign. Level of lymph nodes were asked in image-based questions. Okay. Sir, how to do Hemlix in 2 years? The Hemlix maneuver in 2 years is a little different. In adults, we hug from behind and we do it. But in children, you have to press with 2 fingers right under the xiphisternum area and press with the 2 fingers, you know, pointing downwards. And then the child will cough it out. Okay. But either ways, there is a Hemlix maneuver to do in babies. Of course, you don't go behind the baby and do this kind of Hemlix maneuver. You just press with 2 fingers of the thumb, this thing. Sir, Hemlix maneuver, its X-ray options were Hemlic. Child, we don't do. Put blind fingers and remove, do X-ray. CPR was also given. Okay, if Hemlic was there in the option, see, putting the fingers blindly would not sound like a right clinical approach, especially for the trachea in a child, because the trachea cartilage is such that you cannot pull it out with the finger. It will only push in and go inside the mainstream bronchus. You can otherwise do a tracheostomy, secure the airway, and then put a bronchoscope and remove the foreign body. This would be the most likely thing, and Hemlix maneuver can be done in babies. It is not contraindicated. So if the Hemlix will be there, I think that would be the you know, option. But otherwise, removal under bronchoscopy would be the other option. CPR would be possible only if the child does not have a heartbeat. A child is in asystole, then only you will do a CPR. All right. So this was the question on the type B tympanogram. All right. So I think everything is covered over here. You know, about 10-12 questions have come. A lot of ENT questions are coming, which is a good sign for our field, that ENT is quite relevant and very clinical. And I hope all of you were able to answer this. Once we will get the refined questions and we will share it with you, we will have better clarity. Right now, just for a quick, you know, giving you a quick recall, the exam just happened a few hours before. We are sharing this just to understand how you did and whether our answers can help you. ENT, in my understanding, is quite easy. We covered everything even in our decode, and most of the questions, if not all, have come from past years. So FMG examiners do not make much effort for ENT questions. So that's it from my side, guys. Back to Dr. Siraj and your next faculty.
Thank you very much, sir. That was a wonderful insight about ENT. Jazir sir, I hope you're ready.
Hi, Siraj sir. Am I audible?
Hi, sir. Sir, overall, I hope dermatology questions were not scary for the students. Please proceed with dermatology.
I was interacting with the students today. So
Right.
got to know that initially nobody is able to give me the exact questions. Hopefully during the session now, I'll be able to frame the right MCQs.
Right.
But all of them are able to recall ki kaun sa topic se aaya hua hai.
Right, right.
Okay.
Please
Fine.
proceed, sir. Give them the insight.
Thank you so much.
Thank you, sir.
So, very good evening, all of you. I hope the paper went quite okay for all of you. So, I'll just start with my dermatology recall now. So, to start with, I'll just do the first one, that is in leprosy itself. So, in leprosy, do you remember that this kind of a question was asked, like in multi-bacillary leprosy, what is the incorrect treatment? So, if you could just let me know in the chat box, that would be great. In this case, the options that I could collect was that dapsone 100 mg daily, rifampicin 450 mg monthly, clofazimine 50 mg daily, and clofazimine 300 mg monthly. So what is it? Yeah, Rishabh is confirming that it's the same. So Rishabh, let me know which was the answer that you guys have marked. Dr. Mukesh says it is option B. So does all of you agree to this, that it is option B? So what is the monthly dose of rifampicin that we give? So in this case, just a minute. Yeah. So in this case, I'll just show you one of the snippet from the app. So this is the management where rifampicin, it is not actually 450 mg. So how much is it? Yeah, rifampicin will have to go for 600 mg single loading dose once a month, isn't it? And whereas in clofazimine, we go for a 300 mg loading dose along with 50 mg on a daily basis. And dapsone is given daily, and the common dosage is going to be 100 mg. So I hope that there is no confusion with this question, pretty direct. So if just you were able to make out that this is not 450 mg, it should be 600 mg, I guess all of you should get it right. So thank you for confirming, Monica, Dr. Lokmanya, and all of you. Chalo, theek hai. Not appropriate treatment was given in the question. Still, it means the same. Now, there was one more question, which is again based on chemotherapy and hair loss. Am I right? So, was there any question regarding anagen effluvium? Can anybody tell me what exactly was this MCQ? So, yeah, like you must have got options like a patient who is undergoing chemotherapy. So, is facing some hair loss, correct? Yeah, I'm coming to that comedonal treatment part. So now let us see. So image of anagen was given. So do you mean that an image of the anagen hair was given? Was anything mentioned about chemotherapy in the question? So what happens when a patient undergoes chemotherapy or radiotherapy? In all these cases, what happens is chemotherapeutic agents as well as radiotherapy, this will lead to an anagen phase arrest, isn't it? So the anagen hair, which is supposed to be 85% of our hair, so this goes into arrest and there is going to be an increased hair loss. Yeah, thank you so much, Monica, for confirming. Yeah, so in this case, the right answer should be anagen effluvium, because obviously in the MCQ, you must have seen that telogen effluvium is also one of the options. The right answer here should be, yeah, lady with chemotherapy is given with the picture. Okay, in all those cases, chemotherapy, if it is mentioned, the hair loss that is associated is going to be anagen effluvium. So now let's move to one more. So here this one is regarding acrodermatitis enteropathica. So was this mentioned? Acrodermatitis enteropathica. So all of you know that this comes under nutritional deficiency, where this is usually seen during the weaning period, correct? So image was given. Okay. So can you just let me know what was the kind of question that was asked? Did you get an image-based question where there is a periorificial dermatitis? See, what is periorificial? Around the nasal orifice, around the oral orifice, etc., isn't it? So yeah, image was given along which deficiency? Yeah. So the first wala image. So someone is confirming that Dr. Mukesh is saying that this is the first image. So this is the type of image that was given. So whenever you are able to see that there is a periorificial dermatitis, the usual mnemonic that we use is DAD, right? Diarrhea, alopecia, and dermatitis. So in these cases, this should be zinc deficiency. Okay, zinc deficiency. So Uduman says just image. Okay, this is going to be, okay, in the option, there were options like zinc, copper, iron, etc. Thank you so much, Dr. Lokmanya. So here the right answer should be zinc deficiency. I guess this was also pretty much doable question, isn't it? Okay, Krishna. The question says diarrhea along with the first image. Okay. Now, did you get any image like this today? Like there is an image, something like this nearby the umbilicus. And did they ask you regarding the treatment? So any image like this, can you just confirm with me in the chat box? Yeah, in case you got an image like this, what is it resembling? It resembles, it resembles, the same image. So Dr. Rishabh is saying that this is the same image. So I just took a snippet from the app. So this is the same image which we have used for our classes as well. So here what is happening is you can see that this one is called as strawberry hemangioma or a capillary hemangioma. So what was asked? So in strawberry or capillary hemangioma, what happens is this lesion is not usually present at birth. So it usually develops within few weeks of life. But is there any treatment that is necessary? Remember, in all those cases, capillary hemangioma. So no, the image was given, not the deficiency, right? And the management. So here, this is going to be self-limiting. Because what happens, this lesion is going to start shrink. So once it starts shrinking, so it shrinks by around 50% by 5 years of age. And by around 10 to 12 years of age, the entire lesion would disappear. So no treatment is necessary. So Ria is answering that just observe. So that should be the right answer in this case. So when it comes to strawberry hemangioma or a capillary hemangioma, the right treatment, no treatment is necessary. You just need to observe the patient. Okay, basal cell carcinoma was also given in the option. So I just saw that Ranjit sir has discussed about that question where you had a doubt whether it is a basal cell carcinoma or a squamous cell carcinoma, where keratin pearls or the peripheral palisading of basal cells were mentioned. So I hope you got that one also right. I just wanted to confirm one more thing. Was there any question regarding Koebner's phenomenon? Because some of them were saying that Koebner's phenomenon was asked. Some of them were saying that no, this was not asked. Can you just confirm? So yeah, did you get any question on Koebner, like new lesions which develop on trauma? Second image. So again, the same thing is happening here. Sumukhi is saying that the second image is asked, but many others are saying no. So in case you have at least got this Koebner anywhere in the options. So Koebner means, so whenever you find a new lesion which develops at the site of trauma, like after scratching over the skin, if you develop a lesion, so this is going to be Koebner. But I guess this was the thing that was asked. Like you got an image of a patient with psoriasis, and which is the sign that can be seen. Yeah, Dr. Mukesh is also answering the same. Psoriasis per the question tha, sir. Yeah. So in psoriasis, did you get this question that which is a sign that you can elicit? Is it a Weightage test? Is it a Koebner phenomenon? Is it Nikolsky sign or Aspo-Hansen? Yeah. So this is the question that many of them gave me a vague idea about. So yes, so here the right answer should be Weightage test. So whenever you get a patient who is having multiple erythematous plaque lesions, some plaque lesions like this over the trunk. So what we do is we take a glass slide, and once we take a glass slide and just start scraping over these lesions, what would happen is the scaling, they become much more visible. So the accentuation of the scales, this is called as Weightage test. So this is called as Weightage test. Because we must have learned that, okay, Weightage test mein first what happens, the scaling becomes visible. After sometimes you can see that there is a very shiny membrane that develops. It's called as a Berkeley's membrane. And then finally, once you still continue scraping the lesion, the patient may develop multiple pinpointed bleeding spots like this. So these bleeding spots, then that is going to be Auspitz sign. So this one, the correct answer should be Weightage test, isn't it? So in psoriasis, Weightage test can be done. And then I guess probably Mamta ma'am also had discussed about this one. There was some question where a patient had a rose thorn prick. So after getting a rose thorn prick, the patient develops multiple nodules which is arranged linearly. So this linear arrangement of nodules. So what is the diagnosis here? Yes, Dr. Rishabh is confirming yes, sporotrichosis. Dr. Lockman is also confirming. So there was one question on sporotrichosis. Yeah. So this one, so based on the history, whenever you get a thorn prick, there is going to be an implantation of the fungus into the skin. And that is how the patient can develop sporotrichosis. And that is because of Sporothrix schenckii, isn't it? So did they just ask you about what is the name of the diagnosis, or did they ask you about the organism? So Monica is saying there is no picture. They just asked you the description and asked the organism. So if they have asked you regarding the organism, then what is the organism? So this is going to be Sporothrix schenckii. So this is going to be Sporothrix schenckii. So Sporothrix schenckii, which is a deep fungal infection, that is going to be the organism. I hope all of you have got this one right. Pretty much direct question as well, isn't it? Very good. Excellent. And then a bit confusing because someone of you said that there was a question on genital ulcer. So is this the question that was asked? Like, is there a painful genital ulcer with bilateral lymphadenopathy? First of all, I would like to know whether it was mentioned there is a painful genital ulcer or not. So in case it was mentioned that there is a painful genital ulcer, Sinu, just wait. Just let us complete this genital ulcer, then we'll jump into the acne vulgaris question. Okay, agar painful genital ulcer, then only two things would come to your mind, isn't it? So one should be chancroid and the other should be herpes genitalis. So here, yeah, a 30-year-old lady having a new boyfriend and develop painful genital ulcer with bilateral lymphadenopathy. So this case, in case it is mentioned like this, then the answer should be chancroid. Because in chancroid, this bilateral lymphadenopathy can also be mentioned as painful buboes, isn't it? They can also be mentioned as painful buboes. Okay. So oral lacy lesion plus red color penile ulcer, a condyloma acuminata lichen planus. Because in lichen planus, we don't expect a genital lesion as such. In those cases, it should be condyloma acuminata if you have got those kind of exophytic growths over the genitalia. So Monica, if you could make it more clear, I can give you much more options. Okay. Bilateral lymphadenopathy was mentioned. Okay, done. And what about acne vulgaris? Because every time when you get a question about acne vulgaris, it is not usually confusing. But here they said that some management was asked regarding acne vulgaris. And in acne vulgaris, I guess you got an image as well. So probably the options that you got was topical retinoids, oral isotretinoin, and something else. Can somebody tell me? Okay, lichen sclerosis was also given in the option. So just one moment before we go into acne vulgaris, when it comes to painful genital ulcer, lichen sclerosis is something which you see commonly in the postmenopausal age group, where you find some thinning of the area of the genitalia. Patient may complain of lot of itching and all. So that actually doesn't fit into this scenario. Okay. Okay. So now coming to this one. So regarding acne vulgaris, in case you have got some big lesions like nodulocystic lesions and all, then I guess the correct answer should be isotretinoin. In case if it is nodulocystic acne, because some of you are saying that it is nodulocystic acne. Someone is saying that it is going to be papillopustular. But if it is a severe kind of acne with a lot of lesions over the face, then it is most likely going to be retinoid only. But if the number of lesions are big in size, the number is more, then more likely you should go for an oral retinoid, that is isotretinoin. Okay? But if if the image was something like a comedonal acne or something, like the blackheads or the whiteheads, then in that case also the answer should be retinoid. But here we are not going for an oral retinoid. Instead, we would go for a topical retinoid. Okay, topical retinoid. So Dr. Mukesh says it is comedones. So yeah, if it is not nodulocystic, if it is comedonal, then it should be topical retinoids. If it is comedonal acne, it is comedonal 𝐒𝐿. So not at all nodule, then TK. So if it is not nodule, then it should not be isotretinoin. So these are the questions that I could gather in this short span. And anyways, we will be coming up with a much detailed FMG booklet with all the precise answers and all. So that is it. So not differentiated top or all, just different drug. Okay. So thank you so much. So that is all about dermatology. Very quick recap. So over to Siraj sir. So I'll just hand over the session to Siraj sir so that we can move with the next faculty. Last class se sare questions sir. Okay. Thank you so much, Dr. Mukesh.
Hello, Siddharth sir.
Hi, sir. Thank you very much, sir, for the Derma insight. I hope Vivek sir is audible and visible.
Yes.
Sir, I hope you are ready with your
Sir.
questions. Please put insight on these questions.
Siddharth sir, physiology has always got this unique problem because physiology comes in every other subject of medicine.
Right, sir. Right,
And
sir.
therefore, for one question, there are lots of claimants, and
Right, sir. Right, sir.
it's fine. I could gather, after running pillar to post, I could gather a few questions.
Rest of the questions students might help you, sir, as we proceed in the recall. Yeah.
Yes.
Okay,
Yes.
sir. Please
Yes.
proceed, sir. Thank you, sir.
Yes. So I'll just start and see 2.5 questions that I could collect from the students. They could not recall physiology questions. So let's see what I have gathered. Then I'll ask the students. The question that I could get was, which of the following is involved in the milk ejection reflex? Was this a question? Shreyansh is saying physiology के 20 questions थे, and I am running from pillar to post to collect those questions, and I could get only 2.5 questions. So was there a question on oxytocin and milk ejection reflex? Yeah. And the question was like this: which of the following is involved in the milk ejection reflex? Okay. So answer was oxytocin, I'm sure. Okay, it was in the form of an image. All right. Image of a lady and breastfeeding a child and milk ejection reflex. So it was a straightforward one. Prolactin is for milk synthesis, and for milk ejection, it's the oxytocin. Positive feedback. You are aware of that. Milk ejection reflex. Prolactin was not there. Then what was the other option? Anyways, oxytocin is a very straightforward one. So there is no confusion in that. Image was given. Okay, fine. So oxytocin and milk ejection reflex was there, and I'm sure all of you must have given the correct answer to this question. Second question that I could get is that a person is performing weightlifting. So which of the following will be the change in the sarcomere? Was there a question like that? I band decreases, A band decreases, H zone increases, M line disappears. Was there any question like this? Okay. So just to have a quick review of this is a sarcomere, and you can see on either side of Z line there are I bands, and then there is A band, H zone at the center. So I band shortens with sarcomere shortening. Then this is the H zone, which disappears because thin filaments come and begin to overlap at the center. A band remains unchanged, and there is an M line at the center which becomes prominent. So I band shortens. Was that the question? Options were A and I decreases. Both decrease? No. I band shortens. That's it. A band remains unchanged because A band is the width of this thick filament, and the thick filament is not going to shorten. Thick filament remains as it is. So A band will not shorten, only I band shortens. I band decreases. All right. तो I hope कि आपने ये क्वेश्चन भी आसानी से सॉर्ट किया होगा. तो ये 2 क्वेश्चंस मुझे मिले हैं. तो अभी आप हमें हेल्प कीजिए और क्या क्वेश्चंस थे. एक और क्वेश्चन आया था कॉन्स सिंड्रोम के बारे में, तो वो संदीप सर कवर करने वाले हैं. मेडिसिन में आता है कॉन्स सिंड्रोम, सॉरी संतोष सर, आई बेग योर पार्डन, कवर करने वाले हैं. तो कॉन्स सिंड्रोम, अल्डोस्टेरोनिज्म, सोडियम रीएब्सॉर्प्शन, पोटेशियम एक्सक्रीशन एंड सो पोटेशियम लॉस होता है, हाइपोकैलेमिया होता है, और सोडियम रिटेंशन एंड हाइपरटेंशन. दीज आर द फीचर्स ऑफ कॉन्स सिंड्रोम. अच्छा, ये और कौन सा क्वेश्चन था? हाँ, ऑक्सीजन कर्व. डॉक्टर लोकमान्य जी इज सेइंग ओके, कौन सिंड्रोम में हाइपोकैलेमिया था, तो ये संतोष सर अपने वो कवर करने वाले हैं, तो वो पार्ट वहां पे हो जाएगा. ऑक्सीजन डिसोसिएशन कर्व का क्या था? ऑक्सीजन कर्व के बारे में क्या क्वेश्चन था? कैन एनीवन रिकॉल दिस? अच्छा, राइटवर्ड शिफ्ट था. राइट शिफ्ट, ओके फाइन, नोटेड. लेकिन ऑप्शंस क्या थे? राइटवर्ड शिफ्ट किस में होता है या नहीं होता है, क्या क्वेश्चन था? डॉक्टर ऋषभ, rightward shift happens in which of the following? Metabolic alkalosis, hypocapnia, acidosis, hypothermia. ओके, तो आपको याद होगा 4 इंपॉर्टेंट फैक्टर्स है जो राइटवर्ड शिफ्ट करते हैं. इंक्रीज H+ यानी एसिडोसिस, उसके बाद इंक्रीज CO2, देन इंक्रीज टेम्परेचर एंड इंक्रीज 2,3 डाइफॉस्फोग्लिसरेट. जब ये बढ़ते हैं तो राइटवर्ड शिफ्ट है, और ये कम होते हैं तो लेफ्टवर्ड शिफ्ट है. ऑल राइट, ओके. तो हाइपोथर्मिया, मेटाबॉलिक अल्कलोसिस, 2,4 DNP. आर यू श्योर इट वाज 2,4 DNP और इट वाज 2,3 DPG? क्योंकि डाइनाइट्रोफिनॉल जो है वो मेटाबॉलिक पॉइजन है, उससे मतलब एटीपी, सोडियम पोटेशियम पंप बंद हो जाता है, एटीपी भी बंद होती है और पंप का काम भी बंद हो जाता है. तो वाज इट 2,4 डाइफिनॉल डाइनाइट्रोफिनॉल DNP कि 2,3 DPG? ओके, एंड द आंसर वाज एसिडोसिस. फाइन, चलो, एसिडोसिस में कर्व शिफ्टेड टू द राइट और बाकी सब में लेफ्टवर्ड. ओके, गॉट इट, गॉट इट. खादिम जी, यस, आपने भी लिखा है आंसर वाज एसिडोसिस. सो आई एम श्योर कि सबने ही एसिडोसिस लिखा है. बाकी कोई क्वेश्चन और याद आ रहा है आपको फिजियो का? ओके, श्रेयांश सिंह जी कह रहे हैं क्वेश्चन था अबाउट बैलेंसिंग द बॉडी, विच ट्रैक्ट डज दैट? तो वेस्टिबुलोस्पाइनल, रेटिकुलोस्पाइनल, टेक्टोस्पाइनल, रूब्रोस्पाइनल, ऐसे कोई ऑप्शन थे, या कॉर्टिकोस्पाइनल? गाइस, एक क्वेश्चन आया है सामने, बैलेंसिंग ऑफ द बॉडी, विच ट्रैक डज दैट? वेस्टिबुलोस्पाइनल ट्रैक्ट क्या था ऑप्शंस में? ओके, यही ऑप्शंस थे. सो देन द आंसर इज वेरी ऑब्वियस, वेस्टिबुलोस्पाइनल ट्रैक्ट. बेसिकली आपको पता है कि 4 एक्स्ट्रा पिरामिडल ट्रैक्ट्स होते हैं और एक पिरामिडल ट्रैक्ट. तो कॉर्टिकोस्पाइनल ट्रैक्ट इज सपोज टू इनिशिएट द मूवमेंट and control the finger muscles, distal muscles of the hand and feet, and then उसको बॉडी की इक्विलिब्रियम और बैलेंस बनाना उस मूवमेंट में, वो काम है वेस्टिबुलोस्पाइनल एंड रेटिकुलोस्पाइनल ट्रैक्ट्स का. तो अगर वेस्टिबुलोस्पाइनल ट्रैक्ट ये ऑप्शन में है, तो देन दैट वाज द आंसर. बैलेंस ऑफ द बॉडी ड्यूरिंग अ वॉलंटरी मूवमेंट इज अ जॉब ऑफ वेस्टिबुलोस्पाइनल ट्रैक्ट. ऑल राइट, करेक्ट. तो वेस्टिबुलो स्पाइनल ट्रैक्ट वाज द आंसर. सीनू जायसवाल जी भी कह रहे हैं कि सेम ऑप्शंस थे, सो आई गो विद दैट एंड वेस्टिबुलो स्पाइनल ट्रैक्ट वाज द आंसर. जेवीपी का कोई क्वेश्चन था? जेवीपी somebody saying JVP का कोई क्वेश्चन था, was it a physiology question या कोई मेडिसिन का पूछा गया था उसमें? बार्टर सिंड्रोम, बार्टर सिंड्रोम तो आप देख लेना मेडिसिन में या कहीं और अगर है तो. Physiology to identify A wave, they asked what is A wave in JVP. ओके अच्छा, मेटाबॉलिक अल्कलोसिस वाला जो क्वेश्चन है ना, वो बायोकेमिस्ट्री के सर लेने वाले, राजेश सर लेने वाले हैं. सो ऑलरेडी डिसाइडेड, ही विल डिस्कस दैट. और बाकी फिर ए वेव, हाँ तो ए वेव इन द जेबीपी इज ड्यू टू एट्रियल सिस्टोल. आपको पता ही है 3 अपस्ट्रोक्स है और दो डाउन स्लोप्स है, ए सी वी. और याद कैसे रखना है, ए एट्रियल सिस्टोल, सी isovolumic contraction of the right ventricle, and V isovolumic relaxation, venous blood accumulated in the right atrium. So yeah, identify the cause of A wave was asked. Obviously cause of A wave is the atrial systole. Okay, atrial contraction, Dr. Rishabh is saying correct, absolutely. तो आई थिंक आप लोग थके होंगे, और भी रिकॉल करिए और हमें क्वेश्चंस देते रहिए. अगले वीक में हम ये सारे क्वेश्चंस प्रॉपरली कलेक्ट करके एक बार और इसका प्रॉपर वीडियो बनाने वाले हैं. सिराज सर, ओवर टू यू.
राइट, थैंक यू वेरी मच सर. आई थिंक कि फिजियोलॉजी हमेशा से डिफिकल्ट टास्क रहा है बच्चों को, है ना. रिकॉल करने में मैंने देखा है बच्चों को हमेशा डिफिकल्टी रहती है फिजियोलॉजी में. बाकी क्लिनिकल तो कहीं ना कहीं निकल जाते हैं, बट आई एम श्योर स्टूडेंट्स एक बार थोड़ा और रिलैक्स हो जाएंगे, दे विल बी एबल टू प्रोवाइड मोर इनसाइट टू दिस. एंड नेक्स्ट आई थिंक बायोकेमिस्ट्री सर इज क्वाइट रेडी. सर जल्दी से बता दो, जल्दी से टाइम दे दो. Sir, over to you. Please provide some insight to our students in biochemistry.
Okay. Hi, Siraj sir. Hello,
Hi, sir.
everyone. Welcome to a FMGE recall session of biochemistry. And I could gather 10 to 11, near about 10 to 11 questions or 9 to 10 questions, particularly integrated question, CBME curriculum. See, this is integrated question, integrated with pediatric, mainly ophthalmology, physiology, and skin, and also medicine. So integrated approach is followed here. Small clinical history is mentioned there in the questions, and the questions where the difficulty level simple to moderate. मैं बोल दिया easy, बहुत ही easy था, तो आप लोगों को काफी ज्यादा बुरा लगेगा क्योंकि आप लोगों ने मेहनत की है. हमने तो आपको प्रिपरेशन दिया है, हमने आपको रिसोर्सेज दिए हैं, हमने आपको तैयार करवाया, लेकिन लड़ाई लड़ने तो आप लोग गए थे. तो आप लोग बहुत ज्यादा बेटर पोजीशन पे हो फीडबैक देने के लिए. बेटर ये क्वेश्चन आया था या नहीं आया था. और कुछ लोग मैं देख रहा हूँ कंटिन्यूअसली, कुछ लोग हैं जैसे डॉक्टर ऋषभ है, मोनिका है, फिर लोकमान्य है, कृष्णा, रिया, अल्लूकार्ड, श्रियांश. आप लोग काफी अच्छा फीडबैक दे रहे हैं. आपकी वजह से ये रिकॉल जो है और बेटर होते जा रहा है. सो थैंक यू वेरी मच ऑल ऑफ यू. विल स्टार्ट विद द बायोकेमिस्ट्री सेशन. मैंने पहले ही बोला कि इंटीग्रेटेड क्वेश्चंस बहुत ज्यादा थे. आप लोगों का फीडबैक बहुत ज्यादा मायने रखेगा, और क्वेश्चन के आंसर जो है वो क्वेश्चन के स्टेम के ऊपर, ऑप्शंस के ऊपर बेस्ड होते हैं. क्वेश्चन का आंसर जो रहता है उस पर बेस्ड होता है. तो प्रॉपर स्टेम और ऑप्शंस अगर बराबर नहीं है तो हम भी आंसर तक पहुंच नहीं सकते प्रॉपर. ये क्वेश्चन डॉक्टर जजीज सर ने ऑलरेडी कवर किया. द इमेज शोन बिलो इज ए डेफिशिएंसी मैनिफेस्टेशन ऑफ. ये इमेज बेस्ड क्वेश्चन आया था, काफी लोगों ने ये कंफर्म भी किया. मैंने जजीज सर का सेशन देखा है. तो ओरिफाइसेस के अराउंड में जब रैश दिखती है, दैट इज नोन एज द एक्रोडर्मेटाइटिस एंटेरोपैथिका. जिंक डेफिशिएंसी मैनिफेस्टेशन है, जिंक डेफिशिएंसी मैनिफेस्टेशन से एक्रोडर्मेटाइटिस एंटेरोपैथिका. माउथ, फिंगर, नोज, टोज, पेरिनियल एरिया, these areas are involved. And zinc deficiency, the typical manifestation, diarrhea, alopecia, dermatitis. Then delayed wound healing, impaired spermatogenesis, affect the vitamin A level also. These are the functions of these are the functions of zinc deficiency. काफी PYT based एक्चुअली पेपर जो था वो PYT based था, प्रीवियस ईयर टॉपिक बेस्ड था. ओके, तो ये क्वेश्चन ऑलरेडी डिस्कस हो गया है. वन क्वेश्चन वाज ऑन फॉस्फेटाइडिल कोलिन. हाँ, मैं ये हाँ मुझे आखिरी में बताना, ये फॉस्फेटाइडिल कोलिन लेसिथिन पे अगर कोई क्वेश्चन था तो रिगार्डिंग द मेम्ब्रेन। ओके, ये डिस्कस करेंगे। ओके, दिस वाज द फर्स्ट क्वेश्चन, ये ऑलरेडी डिस्कस हो गया। देन देयर वर क्वेश्चन ऑन द विटामिन ए डिफिशियंसी, इमेज बेस्ड था या नहीं था ये मुझे क्लियर नहीं है, और सुधा मैम भी एक्चुअली ये क्वेश्चन कवर करेंगी ऑप्थेल्म में। सो विटामिन ए डिफिशियंसी कॉजेज द बीट आउट स्पॉट, ये सभी को पता है, नाइट ब्लाइंडेड, बीट आउट स्पॉट, corneal cirrhosis, conjunctival cirrhosis, and the blindness. These are the vision related symptoms with vitamin A deficiency. यहाँ पे इमेज था क्या? नो इमेज, नो इमेज बेस। बिट आउट स्पॉट जो रहता है ये ट्रैंगुलर ओपेक्स प्लाक रहता बिकॉज ऑफ इंक्रीज केराटिनाइजेशन इन द कंजंक्टाइवा, इंक्रीज केराटिनाइजेशन इन द कंजंक्टाइवा। विटामिन ए हमेशा से फेवरेट क्वेश्चन रहा है कोई भी एंट्रेंस एग्जामिनेशन का, वेदर इट इज डेफिशिएंसी or the toxicity of the vitamin A, also the RDA of vitamin A. Okay. It is asking about the management. So, bit out spot ऊपर चला जाएगा अगर if if the in the question they are asking about the management of bit out spot, तो विटामिन A उसमें ट्रीटमेंट में देंगे। ओके, चाइल्ड फ्रॉम पुअर फैमिली, अच्छा हिस्ट्री थी यहाँ पे। माल न्यूट्रिशन पे भी काफी क्वेश्चन थे, तो वो कम्युनिटी मेडिसिन में आपके कवर हो जाएंगे, यहाँ पे हम माल न्यूट्रिशन नहीं ले रहे। ओके, सो विटामिन ए डिफिशियंसी वाज देयर, ये तो सबसे इजी था। विटामिन मींस गम ब्लीडिंग, इसमें भी इमेज थी क्या? गम ब्लीडिंग, चाइल्ड हैविंग द फीवर विदाउट इम्यूनाइजेशन एंड इज फ्रॉम पुअर फैमिली विद बिट आउट स्पॉट। थैंक यू ऋषभ। नो immunization was there and poor family bit out spot, bit out spot। तो बिट आउट स्पॉट क्या रहता है? एक्चुअली ट्रैंगुलर वाइट ओपेक प्लाक रहता है कंजंक्टाइवा पे, बिकॉज ऑफ इंक्रीज केराटिनाइजेशन, हाइपर केराटिनाइजेशन की वजह से होता है। उसमें ट्रीटमेंट में हम विटामिन ए देते हैं। नो इमेज। बेबी वॉज ऑल्सो हैविंग द मीजल्स। हाई डॉक, ऑप्शंस आर नॉट द सेम इन द जिंक डेफिशिएंसी क्वेश्चन। क्या चेंज था इसमें? Okay, we'll cover this again. Institution isolation and vitamin A dose, and another one is isolation with vitamin A with nutritional supplement. Perifollicular bleeding in vitamin C. Option was same. Only iron was mentioned. Hi Lokmanya. Thank you. Okay. Okay. Thank you Lokmanya. Now gum bleeding ये तो एकदम easy है। Perifollicular hemorrhage, यहाँ पे hemorrhage क्यों होता है? It is because of defective collagen synthesis, because vitamin C helps in the hydroxylation of proline and lysine, that is prolyl hydroxylase, lysyl hydroxylase, जिसके वजह से कोलेजन को रिजिडिटी मिलती है, और क्रॉस लिंकिंग के वजह से स्ट्रेंथनिंग होता है कोलेजन मॉलिक्यूल। और कोलेजन अगर ब्रिटल, मतलब कोलेजन डिफेक्टिव सिंथेसिस हो गया तो कैपिलरी की वेसल्स वॉल वॉल जो है वो ब्रिटल हो जाती है एंड इजीली ब्रेकेबल हो जाती है। दैट्स व्हाई देयर इज गम ब्लीडिंग इन द विटामिन सी डेफिशिएंसी। ओके, द नेक्स्ट क्वेश्चन इज डिफिशिएंट एंजाइम इज इन अल्कैप्टोन्यूरिया। अल्कैप्टोन्यूरिया हमने हर जगह पे कवर किया है, एक्चुअली ये विटामिन भी हमने हर जगह पे कवर किए हैं। विटामिन मिनरल ऑलरेडी फेवरेट टॉपिक रहा है कोई भी एंट्रेंस एग्जामिनेशन हो। सी डेफिशिएंट एंजाइम इन अल्कैप्टोन्यूरिया, इट इज होमोजेंटिसेट ऑक्सीडेज। बाकी के कौन से ऑप्शन थे? नो क्वेश्चन। हाय रिया, नो क्वेश्चन ऑन अल्कैप्टोन्यूरिया। हेलो ऋषभ, हाय लोकमान्य। Any feedback regarding the alkaptonuria question, enzyme deficiency in the alkaptonuria? because it is given by 3-4 student, deficient enzyme in the 𝐒𝐴 question was like pigmentation joint with ochronosis. Small case mentioned. Pigmentation. 𝐒𝐴 is the pigment which deposits in the joint. And pigmentation, yes, only enzyme deficiency was asked with picture. Image-based question. Okay, image-based question था. कुछ लोग बोल रहे था, कुछ लोग बोल रहे नहीं था. Okay, so 𝐒𝐴 deposits in the joints in the latter age of life, particularly in the third decade of life, because of deposition of pigment. 𝐒𝐴 causes the ochronosis, and there is black color cartilage, tendon in the 𝐒𝐴. The deficient enzyme is homogentisate oxidase. The classical feature is urine turn dark on standing. Okay, cola color urine. हाय ऋषभ. थैंक यू. ओके, ठीक है. तो इस पे डाउट डाउट है थोड़ा सा. ओके, ओमिटिंग विथ बाइकार्बोनेट लेवल 30 मिलीमोल पर लीटर, pH is 7.5 and PCO2 is 48 mmHg. So what is your diagnosis? This is a case with vomiting. Okay, so बाकी के ऑप्शन तो आप लोगों को पता है. मेटाबोलिक एसिडोसिस, मेटाबोलिक अल्कोलोसिस, रेस्पिरेटरी एसिडोसिस विल बी देयर इन द ऑप्शन. सो दिस इज अ केस ऑफ ओमिटिंग. नाउ सी, ये संतोष सर भी मेडिसिन में कवर करेंगे. मैं सिर्फ इतना बता दूंगा आपको कि डायग्नोसिस एकदम मेटाबोलिक अल्कोलोसिस. यस यस, वेट वेट. Metabolic alkalosis. This is answer, metabolic alkalosis. Now see here, how to diagnose this. First, see for the pH 7.3.7.45. अगर इससे नीचे है तो एसिडोसिस, इससे ऊपर है तो अल्कोलोसिस, सिंपल अल्कोलोसिस. ये हो गया पहला क्लियर, पहला पॉइंट एसिडोसिस अल्कोलोसिस. अभी सी फॉर द बाइकार्बोनेट नाउ HCO3. The parameter who goes with the pH is the primary defect. Remember this thing, जो parameter pH के साथ जाएगा वो primary defect है. Now see here, there is 7.5 means it is alkalosis. So it is alkalosis, it is clear. अभी bicarbonate देखो, it is 30 means 22 to 26 or 28 is the normal range. Now it is increased, मतलब it is metabolic alkalosis. So this parameter goes with the pH. Alkalosis is there, so it goes with the pH, so it is a primary defect. Now this parameter, this is a compensatory mechanism. Increase in the PCO2 is the compensatory mechanism. So it is a metabolic alkalosis. Answer here. Answer is metabolic alkalosis. Okay. Which enzyme raised in prostate cancer? यहाँ पे दो क्वेश्चन का थोड़ा सा ओवरलैप है. वन इज रिलेटेड विद द PSA, वन इज रिलेटेड विद द एसिड फॉस्फेटेज. ओके, इमेज ऑफ यूरिन इज गिवन, इलेक्ट्रोक्यूशन बट टेक इट डार्क रेड. सो ठीक है, मतलब 𝐒𝐴 यूरिया का क्वेश्चन डाउटफुल है. ओके, नाउ सी व्हिच एंजाइम रेज्ड इन प्रोस्टेट कैंसर, ये क्वेश्चन था या नहीं था. और इस पे रिलेटेड मुझे दो क्वेरीज है. एक तो एसिड फॉस्फेटेज वाला क्वेश्चन था और दूसरा PSA वाला भी क्वेश्चन था. सो हियर आंसर इज एसिड फॉस्फेटेज. PSA ऑप्शन में रहेगा तो PSA आंसर रहेगा. मोर स्पेसिफिक मार्कर है PSA, प्रोस्टेटिक स्पेसिफिक एंटीजन. स्पेसिफिकली in the drug monitoring response to the drug therapy, the PSA is the better marker. Response to drug therapy, the PSA is better marker than acid phosphatase. This question was there. यहाँ पे रेस्पिरेटरी लिखा है. See, this is acidosis. This is respiratory acidosis. मतलब PCO2 बढ़ा हुआ है. सी PCO2 मतलब कार्बोनिक एसिड पकड़ने का, कार्बोनिक एसिड बढ़ा हुआ है मतलब रेस्पिरेटरी एसिडोसिस. सो दिस इज कॉम्पेंसेटरी मैकेनिज्म. प्राइमरी parameter who goes with the pH is the primary defect. Remember this thing. Hi doc. तो हियर आंसर इज एसिड फॉस्फेटेज. PSA पे कुछ क्वेश्चन है तो यहाँ पे प्लीज पोस्ट करो. ऑल्सो वन क्वेश्चन PSA का क्वेश्चन पोस्ट करो. प्रोबेबली संदीप सर कवर कर लेंगे उसको. आप जिसको भी याद आया वो wasn't there in the option. हाँ, तो ये तो बराबर है। पीएसए यहाँ पे ऑप्शन में नहीं है, लेकिन यहाँ पे एसिड फॉस्फेटेज आंसर में है। दिस इज आंसर हियर। पीएसए का एक दूसरा क्वेश्चन था, वो पोस्ट कर देना, वो कवर हो जाएगा। ओके, सो पीएसए इज द बेटर मार्कर फॉर द रिस्पॉन्स टू द थेरेपी। ओके, ये क्वेश्चन था क्या 4 डे ओल्ड चाइल्ड एंड 15 मिलीग्राम पर डेसीलीटर बिलिरुबिन लेवल, ऐसा कुछ हिस्ट्री था, फिजियोलॉजिकल जॉन्डिस से रिलेटेड क्वेश्चन था या नहीं था? 4 डे ओल्ड चाइल्ड 15 मिलीग्राम पर डेसीलीटर बिलिरुबिन लेवल। अभी कौन सा बिलिरुबिन था, कॉन्जुगेटेड था, अनकॉन्जुगेटेड था, कुछ पता नहीं है एक्चुअली। यस, हाय लोकमान्य, मोस्ट प्रोबेबल आंसर इज फिजियोलॉजिकल जॉन्डिस। 3rd एंड 4th डे ऑफ लाइफ पे जब भी जॉन्डिस अपीयर होता है, द बिलिरुबिन लेवल कैन गो अप टू 15 मिलीग्राम पर डेसीलीटर। दिस इज ए नियोनाटल फिजियोलॉजिकल जॉन्डिस। इसके साथ कोई और अगर फीचर है, इनडायरेक्ट है या डायरेक्ट बिलिरुबिन बढ़ा है, कौन सा बिलिरुबिन बढ़ा हुआ है, वो भी मायने रखता है। कंजेनेटल जॉन्डिस में एक्चुअली the bilirubin mainly CJ Krigler Najar type 1 type 2 is there, and rotor for the C increase in direct bilirubin, two causes CJ Krigler Najar type 1 and type 2 congenital jaundice, and second one is the Gilbert में 4 तक ही बिलिरुबिन जाता है। यहाँ पे 20 के ऊपर जाता है जनरली, यहाँ पे 20 के नीचे रहता है बिलिरुबिन लेवल, इनडायरेक्ट बिलिरुबिन लेवल। डायरेक्ट बिलिरुबिन लेवल इंक्रीज होने के 2 कॉजेस है, DR दैट इज डुबिन जॉनसन सिंड्रोम एंड द रोटर सिंड्रोम। डुबिन जॉनसन एंड रोटर सिंड्रोम। ओके, मोस्ट प्रोबेबली हियर आंसर इज न्यूनेटल फिजियोलॉजिकल जॉन्डिस। बिलिरुबिन 0.8 बेबी बॉर्न टू कंट्रोल डायबिटीज मदर। ठीक है, ये कुछ अलग ही डायरेक्शन में जा रहा है, तो इसको छोड़ देते हैं। ओके, बट फिजियोलॉजिकल जॉन्डिस अगर ऐसे टाइप में क्वेश्चन अगर पूछा गया है तो ओके। द नेक्स्ट क्वेश्चन, 2 year चाइल्ड विथ बो लेग्स, नॉर्मल कैल्शियम एंड इंक्रीज पैराथायरॉयड हार्मोन लेवल। ओके, कैल्शियम पे भी थोड़ा सा कंफ्यूजन है, काफी लोगों ने कैल्शियम से रिलेटेड थोड़ा सा फीडबैक अलग अलग दिया है। सो एक्सरे इमेज वाज गिवन, बोइंग ऑफ द लेग, जेनु वैरम डिफॉर्मिटी वाज देयर, and 2 year old child with the bow legs. Here answer is rickets. Here answer is rickets. Okay, इसके बारे में कुछ फीडबैक होगा तो, डिक्रीज कैन, इट कैन बी नॉर्मल टू लो कैल्शियम लेवल इन द rickets, normal to low calcium level in the rickets. Parathyroid hormones are raised, ALP level raised, decrease 25 hydroxycholecalciferol, 25 hydroxycholecalciferol, decrease this level in ALP level raised, and the phosphorus levels are also low in this patient. Phosphorus levels are also low in this patient. Okay, so here diagnosis is rickets. Decreased calcium can be decreased to normal calcium in the rickets. Okay. Diabetes mellitus with the cataract. So this is a cataract. If there is cataract, that is snowflake cataract, which is in the diabetes, it is because of sorbitol accumulation in the lens because of osmotic diuretic. This is related with this metabolism. Now see, whenever there is excess of glucose, this glucose is converted into sorbitol by the aldose reductase. So when there is excess of glucose, it is converted into sorbitol. This sorbitol, it is converted into fructose. This is reversible reaction via the sorbitol dehydrogenase. So this sorbitol accumulates in the lens and it causes opacity in the lens, cataract in the lens, that is known as snowflake cataract in the diabetes. Mannitol, dulcitol was in the option. Just wait. Mannitol, it is used in the treatment of cerebral edema. Dulcitol or galactitol, it is accumulated in the lens in the patient with galactosemia. In the patient with galactosemia, dulcitol accumulates in the lens. Okay, thank you, doc. Yes, low phosphorus was mentioned Thank you. Low phosphorus was mentioned. Okay. So this is here answer is sorbitol. Okay, sorbitol accumulation in the lens causes the cataract. So ये जो ऑक्सीजन डिसोसिएशन कर्व पे जस्ट अभी विवेक सर ने कवर किया ये. See, oxygen dissociation curve, this is the partial pressure of O2 and this is percent saturation of hemoglobin. Okay, in this oxygen dissociation curve, you will get, this is a normal curve, S-shaped curve, sigmoidal shape curve in the oxygen dissociation curve because of cooperative binding of O2 to the hemoglobin. Cooperative binding of O2 to the hemoglobin. Now, some factors, some effectors, they shift the oxygen dissociation curve to the right. Oxygen dissociation curve to the right. And these factors are, one is 2,3 बिसफॉस्फोग्लिसरेट और डीपीजी भी बोला जाता है या बिसफॉस्फोग्लिसरेट भी बोला जाता है. आप लोगों ने डीएनपी लिखा सर को, जब आपने रिप्लाई किया तो डीएनपी लिखा. डाइनाइट्रोफिनॉल अनकपलर है. यहाँ पे 2,3 बीपीजी भी हो सकता है, बीपीजी बिसफॉस्फोग्लिसरेट, या डीपीजी भी बोलते हैं इसको, डाइफॉस्फोग्लिसरेट. नाउ इंक्रीज 2,3 बीपीजी, then increase partial pressure of the CO2, then H ion concentration increase means acidosis, जो ऑप्शन में था. This might be the probable answer here, depends upon the option. Okay, shift of oxygen dissociation curve to the right occurs when these factors are there: increased temperature, acidosis, increase partial pressure of CO2 and increase 2,3 BPG level. ये सब options देख के आपको आंसर लिखना है. Most probably here answer is acidosis. 2,3 BPG level decrease अगर है ऑप्शन में. Okay, so shift of oxygen dissociation curve to the right. Already इस पे डिस्कशन विवेक सर ने किया है तो मैं ज्यादा इस पे कुछ जाऊंगा नहीं. So नियर अबाउट 10 to 11 क्वेश्चंस. एक फॉस्फेटाइडिल कोलिन पे किसने तो भी क्वेश्चन बोला था. फॉस्फेटाइडिल कोलिन पे किसने तो भी क्वेश्चन बोला था. Okay, so here answer is acidosis. Here answer is acidosis. So negative effector will causes the unloading of oxygen to the tissues. It is helpful for the tissues. Phosphatidylcholine का क्या क्वेश्चन था, प्लीज मेंशन हियर. ओके, मेंशन कर देना यहाँ पे. ओके, सो these are the questions related with the biochemistry levels near about easy to moderate level. All questions they were covered in the workbook session of FMG. Also these questions are covered in the recall नहीं क्या बोलते हैं, हमने revision session लिया था उसमें cover हुए हैं. So thank you very much all of you. Over to Siraj sir, please. Cell membrane and transfer. So see, phosphatidylcholine is the predominant component in the cell membrane towards the outer side. Sphingomyelin towards the inner side of the cell membrane. Thank you, Lokmanya. Phosphatidylcholine means lecithin. Over to you, Siraj sir. Next faculty, please.
Okay, I think Siraj sir is occupied, so I'll take over from you, sir.
Okay, sir. Thank you, sir.
Okay, so hi guys. So how's your medicine? Well, मेडिसिन एक ऐसा सब्जेक्ट है जहाँ पे ना ही आपका रीडिंग कंप्लीट होता है ना ही मेरा रिकॉल कंप्लीट होता है. So now I do not have the perfect recall, and medicine of course will take some time to build the recall. But whatever we have, we will discuss. Of course, I'll come back with more detailed recall in a booklet form later. So let me start with the first question. So this is going to be my first question, which is based on ABG, which also Jambulkar sir has addressed. Hi, sir. I'll continue. Yeah. Okay. So this was the first question on ABG, where we had a patient with pH 7.50, PaCO2 48, and bicarb 33. Okay. Okay, so this was a pretty simple and a pretty good question. On ABG. So we'll discuss that, right? So now 3-4 easy. So what we will do is how to approach this question. It's a very simple approach. As we look at the pH, we know that it is alkalosis. pH is clearly suggesting alkalosis. Suraj sir, I think there is a little bit of background noise from one more streaming setup. Locomania, yeah, it's very clear. So this is alkalosis. Now we have to decide whether it is metabolic or respiratory. That we know the simple approach, ROM or ROMS, right? So we have to just tag the pH and the direction. As we know, pH here is increased. And when I look at the carbon dioxide, that is also increased. So both are in the same direction. That means both are in the same direction. It is metabolic. So this case is clearly a case of metabolic alkalosis. Locomania, yeah. So I had a confusion whether it was just a simple ABG based question or there was a clinical stem. So I have framed one more question. I guess the question was somewhat like this, right? A young patient reports with episodes of binge eating followed by self-induced vomiting. She is most likely to develop which of the following acid-base disturbance. This is how the stem was there, or it was a very straightforward ABG interpretation based question. So whether there was a stem or no, the answer is very clear. We can clearly look at the ABG and it was a straightforward question. Okay. I will try to reconstruct it with the vomiting story added. But even if the vomiting story is not given, still the answer is metabolic alkalosis looking at the ABG, right? It's not a complicated question at all. Now, was there any question like this? This kind of a question where a young patient had some binge eating. I don't know whether the diagnosis should be bulimia nervosa or anorexia nervosa or a binge eating disorder, but history mentioned that patient had episodes of self-induced vomiting. She is most likely to develop which of the following acid-base disturbance? Was there a question like this? Lokamani, you are saying there was no such question, right? Okay, good. Anyway, we now clearly know that vomiting, if history is there, we should be expecting metabolic alkalosis. I will just brief you. I'll just brief. There was a question like this. So some of you are saying no question like this, or some of you are saying yes. Okay, anyway, even if they had asked a question, I guess most of you would have got it right because vomiting history is there, and we know vomiting causes metabolic alkalosis, especially long-standing or persistent or recurrent vomiting. Why it causes metabolic alkalosis? Because when someone vomits, right? When someone vomits, he is vomiting out hydrochloric acid from the stomach. So he is losing the H+ ions. So we are basically losing acid. So when we lose acids, we tilt towards alkalosis. So it's as simple as that. So I can develop alkalosis by either gaining bicarbonate or by losing H+. So here I'm vomiting out H+, and that is why I get metabolic alkalosis. So that's like as simple as that. What was the question exact, Harshil? Like vomiting was mentioned and the primary cause was asked. So that, okay, so you meant to say it was a psychiatric diagnosis that they were asking for. Like, is it bulimia nervosa or anorexia nervosa or a binge eating disorder? Was that the question? If it was based on acid-base disorder, then it is simple. Metabolic alkalosis is what we are expecting. Okay, so I will try to reconstitute this question and then I'll share it back again. Yeah, so you're definitely losing chloride. So you will be losing chloride, so it will become hypochloremic. Okay, so can anybody help me with STEM on this SAG score? There was a question on SAG score. So that vomiting related, I will try to reconstitute better. I'll also talk to my psychiatric faculty what was the exact STEM and we will reconstitute. Okay, so there was a question on SAG score, right? So can anybody help me with what was the question? STEM, what had they asked? Did they give you a clinical story and then ask you to interpret the SAG score, or it was just like a SAG score number was mentioned and then they had asked you what is the cause? What was the question on SAG score? Anybody is able to recall? So I guess there was a question on SAG score. At least can you confirm there was a question on SAG score? And of course, SAG score, if they're talking about, it is about ascites. And when we talk about ascites, we classify the causes for ascites into portal hypertensive causes and non-portal hypertensive causes. So if you help me with the stem, I will be able to give you a better recall. Kadim, so that was a very straightforward question. I think Rishabh has already addressed it in radiology, and Sandeep will also be taking it up for the surgery. Doc, you're saying we have chosen incorrect option with respect to SAG score, or was it the previous vomiting question you are addressing? SAG score. Okay. So was the SAG score mentioned? What was the SAG score? Was the SAG score mentioned? Or you had to calculate the SAG score? So I guess, okay, I guess that there was SAG score mentioned. Okay, it was 1 point, let us say it was 1.5, right? All of you agree the SAG score was 1.5? So did you guys calculate it as 1.4 or it was mentioned there? No calculation, it was mentioned 1.4. Okay, and what were the options? I guess, so as you said, false about, right? False about this condition. We have to pick up the wrong statement. Okay, and SAG score is mentioned. I guess there will be one option that there is no portal. There is no portal hypertension, or there is presence of portal hypertension, or the causes. Okay, so they asked it which one is false about SAG score with option as less than 1.1 with relation with ascites, protein, and pulmonary hypertension. Wildam, congrats. Okay, so as we reconstitute the options, let me take a quick recap of what SAG score stands for so that you can help me with construction of the stem. Okay, so what is SAG score? It is the difference between serum albumin and ascitic fluid albumin. If the difference is more than or equal to 1.1, that means there is portal hypertension. If it is less than 1.1, like 1.5, 1.4, 1, 0.9, 0.8, less than 1.1, there is no portal hypertension. I guess they would have framed at least one option based on this, right? Whether there is portal hypertension present or not. If it is more than or equal to 1.1, there is presence of portal hypertension. So in our question, if it was 1.5, definitely there is portal hypertension present. Okay. Now, if there is portal hypertension present, it can either be because of the liver problem or it can be because of cardiac problem. Remember, liver is integral or it is connected with the heart through the hepatic veins, which drain into superior vena cava. So if right side of the heart fails, eventually it causes the pressures to go up in the liver, and that can cause portal hypertension. Now, how do I differentiate whether it is primarily liver problem or it is the cardiac problem? We have to look at the ascitic fluid protein. If the ascitic fluid protein is more than or equal to 2.5 grams per deciliter, then we will think of cardiac cause. If it is less than 2.5 grams per deciliter, then we would think of cirrhosis as the cause. Okay, so we will try to reconstitute. So I hope you have answered it right based on your idea of SAG score, right? If it is more than 1.1, it is clearly portal hypertension. And if it is less than 1.1, it is no portal hypertension. I hope you got it right. Please comment down the options. I will reframe the questions as per your options. Okay. I guess this question was there. It was mentioned to me by many students. Gram steel murmur is seen in. Okay. Now I want your clarity. Okay, Anisha Ashraf, I'm noting it down. I will reconstitute and share it. Okay. So I need your clarification. Was there option of pulmonary regurgitation and pulmonary hypertension, or both the options were there, or only one of them was given? Okay, so let me be very clear. This Graham-Steele murmur is the name given to the regurgitation murmur of the pulmonic valve. So remember, like what kind of regurgitation murmur I get in the pulmonic regurgitation? Remember, we eject the blood from right ventricle to pulmonary artery during systole. So if I have a pulmonary stenosis, I will have a systolic murmur. And after systole, I close it. And if I have failed to close, then the blood may regurgitate back. So I will have a diastolic murmur if I have pulmonary regurgitation. So gram steel murmur is nothing but the murmur of pulmonic regurgitation. It is the murmur of PR, murmur of pulmonic regurgitation. Okay, so if pulmonic regurgitation was option was there, of course, that is the correct answer. Okay, so what all was mentioned? Patient had water hammer pulse. What else was mentioned? Hyperthyroidism. And then they had also mentioned gram steel. That's what you're saying? Or there was another question on the valvular heart disease. Okay, see, why am I asking about pulmonic regurgitation and pulmonary hypertension? The most common cause for pulmonic regurgitation is pulmonary hypertension. Why? Because once I develop the pulmonary hypertension, that means pulmonary artery pressure is high. So to compensate for that, we will eventually develop the right ventricular hypertrophy. As I develop right ventricular hypertrophy, the right ventricular need for blood supply increases when I fail to give it, right? The right ventricle will start dilating. So right ventricle will eventually dilate in response to pulmonary hypertension. And once it dilates, right, it will stretch the pulmonary artery. Similarly, even pulmonary hypertension itself causes the pulmonary artery dilatation. That will also stretch the pulmonary valve, and that can cause the regurgitation. So pulmonary hypertension is the most common cause for pulmonic regurgitation, and indirectly that can become a reason for gram steel. So if pulmonary hypertension is not mentioned, our answer is very clear. It is pulmonary regurgitation. But if PR was not in the option, then you should have gone with the pulmonary hypertension as the option. Okay, so good. Then it is very straightforward, pulmonary regurgitation. And I want to reiterate one important statement here. All the named murmurs, whatever is the murmur, if it has a name, it has to be a diastolic murmur. All the named murmurs are diastolic murmurs, like gram steel murmur, Austin Flint murmur. So again, we should think of what condition is likely to cause diastolic murmur. Pulmonic stenosis will cause systolic murmur, VSD will cause systolic murmur. So this was the only option which will cause diastolic murmur. Even that way, you could have reached the answer. Khadim Hussain, water hammer pulse. Okay, so there was another question with water hammer pulse. So let me write it down. Can you help me with the stem? So there was a question on water hammer pulse, right? Okay, so what are the story here? Patient has water hammer pulse. It was clearly mentioned that patient has water hammer pulse. What other features were mentioned? Water hammer pulse was the only information we had, or something else was mentioned? Because if you say water hammer pulse was the only information we had, and we had two options, aortic regurgitation as well as hyperthyroidism, then both of them are correct. Because water hammer pulse is not specific to aortic regurgitation. Remember, water hammer pulse is suggestive of wide pulse pressure. Wide pulse pressure. And what do I mean by wide pulse pressure? The difference between systolic and pulse pressure is equal to systolic BP minus diastolic BP. So anything that increases systolic BP or decreases diastolic BP will make the pulse pressure wider, right? So in aortic regurgitation, what happens? In aortic regurgitation, systolic BP increases, diastolic decreases, the pulse pressure becomes wide. That can give rise to water hammer pulse. What happens in hyperthyroidism? In hyperthyroidism, diastolic remains same, systolic increases, again the pulse pressure becomes wide. In both cases, we can see water hammer pulse. Okay, so then it is very, very clear, right? So if there is history of RHD mentioned, right? Water hammer pulse plus history of rheumatic heart disease plus pulse, plus you're saying that there was a pistol shot femoralis mentioned, right? Pistol shot femoralis mentioned. So if all of that is mentioned, it is clearly a case of aortic regurgitation. And I'm sure if you have done valvular heart diseases decently, superficially also, you should be able to get this question right. So in that case, the answer for this question would be aortic regurgitation. Good. Okay, so what was the question on hypertrophic cardiomyopathy, Ria? What was the question on hypertrophic cardiomyopathy? Okay, so I will take up the hypertrophic cardiomyopathy once you write down the stem and the options. Meanwhile, can anybody help me to construct this question where there's a patient with hemodynamic instability and irregular RR. So there was some question related to atrial fibrillation. Like, was it an image-based question? Like there was an ECG given, or just the story where they mentioned that the RR interval is irregular? What was it? Was it like an ECG-based question where you have to make a diagnosis of what it is? Okay, so Kadim, what other features were mentioned? So remember, there are few things. If the question is talking about acute rheumatic fever, in acute rheumatic fever, we will have predominantly regurgitant lesions. What is the most common manifestation? Mitral regurgitation. Second most manifestation is aortic regurgitation. So was there any other clue to think of mitral regurgitation in the question? Any other symptom was mentioned? Because it is a little unusual to have AR without MR. Usually what happens in acute rheumatic fever, MR is the most common manifestation, followed by AR. Majority of the cases, it will be like MR plus AR. Isolated AR is relatively less common. Okay, so just the story and the management, right? So if that mentioned irregular RR and absent P waves, then we clearly know that this is a story of atrial fibrillation and patient is unstable. So I guess either they have used the word unstable or they have mentioned that BP is less than 90/60. Was it there, or they had mentioned that patient is stable? Because that will make the difference to how we manage. So one option, yes, as you quoted, amiodarone would come into picture for sure. I guess there would also be an option of cardioversion, if my guess is right. So now tell me. Okay, so there was one more choice, verapamil. Okay, what else was there? Okay, so there was cardioversion, right, in the options. Adenosine, good. Okay. So now if this is how the question was there, what would you choose as the answer? Remember here, the patient is unstable. So what is the rule of management of arrhythmias? Unstable patient. Go-to treatment is shock. Pharmacotherapy comes into picture only if the patient is stable. If the patient is unstable, we do not jump to give medications. If unstable patient, we go for shock. Yeah, so this question was about treatment. Okay, can anybody confirm, was there an option of cardioversion? Because if it is clearly mentioned that patient is unstable, then we shouldn't be going for drugs. The answer should be cardioversion. If I just flip it and say patient is stable. Okay, so if cardioversion was an option, that should be the correct answer. So learning message is any patient with arrhythmia, whether it is VT, whether it is atrial fibrillation, whether it is PSVT, whatever is the arrhythmia, BP is low, shock. What type of shock? Supraventricular arrhythmias, it is always cardioversion. If it is pulseless VT or ventricular fibrillation, defibrillation, right? As simple as that. Okay, see, the answer changes the moment you say that the patient was stable, the answer will become amiodarone. It is the preferred treatment for atrial fibrillation. And again, if you say, sir, there was also mentioned that there was some contraindication for amiodarone, like an ongoing thyroid storm or thyroid illness or something like that, then again, the answer will change to verapamil. Verapamil is not the preferred treatment. It is the second best drug, I would say, among the drugs listed here, if you are going for pharmacotherapy. But if the patient is unstable, cardioversion would be the answer. Okay. So now can anybody help me with the next question? There was a question on AV blocks. That's what I heard from the students. Most of the students said. So Kadim Hussain, what was the pointer for you to think that there was also an MR involved in that question? So in this question, the BP was mentioned as 80/60. Good. So if it was mentioned 80/60, then it's all the more cardioversion is the right answer. Okay. So what was the question on AV blocks? Was it for diagnosis or was it for management? And was it ECG based or description based? Adenosine is not preferred for atrial fibrillation. Adenosine is preferred for the PSVT. Okay, so what was the question on AV blocks? See, remember, I think I've repeatedly told you when it comes to ECGs, the two most important topics that you should not miss are AV blocks and arrhythmias. If you've done that, mostly it's sorted. So, Uduman Maidin, can you help me? What was it? Okay, so let me, Prakash Soni is sharing me a clear stem. So let me write it for you. So first degree AV block. One option was normal PR interval. Second option was normal RR interval. Third option was normal heart rate. Okay, so this was a very simple question, right? Nothing confusing here. Prolonged PR interval. So how do we make a diagnosis of first degree heart block? Of course, based on the prolonged PR interval. What is the normal PR interval? Normal PR interval is 120 to 200 milliseconds. Normal PR interval is 120 to 200 milliseconds. So when it is more than 200 milliseconds, we will call it as prolonged PR. And whenever the PR is prolonged, right? Prolonged PR with no missed QRS. Prolonged PR with no missed QRS, we make a diagnosis of first degree AV block. If there are missed QRS, it has to be higher than first degree. It can be second degree or third degree. And within second degree, if there is serial prolongation of PR interval and then an intermittently appearing missed QRS after a serial prolongation, then we will call it as Mobitz type 1. If PR interval is constant, but still there are intermittently missed QRS, we will call it as Mobitz type 2. In the third degree, there is AV dissociation. There is no relationship between P waves and QRS complexes. Okay, so I think this question was sorted. Was there another question on the Mobitz type 1? Was there another question on the Mobitz type 1? Serial prolongation of PR interval with an intermittently missed QRS? Or it was just one question on the AV blocks? So if whatever Prakash Soni has shared me, according to that, the answer should be, of course, prolonged PR interval. Okay. Now there was a question on JVP. Okay, so Kadim Hussain, patient is having dyspnea on exertion, parasternal heave, and right axis deviation. Was there any mention of right ventricular hypertrophy also? And no systolic murmur. So story as of now is leaning towards pulmonary hypertension. Was there any mention of loud P2 or palpable P2? Just to ensure that we were talking about pulmonary hypertension in that question. And then the story is, if the story is acute, I would think of pulmonary embolism. If the story is chronic, I would think of pulmonary hypertension. Okay, so Kadin, if the pulmonary hypertension was an option and there was no pulmonary embolism mentioned, then you're perfectly right to go ahead with the diagnosis of pulmonary hypertension. Okay, so STEM is straightforward. I will write it down and share it in the PDF. Okay, so there was a question on JVP. I was expecting more complex or difficult question on JVP this time because every time the bar on JVP questions kept rising. So this time I was expecting an image-based question, but thankfully there was an easy question. The question shared to me by students is that A wave is due to, I think all of us know that A wave is due to atrial contraction. Because in the past, they were asking questions like A wave corresponds with which phase of cardiac cycle, right? If that was the scenario, then the answer is A wave correlates with the active filling phase of cardiac cycle. Anyway, they have not asked it. The answer is very simple and straightforward, atrial contraction. Okay. Now, was there a question on mid-diastolic murmur? One student told me that, sir, there was a question on mid-diastolic murmur, but I'm not able to recall. Samar Pratap Singh, good for all of us because we have a very simple, straightforward JVP question. I think everyone should have answered it right, and I hope that all of us are going to get 1 mark. So, was there a question on mid-diastolic murmur? And if so, what was the question? Like, was it a story of patient having some symptoms and then mid-diastolic murmur heard in some particular area and then asking what is the diagnosis? Or it is like which of the following condition is associated with mid-diastolic murmur? So can anyone help me with this STEM? Okay, so Khadim Hussain, there was one more question on AV. Okay, so can you frame that question on the AV blocks? So frame that question. I will definitely take it up. Samar Pratap Singh, yeah. So that was a pretty straightforward question, right? Gram scale murmur is nothing but a name given to the murmur of PR. So I think you have got it right. So if you share the question on mid-diastolic murmur, I will address it. Of course, the gram scale murmur is the early diastolic murmur. It's not the mid-diastolic murmur. AR and PR cause early diastolic murmur. Mid-diastolic murmur, we are going to get in mitral stenosis and tricuspid stenosis. So if that was a clinical stem, then based on the symptoms, whether it is right-sided symptoms or left-sided symptoms, we would have differentiated between tricuspid or mitral. Okay. So there was a question on Conn syndrome. Can you help me to construct the stem? Like, were they asking which of the following is seen in Conn syndrome or which of the following is not seen in Conn syndrome? Because these are the three options I got from the students: hypokalemia, sodium loss, metabolic alkalosis. Okay, so Samar Pratap, that's sorted. So can you help me with this Conn syndrome question? These are the three options I got from the students. So let me know where this is the exact option. So Raghav Sharma, see, remember, all the named murmurs are diastolic murmurs. Now, VSD murmur is diastolic? No, it is systolic. Ventricle contracts. See, what is VSD? A gap between the interventricular septum, between two ventricles. When ventricle contracts so that the blood moves from one chamber to other during systole. So you will have a systolic murmur. And remember this always, all named murmurs are diastolic. Okay, so if these were the options, then what was the question asking you? Which of the following is seen in Conn syndrome or not seen in Conn syndrome? If these were options, then it should be not seen in Conn syndrome. Okay, so what is Conn syndrome? Conn syndrome refers to primary hyperaldosteronism. What does that mean? Increased aldosterone levels. As a primary condition, the pathology is in the adrenal glands. What is the most common cause? The aldosterone producing adrenal adenoma, which is producing aldosterone. Now, what this excess aldosterone will cause? The excess aldosterone at the level of kidneys, it will make you reabsorb more sodium and water, right? Sodium and water reabsorption at the expense of, in exchange, what do we lose? We lose potassium and H plus ions. We lose potassium and H plus ions. So what is the outcome of this? Increased sodium and water reabsorption will increase the extracellular compartment or the blood volume that will cause hypertension. So we know that Conn syndrome is one of the causes for resistant hypertension. Okay. Now, sodium I'm gaining, I'm not losing. So that can't be the finding that we get in Conn syndrome. But because I'm losing potassium, I will definitely develop hypokalemia. And I'm losing H plus. So when I'm losing H plus, what am I losing? I'm losing acid. So when I lose acid, what will happen to the acid-base balance? See, there is base, which is bicarbonate, and H plus, which is acid. So if I lose acid, now bicarbonate supersedes. So I end up developing alkalosis. What kind of alkalosis? Metabolic alkalosis. So this is also seen. Sodium loss is not seen in Conn syndrome. So in this question, if they're asking which of the following is not seen in Conn syndrome, given these three options, sodium loss should be the right answer. Sodium loss should be the right answer. Okay. So another question, X-ray was given and patient is having mitral regurgitation and Cons was one of the option. So you are saying acute ARDS was also option. Okay. So Kadim, can you just reframe what was the question? Like X-ray is given, patient is having MR. Right? That is the story. And you're saying that there was acute ARDS as a differential diagnosis and pulmonary edema as a differential diagnosis. Okay, so that's a pretty simple question, right? So if you are having a case of acute MR, let us say you have a case of acute MR. So what is happening in mitral regurgitation? The blood regurgitates back from the left ventricle to left atrium. And because of that, there is rise in the left atrial pressure. So left atrial pressure increases. So that will result in rise in the pulmonary vein pressure. eventually what will happen? There will be buildup of pressures inside the pulmonary capillaries from which the fluid can leak, and we will end up getting pulmonary edema. So in fact, we suspect acute mitral regurgitation in any patient who presented with pulmonary edema. It is one of the differential diagnoses. It can happen after the massive myocardial infarction or in patients with acute rheumatic fever or infective endocarditis. If they present with pulmonary edema, we do think of acute MR. So good. So if the story is MR, okay, so I think you got the story right. If it is a story of MR and patient then had pulmonary edema features on the X-ray, then it is a case of pulmonary edema. Okay, good. Okay, so we will go with the sodium loss as an answer for the Conn syndrome. And I guess there was one question on the lower motor neuron palsy. So can anybody help me with what is the question on LMN palsy? And I heard that there was also another question on LMN versus UMN facial palsy, or like which of the following is true or false about LMN facial palsy. So if you help me with the question, I will try to come out with the answers. What was the question on LMN palsy? Probably the... Okay, so if it is pediatric, I will leave it to... Okay. Okay, if it is pediatrics, I will leave it to the pediatric faculty. Anyway, this is a standard template asking you to differentiate between the UMN and LMN facial palsy. There are only 2 points you have to remember. The first point is that in UMN palsy, there is sparing of the forehead because of the bilateral UMN innervation. In LMN, forehead is not spared, so full hemifacial weakness will appear in LMN. Second thing you should remember is UMN causes the contralateral facial weakness, LMN lesion causes ipsilateral facial weakness. Okay, so Kadim, I'm going to that question. So there was a question on the interpretation of TFT. So I need little help here for building this stem. What I have heard from the students is the story of smoker, smoking 30 years as Kadim mentioned, and having shortness of breath or respiratory symptoms. And they had given you PFT details, right? So there, as you say, FEV1 was decreased. Okay. Was the set of options similar to what I have written here? COPD, pulmonary fibrosis, ILD, and asthma, or it was different? Was it same or different? Was asthma also in the differential diagnosis? So if only FEV1 is mentioned, all right, I will not be able to make a diagnosis in that case, because we have to always analyze it from the perspective of FEV1 by FVC ratio. Without that, we cannot differentiate whether it is an obstructive disorder or restrictive disorder. And only when we have decided that it is an obstructive disorder, then I can do further tests to differentiate between COPD and asthma. So yeah, I will leave that facial palsy for the pediatric faculty to take up. So there was no mention of FVC, FEV1 by FVC ratio or any of the information in the question. Just decrease FEV1. That's all. Okay, so then it is relatively simplified, not the perfect question to construct by the board. But if you're saying that FEV1 by FVC ratio was not available to me, only decreased FEV1 was available with a history of smoking, right? I would go ahead with COPD as the diagnosis if asthma is not in the option. Otherwise, we should always remember that just because someone smokes doesn't make him always to have COPD. He may as well develop asthma. So of course, we have to go with FEV1 by FVC ratio and bronchodilator reversibility test. With the limited information available in the question, I think you're right to go ahead with the COPD as the answer with the background history of 30 years of smoking. Okay. So I think that's all I could recollect from the students as of now. Please keep sharing the questions. I will be live watching your comments, and whatever questions come up, I will make a list and we will definitely incorporate in the PDF that we will be sharing in a few days from now. So Dr. Siraj, that's all I had from my side. Of course, medicine recall will have a lot more questions added and a lot of refining will happen. the refined questions, I will try to share it through the PDF. Over to you for the next faculty, Siraj sir. Okay, so guys, till Siraj sir takes over, how do you feel was the medicine? Because whatever I have heard so far, these questions were relatively straightforward. The instinct will generally give you the right answer. There was not much of thought process involved. So Kadim Hussain, you are saying that there was a question on weakness, which started in the lower limb and then appeared in the upper limb, and the description was ascending type of palsy, right? So if that was a story, remember, where do we get ascending type of paralysis? Most commonly in the diffuse peripheral neuropathies like GB syndrome or specific spinal cord pathologies, the compressive myelopathies, where the compression is extramedullary. So either extramedullary spinal cord compression or GB syndrome should cause. So if the story was ascending paralysis and they had mentioned some other clues towards LMN palsy like hyporeflexia or the decreased tone hypotonia, then it is clearly LMN. So Siraj sir, over to you. I'm going to follow through the comments to come out with a better construction of the questions. So just give me a second. Let me ask. Okay, so just now one of the students has shared that there was an ascending paralysis with flaccidity mentioned. So then, of course, it is a polyneuropathy condition. And given the story of acuity, I would have gone ahead with GB syndrome. Or if the story is mentioning GB syndrome and they're asking whether it is LMN, UMN, then you know it is LMN. Okay, so just let us wait for Siraj sir to take over. Okay, I think Siraj sir is occupied. Let me see who is the next faculty lined up. So Dr. Sandeep. Dr. Sandeep, if you are able to hear me, you can take over from me. So Kadim Muslim, good. Because see, even if asthma was there, if you mentioned COPD, I would say I would give you the marks, because given the story of 30 years of smoking, COPD becomes more likely than asthma. Both absolutely cannot be differentiated without the bronchodilator reversibility test. But if you ask me what is the first preferred diagnosis and what is the second preferred, then I would of course say first is COPD, second is asthma. So if you're choosing COPD, you're still right. Ajil, ascending need not always be mentioned. They may mention the progression of symptoms, saying that first there was weakness in the lower limb and then it progressed to involve the other limbs. That's more than enough to say it is a case of ascending paralysis. Okay, so do we have Dr. Sandeep online here? So guys, I'm just waiting for Dr. Sandeep to join. So he will take you through surgery questions. I guess surgery questions were a bit image-based and slightly more trickier than medicine. Medicine was mostly straightforward. Yes, sir, over to you. Sir, you are able to hear me? Over to you, sir.
Hi guys. Raji sir, am I audible?
Yes, sir. Yes, sir.
All right. So let's start with the pharmacology recall. And I'm having roughly around 24 questions, around 22 to 24 question, right? And let us see what all question that we have. So since this is going to be a recall session, and I'll be looking for your messages as well. We'll see. अगर कहीं पे भी आपको लगे कि ये क्वेश्चन का लैंग्वेज अलग था और this needs some rectification, please feel free to intervene and feel free to message. So there was this question about a patient, which of the following anti-cancer therapy, a patient with the anti-cancer therapy, right? A patient on anti-cancer therapy was given bleomycin. Its side effect is noted at this system. तो bleomycin therapy के बाद which side effect will get affected? So we already know bleomycin, याद है कीमोमैन में मैंने आपको ड्रॉ करके दिया था bleomycin busulfan. So that will be causing mainly pulmonary fibrosis. And since this is causing pulmonary fibrosis, ध्यान रखिएगा, the drug, I mean the system that will be affected pulmonary. Now next exam का मैं हमेशा बताता हूँ, examiner का mindset समझिएगा, अगले exam का potential MCQ होगा कि to prevent this pulmonary fibrosis क्या होगा. तो मान लीजिए हमारे जो जुलाई में एक क्वेश्चन आ सकता है, we can give drug like your perfenidone. That is the next potential MCQ that we have. Perfenidone, right? Or nintedanib. Nintedanib is the other drug that we can actually utilize. Nintedanib is the other drug that we can utilize actually, right? So these are the question, question number 1 that we are having here. Now, in a person with mountain sickness, so there was a history of mountain sickness. A drug was given. What is the site of action of this drug? So we see here there is multiple site, that is going to be site number A. Then we have site number B, site number C, site number D. नंबर कहीं पे भी हो सकता है. अगर माउंटेन सिकनेस की बात आएगी तो we always give a carbonic anhydrase inhibitor by the name of acetazolamide. And acetazolamide कहाँ पे काम करेगा? तो you already know they will be acting at the proximal convoluted tubule. Proximal convoluted tubule A side पे है. I mean this is the proximal convoluted tubule site, right? This area is known as your proximal convoluted tubule और यहाँ पे काम करेगा, right? Making sense to all of you? So this question also, I think most of the pharma question I saw is easily doable, and we did this also in our Sankalp batch here in the in the review session as well. Which of the following is not given in hypertensive emergency? Not given in hypertensive emergency, we already know that PRIL is the one that is not given. Always remember that we always need to avoid a DNB college. मैंने बताया था कि pregnancy में patient आती है तो कहाँ भेजोगे? Always send to Lady Harding Medical College. That is going to be labetalol, that is going to be safe. Hydralazine, that is one of the potassium channel opener, right? Methyl dopa, alpha methyl dopa, and calcium channel blocker कौन सा? Dipines वाले safe होते हैं. Cardioselective beta blocker is also going to be safe. But avoid DNB में always say ACE inhibitor ARB. ACE inhibitor ARB. अगर कभी भी आपने क्लास किया होगा, definitely you will never miss this one. ACE inhibitor ARB should not be utilized. D said diuretic should also not be utilized. And then sodium nitroprusside is something that is also going to be avoided, and non-DHP. Non-DHPs. Do remember that beta blocker में non-selective beta blocker should not be selected. Again, इसी topic से अगले exam का potential MCQ आपके लिए तैयार हो रहा है, तो why not utilize this particular event, and इससे आप अगले topic को clearly तैयार करते चलो. Among these, the only answer that is going to be used D, that is lisinopril. Okay. Next, a patient on anti-epileptic therapy, gingival hyperplasia. I mean, gingival hyperplasia बार-बार बताते हैं हम लोग. Gingival hyperplasia will be caused by mainly cyclosporin, और anti-epileptic drug है तो यहाँ पे there will be none other than your phenytoin, right? Carbamazepine इसी क्वेश्चन से अगले एग्जाम का क्वेश्चन आएगा. पेशेंट वाज गिवन एंड द पेशेंट हैज डेवलप्ड लेट्स से बोन मैरो सप्रेशन, द पेशेंट हैज डेवलप्ड लेट्स से एक्सेसिव एडीएस सिक्रीशन. इस तरह के क्वेश्चन आएंगे. कार्बामाजेपिन, ऑक्सकार्बाजेपिन हो सकता है. वैल्प्रोरेट रिलेटेड हेपाटोटॉक्सिटी. सो ट्राई टू सी कि अगले एग्जाम में क्या पोटेंशियल एमसीक्यू आएंगे, वो यहीं से पता चलेगा. प्रीवियस ईयर टॉपिक से ही पता चलता है. A patient on multi-drug therapy for leprosy was given. I think this was also done in dermatology. So I think इसको कई लोग बोलेंगे डर्मा भी, माइक्रो भी बोल सकता है, फार्मा भी बोल सकता है, मेडिसिन भी बोल सकता है. So we already know multi-drug therapy में we utilize rifampicin. Rifampicin we give 600 milligram per month. Right, on the day 1 we always give these drugs. On day 1 we are going to give these drugs, rifampicin 600 milligram और साथ में clofazimine हम इसका आधा देते हैं, that is 300 milligram on the monthly basis. This is actually going to be supervised dose. And dapsone हमेशा start करते हैं on the day 1, that is 100 milligram on the daily basis. From the day 2 onwards we will continue dapsone. Dapsone will continue 100 milligram on the day 2. राइट, डेप्सोन कंटिन्यू रहेगा, और उसके अलावा हम क्लोफाजिमीन जो है 50 मिलीग्राम ऑन द डेली बेसिस करते रहेंगे, राइट, देते रहेंगे. दिस विल बी कंटिन्यूड फॉर पॉसिबेसिलरी 6 मंथ, मल्टीबेसिलरी के लिए 12 मंथ के लिए. अमंग द गिवन चॉइसेस, व्हाट इज नॉट गिवन, विच ऑफ द फॉलोइंग इज इनकरेक्ट? सो रिमेंबर दैट रिफाम्पिसिन 450 कभी नहीं देते ना, वी डू नॉट गिव 450 रिफाम्पिसिन, वी गिव 600. नो. Now, this was also something that was covered in medicine, I guess, or it was also covered in your microbiology, that meningitis. Among the given choices, the preferred option is going to be ceftriaxone, which is a 3rd generation cephalosporin. It is going to be a 3rd generation cephalosporin, and vancomycin, that is one of the cell wall inhibitor, that is also going to be one of the drugs that will be preferred in meningitis. All other options like rifampicin, acyclovir, they are simply not correct for this patient. Okay? At any point of question, if you guys feel कि question में कुछ modification चाहिए, तो please feel free to intervene. Let me know if that require any changes. Which of the following anti-TB drug require normal functioning of CAT-G gene? Now इस क्वेश्चन में काफी सारे बच्चों के अलग अलग रेस्पॉन्स आ रहे थे. Now CAT-G gene से रिलेटेड क्वेश्चन जो आया था, ध्यान रखिएगा, कैटरीना जी के बारे में मैंने बताया था. कैटरीना जी को आइस पसंद है, राइट? सो अगेन CAT-G gene will actually encode, CAT-G gene actually is going to encode, that is catalase peroxidase. CAT-G gene catalase peroxidase, and this catalase peroxidase, always remember, it causes activation of isoniazid. So the correct answer for this one is going to be isoniazid. ठीक है? Correct answer is going to be your isoniazid. Correct answer for this one is isoniazid. सर्विक्स कार्सिनोमा के लिए अगर क्वेश्चन पूछता है सर्वाइकल कार्सिनोमा के लिए, तो ड्रग ऑफ चॉइस दैट इज गोइंग टू बी सिस्प्लाटिन. मल्टीपल टाइम रिपीटेड क्वेश्चन है, अगर ये क्वेश्चन आया है तो दैट इज गोइंग टू बी द करेक्ट आंसर. सिस्प्लाटिन इज द ड्रग ऑफ चॉइस फॉर सर्वाइकल कार्सिनोमा. Now, which of the following agent can be used to reduce the cardiovascular mortality? So again, anti-diabetic drug. ये क्वेश्चन के अलग अलग लैंग्वेज कई सारे स्टूडेंट बताए हैं. अगेन अगर आपको लग रहा है लैंग्वेज कुछ अलग था, तो प्लीज लेट मी नो that which of the following agent can be used to reduce the cardiovascular mortality. ध्यान रखिएगा कि डायबिटिक पेशेंट विद कंजेस्टिव हार्ट फेलियर, अगर ऐसा हिस्ट्री था, डायबिटिक पेशेंट विद द कंजेस्टिव हार्ट फेलियर, कौन सा ड्रग होगा? तो ध्यान रखिएगा, मैंने बताया था 4-पैक एप्स वाला, उसमें एस से SGLT2 इनहिबिटर, दैट इज गोइंग टू बी योर एम्पाग्लिफ्लोजिन, डापाग्लिफ्लोजिन, कानाग्लिफ्लोजिन. So these are the gliflozin वाले drugs that will actually be utilized in this case scenario. Gliflozin वाले drugs, right? ठीक है? The drug that is mainly going to be utilized, मैं आप लोग के ऑप्शन नहीं देख पा रहा हूँ. सिस्प्लाटिन was not alone given. Okay, so सिस्प्लाटिन अगर नहीं दिया था इस वाले क्वेश्चन में सर्वाइकल कार्सिनोमा के लिए, तो ऑप्शन में जो भी था आप बताइए. What are the other option that is given? Other options बताइए, then we can definitely comment on that. ठीक है? डॉक्टर मोनिका चौधरी, प्लीज लेट मी नो. ठीक है? नाउ नेक्स्ट क्वेश्चन देख लेते हैं. A patient consumed 5 tablets of paracetamol. He was given N-acetylcysteine treatment. Mechanism of action of N-acetylcysteine. Now N-acetylcysteine is एंटीडोट, ये पहले पूछा. ठीक है? N-acetylcysteine was asked previously. उसके बाद इसमें पूछा क्या करेगा, कैसे इसको ट्रीट करेगा. So they are going to actually replenish the glutathione store, right? Replenish the glutathione store. सिस्प्लाटिन विद कार्बोप्लेटिन क्यों दोगे? देखो सिस्प्लाटिन कार्बोप्लेटिन वाला वो एक अलग क्वेश्चन है. सिस्प्लाटिन कार्बोप्लेटिन इज एक्चुअली द डिफरेंट क्वेश्चन, जिसमें पूछा था कि कंपैरिजन बिटवीन सिस्प्लाटिन एंड कार्बोप्लेटिन विच इज मोर नेफ्रोटॉक्सिक. वो सेम क्वेश्चन नहीं है. ठीक है? N-acetylcysteine वाला सॉर्टेड है. N-acetylcysteine रिमेंबर, जब भी पैरासिटामोल देते हैं तो देयर इज अ माइक्रोसोमल एंजाइम CYP2E1, दे विल बी कॉजिंग टॉक्सिक मेटाबोलाइट NAPQI दैट इज गोइंग टू कॉज फुलमिनेंट हेपेटाइटिस, फुलमिनेंट हेपेटिक फेलियर. सो इसको ही जो है कि मेटाबोलाइज करने के लिए वी आर एक्चुअली गोइंग टू गिव N-acetylcysteine. N-acetylcysteine will replenish the glutathione store. They are going to replenish the glutathione store. So this will be inactivated. NAPQI will be inactivated. ठीक है? 2 was there in options. ठीक है? एक बार ऑप्शंस बताइएगा, then we can comment on that. And this was the question that maybe you are talking, cisplatin versus carboplatin. Cisplatin versus carboplatin जो आप बोल रहे थे, तो cisplatin is more nephrotoxic, right? Compared to carboplatin, cisplatin is more nephrotoxic. So there was a question that a patient of a patient was given, let's say cisplatin versus carboplatin, which of the following is correct? So ध्यान रखिएगा, cisplatin का ज्यादा नेफ्रोटॉक्सिक इवेंट होता है ना. अपकमिंग एग्जाम का यहीं से MCQ डिराइव होता है. टू प्रिवेंट दिस नेफ्रोटॉक्सिक इवेंट हम क्या करेंगे? टू प्रिवेंट दिस नेफ्रोटॉक्सिक इवेंट वी कैन एक्चुअली यूज एमीफॉस्टिन. तो अगेन ये भी कहां से हमारे शुरू होता है? ये भी हमारे कीमोमैन से ही सॉल्व होता है. कीमोमैन में हमने इसको डिस्कस किया था, राइट? We can easily get this one as well. Preferred management for cryptococcal meningitis. Now see, single base drug अगर आपको select करना है cryptococcal meningitis के लिए, तो we can utilize liposomal amphotericin B. But many students give different kind of recall. Now as per the recall that we got, there were combination of drugs. So among the given choices that we have, which one is more preferred? अगर preferred पूछ रहा है, we will be using liposomal amphotericin B with flucytosine. 5-flucytosine is a DNA RNA inhibitor that is going to be the more preferred in this case of cryptococcal meningitis. मेलिग्नेंट हाइपरथर्मिया वाला आई थिंक एनेस्थीसिया में भी कवर होगा, और आपको आई थिंक फिजियो में भी कवर हुआ होगा या मेडिसिन में भी कवर हुआ होगा, डेंट्रोलिन. नाउ दिस वाज अ क्वेश्चन दैट वाज गिवन इन अ वेरी डिफरेंट पैटर्न की पेशेंट को कुछ सर्जरी के बाद से उसको है ना एक ब्लैंकेट उड़ा के रखा था, देन हटा दिया, देन उसमें कुछ शिवरिंग होने लगा, ऐसे करके बच्चे बता रहे थे. एंड वी वर नॉट एबल टू गेट एक्चुअली है ना कि क्या एग्जैक्ट लैंग्वेज था, लेकिन बच्चे बोल रहे थे सर इट वाज एक्चुअली पॉइंटिंग टुवर्ड्स मैलिग्नेंट हाइपरथर्मिया. तो आई थिंक डेंट्रोलिन सोडियम इज द करेक्ट वन. ठीक है? cis is more nephrotoxic than carb was no. तो cis is more nephrotoxic. Cisplatin is more nephrotoxic. In that case scenario अगर आपको पता चल गया तो cisplatin is more nephrotoxic. That is the correct one then, right? वो correct हो गया फिर. Now एक osteoporosis patient को zoledronate दिया. Zoledronate, that is one of the bisphosphonate. It is one of the BPN, that is bisphosphonate therapy, right? And he was asked to maintain the upright posture. Upright posture इसलिए because they are always having risk of causing esophagitis. To reduce the risk of esophagitis or to reduce the risk of GERD, we always ask the patient to maintain upright posture. तो मैंने क्लास में आपको बताया होगा कि drink entire glass of water. Take the medicine with entire glass of water and maintain upright posture. तो हम लोग बोलते भी हैं ओपीडी में अगर पेशेंट को देते हैं कि टेक द मेडिसिन एंड गो फॉर अ मॉर्निंग वॉक. लेट्स से यू आर टेकिंग इट वीकली बेसिस ऑन संडे, सो संडे को टेक द मेडिसिन, गो फॉर वॉक, डोंट सिट, डोंट लाई डाउन, राइट? दोनों ही नहीं करना है, ठीक है? सक्सिनिलकोलिन अगर दिया गया तो डेफिनेटली दैट वाज अ केस ऑफ मैलिग्नेंट हाइपरथर्मिया, राइट? तो सक्सिनिलकोलिन एक्सपोजर है तो definitely they are pointing towards malignant hyperthermia. Again, if you have understood already, you will be able to get the answer easily. Succinylcholine is having maximum risk of, it is the one drug that is having maximum risk of causing malignant hyperthermia. लेकिन अगर inhalational route पूछे, which inhalational drug is causing malignant hyperthermia, ध्यान रखिएगा इसका जवाब हेलोथेन होता है. Now हेलोथेन हो या succinylcholine हो, दोनों ही कंडीशन में ड्रग ऑफ चॉइस इज गोइंग टू बी सेम, दैट इज नाइट्रोलिन सोडियम. ठीक है? CKD patient with diabetes. Now there were two question actually. कई बार बच्चे बता रहे थे मेडिसिन वाले में भी और इसमें भी. There were two question. Diabetes patient with the CKD. Which of the following DPP4 inhibitor? अगर आपको ये पता है तो बताया भी क्या, और ये प्रीवियस ईयर क्वेश्चन, अगर ये एग्जैक्टली यही क्वेश्चन था तो पहले भी आ चुका है कि लीनाग्लिप्तिन को लीवर से एक्सक्रीट कराते हैं तो लीना को ले सकते हैं रीनल फेलियर में. लीनाग्लिप्तिन इज द वन DPP4 inhibitor that is going to be safer in the renal failure patient. लीना को लीवर फेलियर में नहीं लेना है, लीना को लीवर फेलियर में नहीं लेना है. Now this was a question. Many students are saying enzyme inducer था, but मैंने पर्सनली कई बच्चों से बात किया, वो एंजाइम इंड्यूसर वाला क्वेश्चन इस बार नहीं आया था. बिकॉज ऑलवेज रिमेंबर, जब हम टीबी की बात करते हैं तो वी यूज्ड टू गिव HRZE, पायराजिनामाइड, इथम्बिटोल, रिफाम्पिसिन, राइट? तो रिफाम्पिसिन इज अ पोटेंट एंजाइम इंड्यूसर. स्टूडेंट्स क्लियरली क्लैरिफाइड कि सर एंजाइम इंडक्शन वाला नहीं था. सो द कंडीशन वर्सेंड एंड द डिटोरिएशन ऑफ द सिम्टम गिवन, वर्सेंड मतलब उसमें द डिटोरिएशन ऑफ द सिम्टम गिवन, दैट इज व्हाट द स्टूडेंट सेड. सर सिम्टम दिया था कि और टीबी का सिम्टम वर्सन हो गया, तो किस वजह से, व्हाट इज द रीजन? सो इम्यून रिकॉन्स्टिट्यूशन इन्फ्लेमेटरी सिंड्रोम. आई पर्सनली लुक्ड फॉर दिस क्वेश्चन. मुझे लगा पहले नजर में देखते ही कि ये ट्रीटमेंट फेलियर, बिकॉज याद है मैंने बताया था आपको एंजाइम इंड्यूस करके फेल कर देगा. इंड्यूस नहीं होना है, सख्ती के साथ रहना है, राइट? बट दिस वाज नॉट दैट क्वेश्चन, इट इज आयरिस सिंड्रोम. इसीलिए टू प्रिवेंट आयरिस सिंड्रोम मैं बार बार पहले आपको बता चुका हूं कि यू हैव टू स्टार्ट ATT एटलीस्ट 2 वीक प्रायर टू ART. लेकिन इस पेशेंट को जो हिस्ट्री दिया हुआ था, द पेशेंट वाज स्टार्टेड ऑन ART, पहले ही ART दे दिया गया, राइट? रिमेंबर दैट. ठीक है? Immune reconstitution inflammatory syndrome. So that is the correct one. Anyone who have marked this one is the correct one. Diabetes patient on metformin therapy. Now this is very questionable. I am putting a question mark itself because कई सारे बच्चे बोल रहे थे सर ये क्वेश्चन आया था, कई सारे बच्चे बोल रहे थे नहीं आया था. अगर आपको लग रहा है कि मेटफॉर्मिन थेरापी 500 मिलीग्राम ले रहा है, HbA1c अभी भी और GFR लेवल इज लेस देन 30, नेक्स्ट स्टेप इन मैनेजमेंट. ध्यान रखिएगा मेटफॉर्मिन को हम हमेशा, if the EGFR level is more than 45, then only metformin is going to be allowed. अगर EGFR level less than 30 है, we should not use this. अगर ये क्वेश्चन आया था तो क्या ये इसी लैंग्वेज में था? और we will be giving other ड्रग, हम दूसरे ड्रग देंगे, शिफ्ट टू एनी अदर ड्रग, बट मेटफॉर्मिन को स्टॉप करना ही होगा. यू हैव टू स्टॉप मेटफॉर्मिन. सो अगेन आई एम पुटिंग अ क्वेश्चन मार्क, इफ यू कैन सी हियर, बिकॉज है ना, पहले डिस्क्लेमर डाल दे रहा हूँ बिकॉज इसमें अलग अलग बच्चों के अलग अलग चीज थियरी आया था, अलग अलग बच्चों के अलग अलग इसके व्यूज हैं. कई सारे बच्चे दो क्वेश्चन को मिक्स कर दिए थे, तो इसलिए मैंने पहले इसमें डिस्क्लेमर लगा दिया कि ये क्वेश्चन अगर आया था एंड इफ द क्वेश्चन वाज लाइक दिस कि 500 मेटफॉर्मिन ले रहा है, इंक्रीज द डोज टू 1000, दैट इज अनदर ऑप्शन. HbA1c 7.5 अभी भी है, GFR लेवल इज लेस देन 30. अगर ये है तो हमेशा ध्यान रखिए मेटफॉर्मिन के डोज बढ़ाना. क्या मेटफॉर्मिन अगर स्टॉप वाला ऑप्शन है तो स्टॉप मेटफॉर्मिन, शिफ्ट टू अनदर ड्रग, है ना. यू हैव टू शिफ्ट टू अनदर ड्रग, शिफ्ट टू अदर एंटी डायबिटिक ड्रग. ठीक है, शिफ्ट टू अदर ड्रग. ठीक है, ध्यान रखिएगा. नेक्स्ट आयोडीन 131, रेडियोएक्टिव आयोडीन, ध्यान रखिएगा, इट विल बी कॉजिंग हाइपोथायरॉयडिज्म. हाइपोथायरॉयडिज्म इज समथिंग दैट इज, है ना, GFR नॉट मेंशन, अगर GFR नहीं था तो फिर अगर पूछ रहा था अनकंट्रोल्ड है, and if GFR was not mentioned, then we can increase the dose to 1000. अगर GFR मेंशन नहीं था, then we can increase the dose to 1000. ठीक है। नॉरएड्रेनालिन इफेक्ट, नॉरएड्रेनालिन ध्यान रखिएगा बीपी को बढ़ाएगा एंड दे विल बी लीडिंग टू रिफ्लेक्स ब्रेडिकार्डिया। बीपी इंक्रीज हार्ट रेट डिक्रीज, बीपी इंक्रीज हार्ट रेट डिक्रीज, बार बार मैंने बताया भी है, बार बार आपको इमेज भी इसका ड्रॉ करके दिखाया कि आइदर दे विल बी गिविंग यू इमेज और दे विल बी गिविंग द डायरेक्ट क्वेश्चन और उसमें पूछेंगे आपसे, राइट। डायरेक्टली दे विल बी आस्किंग द क्वेश्चन एंड दिस टाइम दे, लास्ट टाइम दे गिव द ग्राफ ना, तो ग्राफ में उसमें दिखाया था कि एक्चुअली बीपी बढ़ा हुआ है। लास्ट टाइम व्हाट दे सेड कि ये आपका मान लीजिए सिस्टोलिक ब्लड प्रेशर है और ये मान लीजिए आपका डायस्टोलिक ब्लड प्रेशर है और ऐसे करके हार्ट रेट वाज डिक्रीज। तो अगेन दिस इज आल्सो गोइंग टू बी योर नॉरएड्रेनालिन। ये अगेन नेक्स्ट पोटेंशियल एमसीक्यू हो सकता है आप सभी के लिए इसी से, ठीक है। ओके, हेमंत के एक अलग व्यू है। मेटफॉर्मिन HbA1c जो है 8.4 से लेकर के नाउ 7.4। तो ऑप्शन में क्या क्या था ये बताइए। स्टॉप मेटफॉर्मिन, स्टॉप तो नहीं करेंगे। अगर अगर GFR नॉर्मल भी है, GFR नॉर्मल है तो स्टॉप नहीं करेंगे। इंक्रीज द डोज बिकॉज इट इज इन द शिफ्टिंग पैटर्न, है ना। तो शिफ्ट टू अदर ड्रग। अदर ऑप्शन फिर बताइए, हो सकता है देन कंटिन्यू द सेम थेरेपी हो सकता है, ये ऑप्शन हो सकता है कंटिन्यू सेम ड्रग। सी एट एवरी टाइम यू सी एंड जो भी आपका वर्जन चेंज होगा, जब आपके क्वेश्चन का वर्जन चेंज होगा आंसर ऑटोमेटिकली चेंज होता जाएगा, राइट। मेटफॉर्मिन 1000 मिलीग्राम, इंक्रीज द डोज टू 1000 मिलीग्राम बिकॉज 8.4 से 7.4 ऑलरेडी हो गया है। अगर दैट मींस डाउनवर्ड पैटर्न पे है देन लुक फॉर अदर ऑप्शन। क्या शिफ्ट टू अदर ड्रग दिया था, करने की जरूरत नहीं है। कंटिन्यू सेम ड्रग अगर है तो वी कैन प्रोसीड विद दैट। प्लीज टेल मी द अदर ऑप्शंस एंड देन वी कैन डेफिनेटली कम अप विद द सॉल्यूशन। जब तक ये 2 क्वेश्चन और देख लेते हैं। ओलांजापिन एटिपिकल एंटीसाइकोटिक बताया था ना, ओ आपको फिगर 0 करा देगा, आलू के जैसा, है ना। ओलांजापिन आलू के जैसा मतलब वेट गेन, राइट। सो दे आर वन ऑफ द एटिपिकल और एटिपिकल साइड इफेक्ट में पिछली बार क्या आया था, जनवरी 2024 में सेम टॉपिक से क्या क्वेश्चन आया था, विच ऑफ द फॉलोइंग विल नॉट कॉज वेट गेन, है ना। अरिशिप्रा को देखा, एरिपिप्राजोल, जिप्रासिडोन, दे विल नॉट कॉज वेट गेन, विच वन विल कॉज, ये इस बार पूछ लिया। तो इसीलिए प्रीवियस ईयर टॉपिक्स हमेशा इंपॉर्टेंट होता है, ध्यान रखिए। कैटरैक्ट विल बी एसोसिएटेड विद द क्यूटियापिन, right. Quetiapine will be causing cataract and dystonia is associated with the typical antipsychotics, ठीक है। तो वेट गेन इज द करेक्ट आंसर। डिलीरियम ट्रेमेंस, आई थिंक आप सभी ने देखा होगा। डिलीरियम ट्रेमेंस उसका डायग्नोसिस पूछा था या उसका ट्रीटमेंट पूछा था, राइट। पेशेंट अल्कोहल का एडिक्ट पेशेंट था एंड ही वाज स्टॉप्ड अल्कोहल और उसको ये सिम्टम डेवलप हो रहा है। अगर ऐसे डायग्नोसिस भी था डिलीरियम ट्रेमेंस उसका होगा। पेशेंट ऑन वारफरिन थेरेपी रिकमेंडेड आया ना, ध्यान रखिएगा। वारफरिन थेरेपी में इन मोस्ट केसेस में ऑलवेज रिमेंबर 2 to 3 रिकमेंडेड आया ना, 2 to 3। अगर मैकेनिकल हार्ट वॉल्व है, इफ देयर इज मैकेनिकल हार्ट वॉल्व, सिर्फ उसी कंडीशन में इसका लेवल हम 2.5 to 3.5 एक्सेप्ट करते हैं। क्या ये क्वेश्चन आया था 2 to 3 वाला, है ना। ये क्वेश्चन आया था, वारफरिन थेरेपी वाला क्वेश्चन भी आया था। Now, a patient with asthma had symptom consistent with the PSVT. अगर PSVT का केस है और आस्थमा है, ध्यान रखिएगा, एडिनोसिन will not be answer. एडिनोसिन itself cause precipitation of bronchial asthma. इसका एक साइड इफेक्ट ही होता है फ्लशिंग और ब्रोंकोकॉन्स्ट्रिक्शन। तो एडिनोसिन तो कभी देंगे ही नहीं ना, है ना। एडिनोसिन नहीं देंगे, हम इसमें वेरापामिल सेलेक्ट करेंगे। तो वेरापामिल इज द ड्रग ऑफ चॉइस फॉर supraventricular tachycardia. Definitely it can also be utilized in PSVT, right? So we will be preferring here PSVT, ठीक है। ठीक है। लेटानोप्रोस का साइड इफेक्ट, लेटानोप्रोस इज वन ऑफ द PGF2 अल्फा एनालॉग। लेटानोप्रोस से PGF2 अल्फा एनालॉग और इसका साइड इफेक्ट भी मैंने यही बताया था, PGF2 अल्फा। सो दैट इज गोइंग टू बी पिगमेंटेशन ऑफ आइरिस। जो भी क्वेश्चन आता है, अगर मैकेनिज्म ऑफ एक्शन आता है तो PGF2 अल्फा एनालॉग, पिगमेंटेशन ऑफ आइरिस। देन G से ग्रोथ ऑफ आईलैशेस, हाइपरट्राइकोसिस जिसको बोलते हैं। देन देयर इज ऑल्सो गोइंग टू फॉरेन बॉडी सेंसेशन, फैट एट्रोफी of orbit. Now fat atrophy of the orbit की वजह से there will be enophthalmos, there is going to be enophthalmos and then there is also going to be acute anterior uveitis, acute uveitis. So I think PGF2 alpha का side effect मैंने आपको बड़ी आसानी से बता दिया। PGF2 alpha का side effect will be remembered by the mnemonic PGF2 alpha, ठीक है। Options amiodarone and cardioversion was there, ठीक है। amiodarone, cardioversion, ठीक है, paroxysmal supraventricular tachycardia में we'll proceed with the verapamil, ठीक है। रेड कंजंक्टिवा फॉरेन बॉडी सेंसेशन की वजह से रेड कंजंक्टिवा हो सकता है ना, ये एक्यूट यूवीआइटिस ये भी हो सकता है, ये भी करा सकता है। तो आई थिंक आप सेलेक्ट कर सकते हैं ऑप्शन में जो भी था, ये सारे साइड इफेक्ट मैंने बता दिया, इसमें से कोई आपका एक डेफिनेटली हो सकता है। यू चूज आउट व्हाट वर द ऑप्शन वर देयर। अगर रेड कंजंक्टिवाइटिस यूजुअली पेरियोक्युलर पाल्सी, नहीं पाल्सी तो नहीं कराता ये लेटेनोप्रोस, राइट, लेटेनोप्रोस पाल्सी नहीं कराता है, राइट। सो दिस वाज द इंपॉर्टेंट क्वेश्चन इन फार्माकोलॉजी। लेट अस क्विकली सी लेटेनोप्रोस का साइड इफेक्ट जो भी पूछा था इन्होंने। पीएसवीटी में वेरापामिल वी आर गिविंग, वार्फरिन थेरेपी में 2 to 3 INR, डेलिरियम ट्रेमेंस, लोराजिपाम, इसका डायग्नोसिस था, वेट गेन बाय क्यूटियापिन, नॉरएड्रेनालिन, बीपी इंक्रीज, हार्ट रेट डिक्रीज, आयोडीन 131, हाइपोथायराइडिज्म इज साइड इफेक्ट। एंड दिस वाज अ क्वेश्चन, जैसे कि मैंने पहले ही आपको एक यहाँ पे क्वेश्चन मार्क लगा दिया था कि आपको करेक्ट ऑप्शन बताना पड़ेगा। इफ द ऑप्शन वाज कंटिन्यू द सेम ड्रग बिकॉज देयर इज अ शिफ्टिंग ऑफ, आई मीन देयर इज अ फॉलिंग पैटर्न, देन वी कैन कंटिन्यू द सेम डोज। अगर अनचेंज है, देन अगर वो ऑप्शन नहीं है तो वी कैन इंक्रीज द डोज टू 1000 मिलीग्राम, वी कैन इंक्रीज द डोज टू 1000 मिलीग्राम। इम्यून रिकॉन्स्टिट्यूशन टीबी और एआरटी वाले केसेस में आयरिस सिंड्रोम की वजह से लिनाग्लिप्टिन डीपीपी4 इनहिबिटर प्रेफर्ड होगा इन रीनल फेल्ड पेशेंट विद डायबिटीज। जोलेंटोनेट में टू रिड्यूस द रिस्क ऑफ इसोफेजाइटिस वी आस्क द पेशेंट टू मेंटेन अपराइट पोस्चर। सक्सिनिलकोलिन वाला क्वेश्चन था, उसमें वी आर एक्चुअली गोइंग टू गिव डेंटोलिन एज अ ड्रग ऑफ चॉइस। लाइपोसोमल एम्फोटेरिसिन बी plus flucytosine is going to the preferred in cryptococcal meningitis. Cisplatin is more nephrotoxic than carboplatin, remember that, and to prevent that we use amifostine, that is a potential MCQ. N-acetylcysteine, they replenish the glutathione store. SGLT2 inhibitor is the preferred in diabetic patient with a congestive heart failure. Cervix carcinoma का अगर था, अगर इसमें डबल ऑप्शन थे तो फॉर एग्जांपल मान लीजिए या तो ऑप्शन होगा इटोपोसाइट ऐसे करके होगा, ठीक है। तो अगेन वी कैन प्रोसीड, सिस्प्लाटिन वाला जो भी होगा वी विल गिव द कॉम्बिनेशन थेरेपी। आइसोनाजिड विल रिक्वायर कैट-जी बिकॉज कैट-जी विल कॉज कैटालेस पेरोक्सीडेज, और कैटालेस पेरोक्सीडेज ही है जो आइसोनाजिड इनएक्टिव को एक्टिवेट करता है, आइसोनाजिड इनएक्टिव को एक्टिवेट करता है। एक्टिव पार्ट ऑफ आइसोनाजिड विल बी विद द हेल्प ऑफ कैटरीना जी वाला आइस, राइट। एंड सेफ्ट्रैक्सोन वैंक्सोमाइसिन फॉर द मेनिंजाइटिस, रिफाम्पिसिन, ये वाला क्वेश्चन भी हो गया। लेप्रोसी में आराम से हमने सारे क्वेश्चन किए। जिंजिवल हाइपरट्रोफी फेनिटोइन, लिसिनोप्रिल शुड बी अवॉइडेड इन प्रेगनेंसी, एंड कार्बोनिक एनहाइड्रेज एक्ट एट द प्रॉक्सिमल कन्वोल्यूटेड ट्यूब्यूल, pulmonary fibrosis is a side effect of bleomycin. So this was the pharmacology recall. I hope that you guys got maximum correct, and ये सारे क्वेश्चन हमने अपने रिव्यू क्लास जो पीडब्ल्यू मेडेड पे किया था उसमें भी मोस्ट ऑफ द टॉपिक्स, मतलब 90% से ज्यादा हमने यही रिव्यू क्लास में किया था, और आप चेक कर सकते हैं यूट्यूब में वो सारे वीडियो फ्री में अवेलेबल है, यू कैन चेक इट आउट। 4 घंटे का एक वीडियो, वहां से यू कैन इजीली गेट दिस ऑल, राइट। सो थैंक यू वेरी मच टू ऑल ऑफ यू गाइस। नाउ नेक्स्ट फैकल्टी विल टेक ओवर, यू गाइस विल बी नेक्स्ट सब्जेक्ट विल बी सर्जरी। थैंक यू वेरी मच। रंजित सर।
All right, guys, good evening. I hope you're able to see me, you're able to hear me. Right, so let's get started with the surgery recall. So today we did a center visit. We spoke to a lot of you down there also, got a, first-hand information how the exam was. We already had a bit of discussion on that as well. So I'm not going to waste any further time. I know रात बहुत हो गई है, थक भी गए होंगे, तो simply धीरे-धीरे जल्दी-जल्दी questions कर लेते हैं, फिर देखते हैं कि क्या बनता है, ठीक है। Again, the questions are not complete. This time was not completed. Whatever minimum effort, I mean, I don't want, all of you guys to stress on it also. So we'll try to reconstruct it as we go. So we'll start with one question at a time. So the first question that I have is a 20-year-old female with dysphagia more for liquids when compared to solids. See, the only, when you talk about motility disorder where dysphagia is more for liquids when compared to solids is going to be your achlesia cardia. In the achlesia cardia, you will have rat tail appearance, and that is what the answer is. Remember, there is no filling defect. So I cannot say the word defect is used here. Agar the word defect is there, it cannot be an achlesia cardia. There is smooth, you would say, the margins which are present. That is why we say bird beak appearance, pencil tip appearance, rat tail appearance, all that goes into favor. Irregular defects cannot be the answer. Corkscrew is for diffuse esophageal spasm. So answer here is going to be your rat tail appearance for your achlesia cardia. Clear? Okay. Going into the next question that we have. Was there a question which is having Meckel's diverticulum with some bleeding? Rat tail was not there. Okay, if rat tail was not there, what else option? If this was not in the option, what is the option? Can anybody help me with the option if there's not an option? अगर rat tail option में नहीं था तो क्या option में था? Anybody? It was an image based question. अच्छा ठीक है. If there was an image, if it had a distal tapering with a smooth filling, it is something like that, then it will be called as, yeah, this was in the option. Achha. Okay, guys, we are having a mixed response, but more or less, if this is, see, the diagnosis is going to be eclampsia cardia if you will have dysphagia more for liquids when compared to solids. End of discussion. Okay. Now, was there a question on Meckel's diverticulum with bleeding? If they have asked you, no, sir, image for Meckel's. Monica, was there a question on Meckel's diverticulum with bleeding? See, if they're asking the source of bleeding, then it is going to be superior mesenteric arteries is the primary source. When you say the iliacoelic artery is going to be the secondary source of it. So if it's a single vessel, it is going to be iliacoelic artery. It is in fact going to present to as red current jelly stool. If it is going to be associated with interception, all that data is being there. Okay. Yeah, Meckel's diverticulum bleeding, or if it is red current jelly stool, that is going to be interception. Meckel's diverticulum is most common lead point for interception. So look into those lines of options. Okay? Yeah, if there is probably Meckel's diverticulum causing interception would have been a question. Okay? If they've asked you a question like this, where they have shown you an image of an MRM, and after doing an MRM, they have this muscle which is pointed out. The superficial muscle that you'll see immediately is going to be your pectoralis major muscle. It is going to be a pectoralis major muscle. But if you see, this is the pectoralis major that you can see. This is the pectoralis major muscle. But if you see the lateral ones, this is going to be your serratus anterior group of muscle. So see what they've asked you, right? If they're asked you the lateral boundary, then it is going to be the serratus anterior. If it is superior, it is going to be your pectoralis major. Okay, below, see, if pectoralis major is reflected out, then it is under beneath is pectoralis minor. But if they ask you the lateral wall, if it is going to be the lateral, then the answer is going to be serratus anterior group of muscle. Okay? Chalo. Then you have the right scrotal swelling with the hydrocele and the left testes is normal. So you have the right hydrocele is there, you have right scrotal swelling, left testes is normal. There's an enlarged pre-aortic lymph nodes. If it is an image-based question, probably you're talking about the testicular tumors. In testicular tumors, the biopsy is contraindicated. This cannot be the answer. So you cannot simply go and do an excision of the right testis. You have to do an high inguinal orchidectomy. And that high inguinal orchidectomy is excision of the right testis with epididymis. And these nodes have to be sampled also. So if the options are there, it should be your, that is what we call as Chivasu's maneuver, where you have high inguinal orchidectomy with the FNSE of your retroperitoneal group of lymph nodes. So here the answer would be C for Calcutta. Okay? Yeah, if the options has to be reconstructed, feel free to pounce a bit and add a bit more. But this is the primary stem of the question that I got to. Now, was there a question if there was cyanosis after 48 hours of bone fracture, then you're looking at fat embolism. So most likely answer here is going to be fat embolism. So if you have a fracture and then after fracture, if it is developing into a cyanotic condition or it's a ischemic condition, then yeah, femur, very common. Yes, it is going to be a fat embolism. The answer remains as fat embolism. Was there a question where they've asked you an image like this where you have a varicose vein, if they're asking you about what is the treatment? Okay. Now, there are two different options that I got. One, they're asking for treatment or they're asking for sclerotherapy. Remember, varicose vein mein sclerotherapy nahi karoge. You will do, because the criteria for doing a sclerotherapy, the size of the vessel should be less than 3 millimeters in diameter. Varicose vein itself is more than 3 millimeters. So, yahan pe you can do a Trendelenburg surgery, endovascular, laser ablation or a radiofrequent ablation. Sclerotherapy answer nahi hoga. अगर वो पूछ रहे कि sclerotherapy agent क्या है, then it is sodium tetradecyl sulfate, right? Asking which is not true. Yes, sclerotherapy cannot be done in a primary varicose vein. नहीं कर सकते हो. ठीक है, Cephalus vein का relation, this is if it is on the, see again you have to see if it is on the medial aspect, it is going to be great Cephalus vein. If it is on the lateral aspect of the limb, it is going to be a short Cephalus vein. As simple as that. ठीक है? Yeah, endovenous laser ablation can be performed. Endovenous laser ablation can be performed. Okay? Yeah, which is not true, no? If they're asking not true, endovenous laser ablation is actually a treatment option. It is true. ठीक है, नॉट ट्रू में स्क्लीरोथेरेपी नहीं कर सकते हो, ठीक है, चलो. Now, this I think again ortho ma'am has also discussed it. So this is a question where you have, see, if it is on the dorsum of the hand and it is along the tendons and the joint, it is going to be your ganglion cyst. We have discussed this as a spotter also. Lipoma के लिए slip sign होना जरूरी है. You cannot say it is lipoma. देखो अगर वो जॉइंट पे है, टेंडेंस के साथ है, तो इट इज अ गैंग्लियन सिस्ट, ठीक है, एंड इट विल बी इमोबाइल. लाइपोमा इज हाइपरमोबाइल. नो, लाइपोमा क्या स्लिप साइन पॉजिटिव होता है. जेलाटिन वाज मेंशन्ड, फिर तो एंड ऑफ डिस्कशन है. अगर जेलाटिनस सब्सटेंस, gelatin transparent substance is mentioned, then it is going to be your ganglion cyst. End of discussion. ये जो instrument है, this is a repeat question. If they have asked to identify the instrument, this is going to be our Veress needle. And we all know Veress needle is a needle that is used to create pneumoperitoneum. इस पे we have done a detailed discussion also. ये जो image है, this you cannot, yeah, you cannot afford to do it wrong. Absolutely. ठीक है. फिर ये GCS का question, I hope everybody would have gotten it right. A patient with a head injury has an eye opening to a verbal response. If it is to a verbal response, a score of 3 is there. He localizes to pain, that means a score of 5 is going to be there, and he is confused, a score of 4. So 5 plus 4 plus 3, कितना हो गया? 5 plus 4 is 9, 9 plus 3 is equal to 12. So answer here is going to be 12. So GCS of 12, yes, absolutely correct. Everybody got it spot on. This is absolutely correct. Now, if they've asked you what is, somebody told me the swelling was mentioned. Well, the swelling was mentioned somewhere here. If it is on this, it is going to be the level 2 group of lymph nodes. Okay, we have already discussed it multiple times. Papillary cancer thyroid has predominance to the cervical lymph node. Most common is going to be your central, that is level 6. Okay, अगर आपसे पूछ रहे level 1A submental, level 1B is your submandibular, level 2A, 2 is upper jugular, 2A, 2B वो अपने spinal axillary nerve के ऊपर नीचे का division है. Then you have 3 is going to middle jugular, 4 is lower jugular, then you have posterior triangle is 5, 6 is going to be central, 7 is going to be mediastinal. अगर वो pointed है, it is going to be your level 2 group of lymph nodes. There is no confusion in this. ऐसा कोई instrument आया था? I just want you to see this instrument and tell me कि ऐसा कोई गंदा सा instrument देखने को मिला था आज? ऐसा कोई गंदा सा इंस्ट्रूमेंट देखने को मिला था? See, this will be a bouncer. अगर ऐसा इंस्ट्रूमेंट पूछा है, they shouldn't ask you because this is usually done for banding a hemorrhoid. Now we have a different banding system. We don't use this, but this is what we call it as a barren band ligator. This is what we call it as a barren band ligator. अगर ऐसा सवाल आया था, I'm so sorry. I apologize from the NB's point of view. ऐसे नहीं देना चाहिए था. But then if they have asked you, this is your, yes, it's a hemorrhoid ligation. It's a barren band ligator for hemorrhoids. ठीक है. ऐसा कोई रेडियोग्राफ आया था Boston hernia के लिए? Was there a radiograph given for Boston hernia? A quick feedback. अगर Boston hernia के लिए दिया था, तो radiograph में you can see there is bowel loops in the left hemithorax. There is a mediastinal shift. There is, yes, white and black image. Guessed correct. No, no. CT था कि MRI था बेटा मोनिका? ऐसा कोई CT MRI दिया हुआ था? They just asked posterolateral congenital diaphragmatic hernia question. ठीक है. If they have given, okay, Boston hernia में points क्या है? It is the defect is going to be present in the left-sided posterolateral defect. The most common structure to herniate is going to be stomach. The most common congenital hernia is also Boston hernia. ठीक है. Morgagni will be on the right side, बेटा. Right anteromedial होगा. Left posterolateral is going to be your Boston hernia. ठीक है. चलो. Appendix और carcinoid पे कोई question आया था? I was not able to reconstruct the entire question. I would like to take some options. If you can contribute later, we can come back and reconstruct this question. अगर ऐसा कोई question था तो, ठीक है, नहीं है तो very good. Now, there was a question which was asked which says a patient has been brought to emergency with a respiratory distress है, with the absent of breath sounds. यहीं पे diagnosis बन गया है. That is going to be pneumothorax. Trachea deviated to opposite side. What is the answer? It is going to be tension pneumothorax, right? So absence of breath sound, tachypnea is present. There's going to be increased distress is there. Trachea deviated to opposite side. All this goes in favor of tension pneumothorax. But a Meckel's with rebound tenderness, differential diagnosis by image. अच्छा बेटा अगर Meckel's diverticulitis है तो differential diagnosis acute appendicitis होगा, ठीक है? चलो. Total body surface area burned, बच्चे में सवाल आया था. I think they have asked you. If I'm not right, if I'm not wrong, they have added. There is one upper limb of the baby was involved completely. अगर upper limb of the baby is involved, it is going to be 9%. The chest and the abdomen on the anterior surface is going to be involved. Then it is going to be 18%. See, lower limb is going to be 14%. anterior is 7, posterior is 7. If you say thigh, that is going to be 3. Only thigh, if it was involved, then it is going to be 3.5%. Okay? So if you look at the entire one, 19 plus 8 is going to be 27, 27 plus 3 is going to be 30.5. So if they are given a range anywhere between 30 and 35, 30.5 is the answer, beta. ठीक है, देख लेना closest one को 20 to 30 will be correct. ठीक है, अगर पूरा leg involved है, only thigh है कि पूरा leg है, देख लेना. I got two different components. If only thigh वो भी anterior surface पे तो 3.5 है. ठीक है, अगर पूरा limb लोगे तो 14% add करोगे. If the entire limb is there, then it is going to be 14%. If you add 14%, then it will jump to 40%. ठीक है, it is going to be 40%. Yeah, look at the question, but this is the only thing you have to remember is बच्चे में head is going to be, the head and neck is 18% and the lower limb is 14%. That is the carry message that you have to take across. Okay? Now this I think Rishabh sir has also discussed it. I'm going to discuss the same thing. You can see there is a coffee bean sign, and the coffee bean sign which is present is pointing towards, this happens to be the right upper abdomen, this is the left upper abdomen. Pointing to right upper abdomen is going to be your sigmoid volvulus. Okay? Chalo. Which of the following condition is described in the radiograph? Again, I think Rishabh sir has discussed it. It's a hollow viscous perforation. You can see free gas under right hemidiaphragm as well as on the left hemidiaphragm. Free gas under diaphragm indicates it is hollow viscous perforation. It is your hollow viscous perforation. As simple as that. Okay? If they have asked you the parts of the ulcer, I don't know because I got a mixed response on this question. If they asked you the parts of the ulcer, the junction, ये normal skin है. This is the normal skin, this is the ulcer. The junction between the normal skin and the ulcer is called as margin. Niche wala, you will call it as the floor of the ulcer. Between the margin and the floor, we call it as edge. And whatever it is resting on is called as the base of the ulcer. If they have asked you the parts of the ulcer, this is what you have to look up to. Okay. Was there a question on negative pressure wound closure system like VAC, vacuum assisted closure? ऐसा कोई सवाल था? Was there a question on negative pressure wound closure system? Anything, anybody who can recall if there's a question on negative pressure wound closure system? They gave A, B, C, D and described each of the question, which was true. Okay, fine. Margin not given, sir. Surface was given. Surface, देखो, see the normal surface of the skin and the ulcer का जो junction उसको margin बोलते हैं. VAC answer था IBQ में. ठीक है. If they've asked you, if they've given you a blackish foam and there is a transparent component and they've put, अगर ये image based question, I will add the image to this. VAC का image add कर देंगे. It is going to be a negative pressure wound closure system. Identify the structure marked. I don't know because I got multiple responses. I'm just going to quickly mark the structures. This is your cystic duct. This happens to be your common hepatic duct. This is your common bile duct. This is your cystic artery. And between this is what we call it as your 𝐒𝐿 triangle. Okay, so cystic artery, common hepatic duct, cystic duct, common bile duct. This is what you look across here in the context of your 𝐒𝐿 triangle. Sir, ये image तो आपने दिखाया, ये गलत है. Sabiston की image है. The base answer है. बेटा again cystic artery. अच्छा, अगर ये option में pointed है ना, तो ये cystic artery. ठीक है? Yeah, if they have asked you to, ये 𝐒𝐿 triangle का area है. Okay, not green. ठीक है, ठीक है. See, अगर ये पीछे वाला स्ट्रक्चर दिखाया है, if they have shown you this वाला structure, again be very careful. अगर ये वाला structure है, then it is going to be your right hepatic artery. ठीक है? So cystic artery is a branch of right hepatic artery. ठीक है, चलो. Okay, fine. MRM का question already discussed है. ठीक है? Yes. So these were the questions which we got it. If there are any more questions that you want to add? Okay. Right hepatic duct is the answer. बेटा देख लो कि क्या मार्क किया है. Right hepatic duct तो ऊपर हो गया ना, ये यहाँ पे है. This is your right hepatic duct. This is your right hepatic duct. This is your left hepatic duct. This is your common hepatic duct. This is your common bile duct. This is your cystic duct, which is here. This is the cystic duct, and this happens to be a cystic artery. ठीक है? Clear? So ये component देख लेना. Whatever they have asked you pointed out, I think you will be able to interpret it and give. See, the whole triangular part is the hepatocystic triangle. इसमें ये जो region है 𝐒𝐿 triangle है, इसका जो content अगर बीच में को lymph node of Lund है. ठीक है? Sir, never that right hepatic duct, that red color artery they marked. बेटा अगर artery marked है, it is cystic artery यार. उसके पीछे आपको right hepatic artery देखने को मिलेगा. अगर right, see that's what I was not there in the exam, तो मुझे exactly पता नहीं है क्या pointed है, but this is the orientation that you have to keep. ठीक है? Now, so this is all that it is there in the recall for the surgery. If you have any more questions, feel free to add to this. ठीक है? Yeah, see, the debate can never be settled because I don't know what was there in the exam exactly. But अगर आपकी orientation बन रही है तो यही question का answer होगा. ठीक है? चलो. So thank you so much, guys. Hope you did well. देखो, again, calm yourself down. No need to panic. All these recalls that we are doing it is on the basis of the input of the students. Again, the original answer might vary a lot because it depends upon how a question was constructed. आपका जो आज दिमाग लगा था एग्जाम में वो ही सही है. ठीक है? Calm yourself down. All this is just to have a bit of that confidence कि हाँ मैं पास हो जाऊंगा. रिकॉल में ये देख लेना कि सवाल आया था, आंसर मुझे सही सही लगा था, आंसर मार्क किया हुआ है. मार्क करे और क्वेश्चंस में देख लो कितने आपको नियर बाय करेक्ट मिल रहे हैं. इफ द नियर बाय करेक्ट इज गोइंग टू बी मोर देन 160 170, यू आर डेफिनेटली गोइंग टू पास. ठीक है? चलो. So with that, thank you so much. I will hand over the baton to our next teacher. So over to you, Ranjit sir. Thank you.
Manjana sir, you can start, sir. Manjana sir, you can start, sir.
Yes, hi, hello everyone. So am I audible?
Yes, sir. Yes, sir.
Am I audible, sir?
You're audible, sir. You're audible.
Okay. So let's start with the FMT questions. Yes, fine. Speedy, Miman Mohsin, yes, I'm going to complete all 10, 12 questions in 10 minutes only. Yeah. The first question that is from one of the very commonly discussed topic in our classes, CRPC and BNSS. So as you know, CRPC means Criminal Procedure Code. BNSS is Bharatiya Nagarika Suraksha Samhita. Okay. So the first question, I think this is the question, similar question, almost similar. A married female died in unnatural condition. So maybe a burn injury or some other injuries within 7 years of marriage. The section related to this. Okay, so it is probably a case of dowry death. As you know, dowry death is an indication for magistrate inquest. So the question asked, what is the section of BNSS related to magistrate inquest? Yes, Shubham Guy, yes, you are right. So it is 196 BNSS. So in exam, CRPC also was given, I think, 176. That is also correct. So it is either 176 CRPC or 196 BNSS. So the best answer is B is the correct answer. So try to memorize. 174 CRPC is police inquest. 176 is magistrate inquest. In the similar way, BNSS, 194 that is the police inquest, 196 that is your magistrate inquest. Okay, so B is the correct answer. Okay, fine. I think 217, no, it is not the answer. 217, it is not related to dowry death or magistrate inquest. So any option with 176 CRPC or 196 BNSS, that is the accurate answer. Okay, yes. So answer is B. So we discussed in our classes, especially in PW videos and YouTube lectures. Okay. The second question, again, two questions, I think, from inquest. So we discussed many times, inquest means inquiry towards cause of death. So there are two types in India. One is police inquest, second one is magistrate inquest. So let me explain the question. I think this is the question. A married female died in unnatural condition within 7 years of marriage with a history of demand of dowry. Inquest is done by. So the answer is very simple, magistrate. The answer is magistrate is the correct answer. Okay. Sir, in question it's police inquest. Fine. Okay. In case of death due to dowry, so it is an indication for magistrate inquest. If the word given demand of dowry, the answer is magistrate inquest, that is 196 BNSS or 176 CRPC. No doubt in that. Next question, I think the question asked about postmortem staining or postmortem lividity. Okay, so this is the postmortem staining which is unfixed. So let me explain the question now. I think this is the question probably. Fixation of postmortem lividity occurs in fixation. Fixation means no color change on pressure during autopsy examination. So options are 8 to 12 hours, 1 to 2 hours, 4 to 6 hours and 24 to 48. So yes, anybody, what would be the correct answer? Shubham Gai. Yes, we discussed many times. Lividity fixation occurs, that is in 8 to 12 hours. So that is the best answer. So the answer is A, 8 to 12 hours. Yes. Ijaz Mohammed, Shubham Gai. Yes. Any correction in the question? Any correction if you want me to do? Yeah. Next question again from the inquest, very simple, it is very, very simple. Death in police custody, the inquest is done by, inquiry and investigation done by magistrate. So the very simple, magistrate, memorize, it is 196 BNSS or it is 176 CRPC. Fine. Okay. Next question. So next question from one more very simple topic, that is summons. The question, doctor received two summonses, one from the criminal court, one from the civil court at the same court complex for expert witness. We doctors are expert witness, right? So what is the correct statement in this scenario? So the probable options they asked in your exam: attend together both the cases, don't attend criminal court. Option D, he should attend the court from which he received the summon first and inform the other court. So anybody? Yes. Okay. Okay. Shubham Gai, okay. Postmortem lividity, rigor mortis, liver mortis, all were given, right? Yes. So I'll discuss in detail about that question in upcoming videos. So time being, this question, all of you, very simple it is. In case of summons, so criminal court, they have priority than civil court. So the answer is attend criminal court. Answer is C. Mani Dheeraj. No, it is not D. It is the C. That is the accurate answer. If the question asks from criminal court and civil court. Okay, if both are from criminal court, then answer is D is the correct answer. But I'm sure that the question asked about criminal and civil court. So that is about the question number 5. Then question number 6, one very commonly asked in your exam. We discussed many times in our classes. Rule of 9, Browder formula, very commonly asked. I think this question was discussed by our Sandeep sir. Yes, this is the question. A 1-year-old child presented with burn injuries involving entire head, neck, upper limb. So anyway, you know that already we discussed in surgery class. So the answer probability is 25 to 30, that is because head, that is 18%. So we discussed in our classes. So infant head is 18%, leg is 13.5%, and trunk and upper limb, that is same as adult. So anyway, it is discussed by our surgery sir. Yes. The next question from the one more very commonly asked topic, that is courtroom procedure. So it is asked more than 5 times in FMGE exam in the last 2 or 3 years. So I think this is the question. Leading questions are allowed in. Leading questions are allowed in. What do you mean by leading question? Leading question means yes or no type of question. Okay, the question which has answer in it, that is known as leading question. So what is the best answer? Okay. Okay. Yes. So options are examination in chief, cross-examination, re-examination at any time. Definitely not at any time. So judge can ask question at any time. That is repeat question. Re-examination, no. Leading questions are not permitted. Examination chief conducted by public prosecutor. Leading questions are not allowed. So what is the best answer, guys? The best answer is cross-examination. So we discussed many times in our classes, even FMGE YouTube session also, courtroom procedure. So the answer is B. Okay. Yes, Anisha, Ashraf, Sufyan Khan, Shubham Gai, Hitesh Kumar, fine. Okay, all answered. Very nice to hear from you, all of you guys. Congratulations. Yes. So next question. So one more question that is from skeletal remains. So basically one very important chapter, identification. Cephalic index, you know, cephalic index, crural index, humeral index, all these are very commonly asked. I think in exam, this was the question. The cephalic index, so in skeletal remains, it is 85. 85. It belongs to dash race. You know, cephalic index means maximum breadth divided by maximum length multiplied by 100. So options are Aryans, Europeans, Mongolians and Chinese. So very simple it is. So it is Mongolians is the correct answer. Okay, 70, 75. So that is dolichocephaly. 75 to 80, mesocephaly. Mesocephaly, and more than 80, that is your brachycephaly. So the brachycephaly, the answer is Mongolians. Yes, you are right, Shubham. Shubham, you are right. It is the Mongolian correct answer. And again, it's a repeatedly asked question in our FMGE exam. Also, we discussed many times in our classes. Next question. You can see here from the standard textbook, dolichocephaly 70, 74.9 Aryans, mesocephaly Europeans, and brachycephaly Mongolians. Fine. One more question, one more favorite of FMGE exam, the skull fractures, especially the fracture caused by heavy object having a small striking surface, like example hammer. Yes, look at this. Fracture caused by hammer. Hammer, you know, heavy object. So having small striking surface. So it can cause linear fracture, depressed fracture. I know. So what is the fracture caused by hammer? Also known as signature fracture, depressed fracture. So the best answer is depressed fracture. Yes, how many of you answered correctly? Hitesh Kumar, Sufyan Khan, Shubham Gai, very simple. Yes, the same question asked, most common skull fracture, and answer should be linear fracture. Okay, ring fracture seen around the foramen magnum. So hinge fracture, that is the that is the fracture of the base of the skull, also known as motor cyclist fracture. So here answer is B, that is the correct answer. And question number 10. And question number 10 from alcohol. Alcohol, it is very commonly asked in any exam. FMGE, INI-CET, NEET PG exam, there will be a question from alcohol. Either from delirium tremens, Wernicke encephalopathy, or Korsakoff psychosis, or legal limit of alcohol, test for alcohol. So there was a question about alcohol. So this is the question. Very simple it is. A chronic alcoholic patient presents with anxiety, tremors, insomnia following cessation of drink during festival season. Most probable diagnosis. So tremor is there, insomnia, anxiety. The best answer is delirium tremens. So delirium tremens is the correct answer. In Wernicke encephalopathy, you will see 3 important findings. What are 3 important findings? Global confusion, ophthalmoplegia, ataxia, mnemonic is Goa. So alcohol, Goa party, hai na? Yes, 2 days given, fine, 48 hours, 72 hours, that is fine. So answer is delirium tremens. So Wernicke encephalopathy characterized by Goa. Korsakoff psychosis, vitamin B1 deficiency, right? Characterized by approximate answers. So answer is not C also. Run amok. Run amok is seen in case of chronic cannabis poisoning, characterized by homicidal mania. So the answer is A is the correct answer. Yes, Shubham and Sufyan, Prashant, all answer. Very nice to hear from you. And the last question, the question from standard forensic topic, dying declaration. So dying declaration, dying deposition, very commonly asked in FMGE exam. So let me explain the question now. I think this is the probable question asked in your exam. True about dying declaration. Okay, so there was a history of assault in a village or something, it was given, but the question about dying declaration. True about dying declaration. I just simplified the question. So options are oath is not required, leading questions can be asked, recorded only by magistrate, defense lawyer presence is needed. So what is the answer, guys? Yes, what is the best answer? Defense lawyer presence, is it required? Not required. It is required in dying deposition. It is not followed in India. So D is not the answer. Recorded only by magistrate? No. No, it can be recorded by any man or any magistrate, a police officer can record, right? So it is, even doctor also can record. So C is not the answer. Leading question can be asked? No. Leading questions are not permitted in examination chief as well as dying declaration. So the best answer is oath is not required. Oath is not required. So anyone, what is the section of dying declaration as per BSA? Can anyone answer? What is the section of Bharatiya Saksha Adhiniyama that defines dying declaration? Anyone, can you answer? Yeah, Shubham Gai, I remember some toxic language, it was actually fine. So question is not simple, fine. So BSA, anybody? BSA, anyone, can you answer? Yes, so this is about the 11 questions. No, it is not 60 beta. It is 26A BSA. Okay. So the first question, the question is about BNSS. So either it is 176 or 196 BNSS. The second question about the inquest. So 2 questions about the magistrate inquest. Very simple. Fixation of postmortem lividity 8 to 12 hours. Death in police custody, magistrate we discussed 176 CRPC. Summons, very simple question. Then rule of 9, very simple. Then courtroom procedure. Leading questions are not allowed in cross examination. Cephalic index 85, that is Mongolians. And question number 9, that is the fracture, that is depressed fracture by hammer. and 10 that is from the alcohol delirium tremens. So, and the question number 11 and the last question about the dying declaration. So, this is all about the forensic medicine questions. All these questions came from our lectures and the standard notes, I can say. So, FMT 11 out of 11, 100% strike rate. So, thank you all, wish you all the best, and thank you, Ranji sir.
Thank you, sir. Thank you, sir, for the detailed discussion of FMT questions. Next will be Dr. Murugan, sir, for PSM recall. Hi, sir. Over to you.
Am I audible, Ranjit?
Yes, sir. Yes, sir.
Okay, fine. Okay. So good evening, guys. So this FMG PSM questions. Okay, so we got some more than 20 questions we got. We'll go questions straight away. We'll just quickly discuss. A study was started in the year 2014 with a group of 5,000 to 6,000 people to find the occurrence of disease till 2024. Okay, so from 2014 to 2024, guys. Okay, so can you tell me what is the answer for this question? Okay, it's starting from 2014 to 2024. So it's a prospective study. Okay, they have not given regarding anything regarding exposure and all. So the best possible answer here is prospective study, guys. Okay. Okay, so prospective study. Okay, they are given it. Hypertension, CAD, fine. So they are given it. So anyway, with this also we can answer it. Okay, it's prospective cohort study. Prospective cohort study. We are following people for the occurrence of disease. Fine. Second question, guys. In a leprosy kit, tablet doses, which one is incorrect? The question was incorrect. So based on recall only we are giving. This is not a very elaborate one, but we can answer it. You can add on to this point, guys. Okay. So which one is wrong here? Which one is wrong here? Dapsone, rifampicin, clofazimine, monthly, clofazimine 50 milligram daily. What is the answer here? Dapsone we are giving daily, clofazimine 300 milligram we are giving monthly, clofazimine 50 milligram we are giving daily. What is wrong here is rifampicin is not given weekly, guys. It is given monthly. So this is wrong. Okay, this is wrong. Rifampicin is not given. Okay, rifampicin is not given weekly. It is given daily, guys. It is given monthly. Okay, fine. Next question, guys. Next question. Fine. Population norms for ASHA for urban areas, guys. ASHA. Okay, what is the population? Now this is a straightforward question. Multiple times we have discussed in the class, and it's a common question. ASHA in village areas, it is every 1,000 population. Every 1,000 population. What about in urban areas, guys? What about in urban areas? No, in urban areas, ASHA is for every 1,000 to 2,500 population. ASHA. So ASHA is a health worker. Okay. So in urban areas, in village areas, okay, she is appointed for every 1,000 population. Usha ASHA concept is same. Shubham, Usha ASHA concept is same. Okay, she will be available for every 1,000 to 2,500 population. One ASHA has to be appointed. For every 10,000 population, one ANM should be there in urban areas. Okay, ANM. Okay, one 10,000 population, one ANM should be there in urban areas. Okay, fine. Next question, guys. Next question. Killing mosquito larva with chemical. This belongs to which level of prevention? Same. Accredited social health activist. ASHA means accredited social health activist. Killing mosquito larva with chemical, like for example, Paris green, is which level of prevention? Is it primordial? Is it primary? Is it secondary? Or is it tertiary, guys? Okay, so we are doing it before the onset of disease. Okay, but there are risk factors are there. So what is the answer? Yes, this is primary prevention. Primary prevention. This is as per recall of students only we are giving it. Killing mosquito larvae with chemical, guys. Chemical. So this is an example for primary prevention before the onset of disease. Fine. Next question, guys. The question was not there. Okay, fine. Students has given us, no problem. Answer this question. A patient presented with family history of type 2 diabetes. When should we start screening? When should we start screening? Family history, no question. This is also given to us from our students only. So, okay, anyway, fine. Okay, according to the program NPCDCS, okay, the screening should start as early as 30 years, guys. Okay, at subcenter level. Okay, it should be started. Screening should be there as early as 30 years at subcenter level. The subcenter level screening should start. Okay, for diabetes as well as hypertension, guys. Both diabetes and hypertension screening should start at 30 years. 30 years. Fine. This question also not there. Okay, fine. Anyway, we'll give you a PDF. Okay, completed one. Okay. Now the question, what should be included at the base of the triangle in terms of levels of healthcare, guys? Levels of healthcare, what should be there? Yes, we will see the question. Okay, at levels of healthcare, at this base level, we should have subcenter and PHC. Above this, we should have community health center and district hospitals. At top level, we should have medical colleges and Apex institutes, guys. At Apex institutes. This question was there. Okay, yes. At the base level, we should have subcenter and PHC. Above that, we have CHC and district hospitals. Okay, at the top level, we should have medical college and Apex institute like AIIMS and other centers. Okay, fine. This question was there. This is the answer for the question, guys. Okay, this is the answer for the question. Fine. Now, what about this one? This is a neat question. Okay, it was asked in the last NEET exam. The girl below image used the mascot for which condition? Okay, it's a straightforward question. Okay, this is for National Leprosy Eradication Program, guys. NLEP. Okay, probably they are given the program, National Leprosy Eradication Program. So the girl is Sapna. The girl name character is Sapna to create awareness regarding leprosy, guys. Leprosy. Fine. Now, 2-3 problems were asked this time. Okay, fine. So in a study with a total population of 2000, okay, so they are asking specificity. So this calculation was asked. Fine. So you have taking diseased, non-diseased in the x-axis. Okay, screening test, positive and negative in the y-axis. Okay, fine. Now, the total population is 2000. This was the total population. So among them, okay, how many were having disease? 200 were having disease. Okay, how much is remaining? 1800. 1800 were remaining. This calculation was asked. So 2000 population. Okay, so 200 were having the disease. The total how many people tested were positive is 260. 260 were positive. Okay, among them 130 are having disease, guys. Okay, fine. So how much is remaining? 200, 130, 70. Here it is 130, 1800 minus. Okay, 130 is 1670. This calculation was asked. Okay, what is the formula for specificity? The formula for specificity is this is true positives, true negatives, false positives, false negatives. So specificity is true negatives by non-diseased people. That is 1670 by 1670 plus 130 multiplied by 100. It comes around 92.7%. No pen and paper. Yes, I understand. But we have to do the calculation. Okay. Yes, I understood that. But that is the situation they are asking. Okay, fine. So 92.7%, guys. Okay, so roughly around 93%. Okay. Hope this was there in the answer. Roughly around 93%. Okay, fine. I know that's a difficult question, but we can answer it. Yes. We have discussed in the classes also. Now, in a school, 75 children went on a trip. Okay, 75 children. Yes. Some questions are difficult. Yes, I understand that. Okay. Among them, 80 were vaccinated for a particular condition. Out of people who are remaining is 12 developed disease. Question is, what is the secondary attack rate, guys? 86% was there. Okay, fine. Okay, 86% were vaccinated. 86 is what? Vaccinated group. Let me explain the concept. Okay, then the answer will come accordingly. Okay, fine. Now, so what is the secondary attack rate? Secondary attack rate is, what is the formula here is, secondary attack rate is number of new cases, okay, developing within an incubation period. Number of new cases developing within one incubation period divided by total number of susceptible. Total number of susceptibles among exposed multiplied by 100. This was the formula. Number of new cases developing within one incubation period by total number of susceptibles among exposed. Okay, look here. How many were vaccinated here? Out of 75 children, how many were vaccinated? 80%. What is 80% of 75? 75 multiplied by 80 by 100. Okay, so that comes 60, guys. Okay, fine. So 60 people are vaccinated. So how many are susceptible means denominator is 15. Among them, how many are developing disease? 12. 12 multiplied by 100. Secondary attack rate is 80%. Okay, secondary attack rate is 80%. Okay, so total children is 75. Among them, 80% are vaccinated. That means 60 are vaccinated. Okay, remaining is 15 people. Among them, 12 children are developing disease. Okay, so the secondary attack rate is 80%, guys. Okay, 80%. Fine. I know that's difficult, but that is what exam we have discussed in the class. It's there in all videos. It's there. Okay, rapid revision, and also it's there in the original videos. Also, it's there. Colonoscopy is done as a screening tool in a patient. It's an example for which level of prevention, guys. Okay, colonoscopy. Colonoscopy is which level of prevention? Colonoscopy is a screening tool. Okay, so as a screening tool, which level of prevention, guys? Any screening tool is an example for which level of prevention? Okay, it's a secondary level of prevention, guys. Any example, any screening tool is an example for secondary level of prevention. Okay, fine. Which are the following vaccine contraindicated in pregnancy? Following vaccine in pregnancy, all live vaccines are contraindicated. In pregnancy, all live vaccines. Can you tell me? Okay. So, which vaccine is contraindicated here? Father history is given. Which one? So, secondary attack rate. Fine. So, which vaccine is contraindicated here? Here, all live vaccines are contraindicated. Which is the live vaccine here? So, rabies we have to give, hepatitis B we can give, influenza we can give. Which is the live vaccine here? Varicella is the live vaccine, guys. Okay. We cannot give varicella. Varicella is a live vaccine. Fine. National Deworming Day, celebrated every year. It was started in the year 2015. We have to give these tablets, okay? Albendazole, okay, for children between 1 to 19 years. Both days are given or only one day is given? 10th February. Every 6 months once we have to give. Okay, whether both days are given, guys, in the question? Not 10th March, 10th February. 10th February. Okay, 10th February, both days. 10th February and 10th August, guys. 10th February, every 6 months. March, April, May, June, July, August. 6 months, every 6 months. Yes. Identify the larva. Here, A and B. Let us assume this is A and this is B. Identify the larva. A, no siphon tube. No siphon tube. Then it be Anopheles. The other option is given. I think siphon tube was here. Siphon tube was present. I think this is 𝐒𝐄𝐝. Okay, 𝐒𝐄𝐝. Okay. Option was there. What was the option? Okay. So, Anopheles, A is no siphon tube. B with 𝐒𝐄𝐝. Siphon tube is present. Siphon tube is present. Okay, fine. Yes. Is this question was there, guys? Ayushman Bharat was started on which date? Was it there? Yes. Ayushman Bharat started September 23rd. As per students, recall they were saying, if it's not there, it's okay. Anyway, it's September 23rd, 2018, guys. If it's not there, okay, no problem. No problem. Okay, fine. Yes. Which is the nodal ministry for disaster management, guys? Which is the nodal ministry for disaster management? Nodal ministry, yes. The nodal ministry for disaster management is Ministry of Home Affairs. So, disaster management says there should be a nodal center. At every district, we should have a nodal center, guys. Every district should have a nodal center. Okay, so nodal ministry is Ministry of Home Affairs. Ministry of Health and Family Welfare, they don't do. Okay, and disaster management is done by a responsibility of state government, guys. Okay, it's the responsibility of state government. Fine. Again, a calculation was asked. There occurred an epidemic of in a particular village, particular disease were there. There were 12 deaths reported out of 60 cases. What is the case fatality rate? What is the formula for case fatality rate? Okay. Number of deaths by number of cases multiplied by 100. Okay, celebrating which month? Celebrating which month is what? Okay, fine. So number of deaths by number of cases, guys. Okay, fine. So how many deaths were there? 12 by 60 multiplied by 100. Okay, that is what? 20%. Answer is 20%. Okay. So 12 by 60 multiplied by 100. This is 20%. Okay, fine. Yes. Management of HIV positive patient with dog bite for rabies based on the category, guys. You have to provide vaccine, if needed, immunoglobulin, okay, plus wound management. So all should be done. Based on category, what was the question? Based on the category. In HIV positive, you can give it, no problem. Okay, fine. Management for rabies, dog bite with rabies, you can provide vaccine, immunoglobulin, and you can do management. Okay, all should be done. There is nothing different there. Okay, you have to do it. Fine. What about this one? In a study, mean value is 82 kg. 4 problems were there. 82 kg. Standard deviation is standard deviation. No category given. You said right, sir. Whatever it is. Nothing is there means based on what is the normal thing you have to provide. There is no difference between HIV positive person, normal person. They're asking 95% confidence interval, guys. So what is the formula here? 95% confidence interval means, so mean plus or minus 2 standard deviation. That is 82 plus or minus 2 into 1.5. That is 3. Okay, 82 means 79 to 85, guys. That is the answer. So if it is there, that is the answer, guys. 95% confidence interval. Okay, 79 to 85. Okay, fine. Shubham, answering nicely, man. Fine, yes. Formula for sensitivity. Okay, what is the formula for sensitivity? Okay, yes. True positives. So sensitivity is ability of the test to identify true positives, guys. True positives denominator is false negatives multiplied by 100. This is the formula for sensitivity, guys. Okay, true positives. Okay, denominator is true positive plus false negatives. Okay, fine. No question was there. A by A plus C, it was there. Is it like this? It was, the option was there. Okay, just fine. This is sensitivity. This is related with sensitivity. Fine. Fractional IPV dosage. Okay, fractional IPV dosage schedule in the national immunization. Fractional IPV dosage in the national immunization schedule. So it is given at 6th week, 10th week. Okay, and also at 9 months. 0.1 ml we are giving intradermally, guys. Intradermally. Okay, 0.1 ml intradermally we are giving. Okay, 6th week, 10th week, and 9 months. 9 months you are giving. Okay, this is fractional IPV. This is the Salk vaccine. This is the Salk vaccine. Okay, fine. No sensitivity question. Okay, fine. Sensitivity was not asked. Okay, fine. Yes. Last question, guys. Danida supported which health program in India? Okay. In the past, they supported which program in India? SIDA supported TB. Danida supported blindness control program, guys. Okay. Not there. Blindness control program. Danida. Okay. So just roughly, I have discussed around 20 questions. Maybe the number will be more. Okay. Maybe the number will be more. Okay. Fine. No issues. Anyway, we'll give you detailed booklets we will provide. Okay. Fine. Okay. Thanks for listening, guys. Okay. Yes. Danish is Danida. That is blindness control program. Okay. Thank you, guys. Okay. We can go to the next session. Thanks, Dr. Ranjit.
Thank you, sir. Over to you, ma'am.
Hi guys, it's late, but we'll make it interesting by just quickly looking at some psychiatry questions. As always, the PYTs were a hit. Substance was something that was obviously asked. Psychopharmacology, we keep insisting that if nothing, please at least do these topics. MSc, repeat, and even schizophrenia, and finally mood disorder. All PYTs, at least some PYQs as well. So let's take a very quick look. Please tell me if the questions that I'm sharing, I'll be sharing about 7, if they were there or not. So a 24-year-old male previously diagnosed with a psychiatric disorder has become aggressive with his neighbors, speaking rapidly, sleeping very less. Sleep is less and speech is excessive. And he also shows hyperactivity. This is after he has discontinued the prescribed medication. What is the most likely diagnosis? Why don't you tell me, guys? Was it depression, bipolar disorder, manic episode, schizophrenia, or substance-induced mood disorder? Yes, Shubham. Shubham's answer is correct. The answer is bipolar disorder, manic. Khadim, did you get the right answer as well? So the answer was a manic episode. Pretty straightforward, pretty easy, I would say, because you can find all the core features of mania. Of course, we're going to have a booklet later on for all the subjects where you're going to find the answers and a little bit of detailing of why. Today, let's go through your answers to just put you to sleep at night peacefully. Right, a lot of you got B as the answer, right? Great. आगे बढ़ते हैं, अगले वाले पे बढ़ते हैं. We will not waste too much time on this. This one is a very straightforward one. The next question was, a 45-year-old man presents to the hospital with complaints of seeing snakes crawling and an inability to recognize his own family members. So he is already delirious, meaning he is not oriented to time, place, and person. And he is chronically taking alcohol. Last was 48 hours. What happens at 48 to 72 hours? When somebody stops alcohol suddenly, is it induced psychosis? No, not at all. Schizophrenia? Absolutely not, because there is a clinical picture of alcohol in the mix. Is it alcoholic hallucinations? No, because he is not oriented. So the answer is, what is the answer? B. Perfect. Delirium tremens. नाम ही काफी है. Delirium भी है और tremens भी है, right? So I hope all of you all got the 2 on 2 so far. Give me a thumbs up if you got 2 on 2 so far. I'll be happy to know that all the PYTs that we've covered, all the PYQs we've done, and this is in fact a PYQ that we've done in Psych, you all are on the same page. So give me a thumbs up if you've got 2 for 2. Awesome, Shubham. Good. Right. अगला बढ़ते हैं. A young female reports episodes of binge eating followed by self-induced vomiting, which is called purging. Was this question there? She is most likely to have which of the following acid-based disturbances? Respiratory acidosis, alkalosis, metabolic acidosis, or metabolic alkalosis? Well, this question was there. Shubham, I am hoping आप इसी का आंसर दे रहे. All right. Meanwhile, I think a lot of you got 2 on 2 so far. Yes, the answer is so far 3 on 3. If you've gotten it right, the answer is D. Dr. Ashwin, you've got it correct. Dr. Shubham, absolutely right. Dr. Traveling, absolutely right. The answer is pretty straightforward. Metabolic alkalosis. You can consider this to be an overlap between both medicine and psychiatry interface. Tell me if this question was there. That a doctor asks a patient about how old are you? What is your age? And she starts from the topic saying, you know, doctor, I'm from a village. We were married at a very young age at 12. My husband, who is 5 years older than me, then I had 2 kids. And when I was around 18, I know I look like their older sister, but I'm just 32, doctor. What is this likely to be? Circumstantiality, गोल गोल घूम के point पे आना, or is it tangentiality, point miss कर जाना, derailment, बिल्कुल point नहीं बनाना, or flight of ideas? Definitely not flight. She's answering goal oriented, not derailment. She was on track and she did touch and come to the final point. The answer is A. All of you have gotten it right. So do we have 4 on 4 so far? Please write 4 by 4 in Psych. If you've got a 4 on 4 strike rate, then I'm so happy for you, because Psych was pretty interesting and straightforward this time. We're moving on to a slightly tricky question next. So give me a 4 on 4, guys. 4 on 4 so far. Dr. Traveling, 4 on 4. All right, 4 on 4. Dr. Harshni is 4 on 4. Shubham is 4 on 4. Excellent. This question can be tad bit tricky, although it is very straightforward. What kind of symptoms does the term affective flattening, that is a flat affect, imply? Now, one can obviously confuse certain of the things. It is surely not positive symptoms. Is it negative symptoms, affective symptoms, or cognitive symptoms? I think A and C, D minus karna bahut aasan hai, but between the affective and negative symptoms, that's the only tricky part which I believe somebody can get wrong galti se, because affect likha aur yahan affect likha hai. No, it is a negative symptom because we have the 5 A's in the negative symptoms and flat affect is one of them. Did you get this one right, guys? This is the only one so far I feel thoda sa किसी को confuse कर सकता था. Negative symptom. Great. B. So we have a 5 on 5 so far. Excellent. So happy to hear that 5 on 5 is a strike rate for y'all. Good. बढ़िया. Prasanna, आप क्या बता रहे हैं? S. अच्छा, yes. All right. 5 on 5. Lovely. Let's move on to the final 2. A lady presents to the hospital after fighting with her husband, and she is unable to speak. But all the physical examinations of the world, all the neurological examination, all say, you know what, you're fine. Nothing is wrong with you. And she's not even concerned. She doesn't give a damn about her health status. वो जैसी लेटी है वैसी लेटी है. What is the likely diagnosis? She doesn't care. Is it labella indifference? Is she making it up? Malingering? Is it somatic symptoms? Or is it GAD? Now, clearly not anxious about her problems, not complaining about her problems. She is not seeming to have any gains and she is not worried. Labella indifference, we have covered this already in the videos, in the PYTs. Yes, this is a very classical labella indifference presentation. 6 on 6, excellent. Everybody is doing great in psych so far. I think बढ़िया, perfect strike rate hai sabka bhi. And hamara bhi. And in the booklet, we are again going to share this. In the coming week, we'll put the booklet out with all the possible questions of all the subjects. Please wait for that. And the last question, psychopharmacology. This is the one that some of you may have had a little bit of trickiness with. Was it a 28-year-old woman diagnosed with schizophrenia? She's been compliant on the medication olanzapine, second generation antipsychotic, for many months, but she discontinued the treatment. So what is the most possible reason for her discontinuation? Is it because she gained weight? Is it because of tardive dyskinesia, acute dystonia, or akathisia? Now, as we know in second generation antipsychotics, while these are lesser possible though, but weight gain and metabolic syndrome is a very common presentation, which is why one can stop the medication. So weight gain is the right answer. I think everybody's got 7 on 7. And were there any other questions that I have missed out? Please add. I'm happy to solve them right now. Was any of these questions not there? Then please comment. Otherwise, we'll give it over to the next faculty. Everything that we've shared was there. All 7 on 7 were there. And all of you all have gotten the 7 on 7 right. So Dr. Traveling says yes. Can we have 1 or 2 more people confirm, please, very quickly? All right. I'm going to not take a lot of time. I'm going to pass it over. 7 on 7, yes. So that's 100% strike rate for all of us, and great. So great. Over to Dr. Sudha ma'am, and thank you, everybody. Psychiatry was easy. I'm so happy. That's how it needs to be. Good night.
Am I audible and visible?
Ma'am, you're not visible, you're audible. Yes, ma'am.
Now? Now I'm audible and visible, Dr. Anjay?
Yes, ma'am.
Yeah. So, I mean, we are close to midnight. I'll just quickly go through the ophthalmology questions. And as all of us have been saying, we will have a detailed booklet where we'll have the questions with the proper options. I know it's really late and all of you are tired. So see, this was one of the questions from ophthalmology, I believe, the image-based question, which said that there was a patient who had some kind of injury and this picture was given and it was asked, what is the diagnosis? Am I right? This question was there. And so we have, you can see that here the iris is like torn from the root. And you have a D-shaped pupil, right? So you have a pupil which is like D-shaped and we have iris, as you can understand, which is torn from its root. So we know what this is. This is obviously iridodialysis. This question was there, everyone? D-shaped pupil and the iris is torn from its root in a patient who had suffered some kind of trauma to the eye. So there is no confusion about this. The answer is iridodialysis. I do not know what the other options were, but it actually doesn't matter also because the answer is iridodialysis. Right? So this was the first question that I got. The second question is that this is also a one-liner. I'm not exactly sure how the question was framed. It probably said that there is a patient who of diabetes having a cataract, or it said that there is a patient having a snowflake cataract, and the question that was asked is, what is the substance that is accumulated in this kind of a cataract? Right? Yeah, so this is the substance that is accumulated. I think all of you know it is sorbitol. The substance that is accumulated is sorbitol. Yeah, so we know that in diabetes, the excess glucose gets converted to sorbitol with the help of the enzyme aldose reductase, and this sorbitol gives rise to snowflake cataract, a question that has been often discussed in all our sessions, and it is like a PYQ.
right? So this was the second question. Most of the questions in Ophthal were actually quite simple. I would say one was a little difficult. I'll come to that. Then there was this question, again, another very simple one. It was asked that where is cover uncover test used? So I think that either you would have had latent squint in the option, or you could have had phoria in the option. So cover uncover test, this is the test for latent squint or phoria. Whereas you all know that Hirschberg test is the test that we do for manifest squint, that is tropia. So for cover uncover test, latent squint or phoria. Except was asked. Cover uncover test is not used for. That is what was asked. Cover uncover test is not used for. Yeah, cover uncover test is not used for if that is what has been asked, and you have manifest squint as the option. Then manifest squint, the test is actually Hirschberg test. The test is actually Hirschberg test. Hirschberg test is for manifest squint, that is tropia. And cover uncover test is for latent squint, that is phoria. So if it is except, then we have to look at all the options. Otherwise, it will be very, very difficult. Yeah. Cover uncover test is not to be done for manifest squint, certainly. So if it is except, then the answer probably would have been manifest squint. It is done for latent squint, that is phoria. Yeah. So let us just go to the next question then. Then there was a question where there was the question that was given is there is a significant difference in the refractive error between the two eyes. I think it was given that in one eye, the refractive error is -5 and in the other eye, it is -2. And it was asked, what is this condition called? Right? So if there is a difference of more than 2 diopters between the two eyes, then that is considered to be significant anisometropia. Was this the question? +2 and 3, +2 and -3, -1 and +2. Yeah, see the numbers would, I believe there would have been a difference of more than 2 diopters or 2 to 2.5 diopters between the two eyes. So whether it is, say, either they can give, say, if they say -5 and -2, then also you see there is a difference of more than 2, right? And if they say it is +2 and -1, then also it is fine. So if it is +2 and -1, then also it is anisometropia. Then that is anisometropia. Yeah, I believe that the question was that there is this error, that there is +2 error in one eye and -1 error in the other eye. Or it would have been, say, minus so and so in this eye and minus so and so in this eye. But the difference of refractive error between the two eyes would have been more than 2 diopters. And that is when the answer becomes anisometropia. The answer is anisometropia there. Mixed astigmatism is a refractive error which looks like this. Like it is -2 sphere and say +3 cylinder at any axis. This is what is mixed astigmatism. This is mixed astigmatism. Okay, I think that the question was that there is -2 or +2 in one eye and -1 in the other. Also a difference of more than 2 diopters between the two eyes, suggestive of significant anisometropia. Let's go to the next question. Yes, then there was a question on a PG analog, that is latanoprost or prostaglandin analog, which is one of the anti-glaucoma drugs. And was there a question about the side effects? Now, the ocular side effects, what are the ocular side effects? Was there a question like this, ocular side effects of latanoprost? Or was it just prostaglandin analog, which is not used in... was there a question on the ocular side effects of latanoprost or PG analogs used in glaucoma? The important ocular side effects of was it the ocular side effects? The ocular side effects, if it was, the important ocular side effects are it causes iris pigmentation, it can cause allergy, it can cause hypertrichosis. Iris pigmentation, allergy, hypertrichosis. Yeah, it also exacerbation of uveitis. Yes, exacerbation of uveitis is also, yes, it increases intraocular inflammation. That is also correct. It increases ocular inflammation. So these are the possible side effects. So was the question like which of these is correct? Conjunctival hyperemia also it causes. It causes conjunctival hyperemia also. Now this some of you are saying it is the mechanism of action that was asked, and some of you are saying it is a side effect that was asked. I think we are like too late into the night and you've got just completely confused. Okay, let's go to the next question. Yeah, now there was this question. This was about, the next question says that there was a child who at the time of feeding, that is when there is a movement of the jaw, the mother notices that there is an up and down movement of the lid. Was there a question like this? That a child, there's a small baby, and at the time of feeding actually indicates that there is a sideways movement of the jaw, and at the time the mother is noticing that there is an up and down movement of the lid. Yes, if that was the question, then the answer is Marcus-Gunn jaw-winking syndrome. Marcus-Gunn jaw-winking syndrome. Yes, ptosis, which, there is an up and down movement of the lid, which is associated with side-to-side movement of the jaw. That is when the child is either sucking or drinking, feeding, anything. That was the question. That is Marcus-Gunn jaw-winking syndrome. Okay, so let me go to the next question then. The next question was again an often expected question. There was a question on homonymous hemianopia with macular sparing. What did they ask? What is the site of the lesion? What was the question? Homonymous hemianopia with macular sparing. I think this is like a question that all of you would have got correct only. Did they give the image? What was the question? Homonymous hemianopia with macular sparing. Did they give you an image like this, or did they give it in words? Yes, there is both eye right-sided vision loss, but they did not say about macular sparing. Both eye right-sided vision loss. Okay, so we can say that it's a right homonymous hemianopia. Right-sided vision loss, but did they say that there is a macular sparing with central sparing? Both eyes, right-sided vision loss with macular sparing or central sparing. They may have used the word central sparing instead of macular sparing. And did they ask what is the site of the lesion? This is like something which we have discussed maybe 100 times. The site of the lesion is obviously the occipital cortex or the visual cortex. Yeah, the image was not there. Fine. But that's what it means. Like there is a right-sided vision loss and the central vision is clear. That means that it's homonymous hemianopia with macular sparing. So it was asked that what is the diagnosis? What is the diagnosis? So the diagnosis is it is a lesion in the occipital cortex, or what is the field defect? If it was asked, then it is homonymous hemianopia with central or macular sparing. Yeah, right-sided vision loss with central clearing or central sparing. Right-sided homonymous hemianopia with central or macular sparing. And it is the They asked whether it was homonymous or non-homonymous. If it is on the right-hand side, if they are saying that the vision loss is on the right-hand side, then it is homonymous. Non-homonymous or heteronymous means, like for example, bitemporal hemianopia. This is something I think you would have definitely answered. Chalo, let's go to the next question. Was there a question on bite or spot? Was there a question on bite or spot or vitamin A deficiency? Was there a question on bite or spot? I think everybody is like either too tired because somebody is saying it is the site of the lesion that was asked, and another person is saying that what is the defect that was asked. Okay, there was no question on bite or spot. Okay, fine. We'll go to the next one. So this is a picture of cystoid. This is an OCT picture of cystoid macular edema. I believe there was a question which said that there is a patient who after a few weeks after cataract surgery is presenting with a decrease in vision, and on OCT this is what is being shown. This is a cystoid macular edema. So what is the diagnosis? That is, a patient post cataract surgery presents about 4 to 5 weeks later with decrease in vision. On examination you see this kind of cystoid macular edema. It is Irwin-Gass syndrome. Irwin-Gass syndrome. Irwin-Gass syndrome was there? Yeah, let me know if this, I think this also is a PYQ. You would have got it right anyway. Again, I'm getting contrasting answers, which kind of tells me that all of you are very tired. So we'll come back with a proper recall of all the questions. This is what I believe this question was there because this has been recalled by quite a few of you. By quite a, yes, Shubham, yeah. Okay. Now, the next, was there a question on indirect ophthalmoscopy? Something which was asked, like what is the magnification? Something related to the magnification of the indirect ophthalmoscope. This is also something, if it was there, I think everybody would have answered this, because the magnification of indirect ophthalmoscope is between 2 to 5 times. The magnification of the indirect ophthalmoscope is 2 to 5 times. This is also something we have discussed multiple number of times in the class. Was this there, that what is the magnification, a question related to the magnification of the indirect ophthalmoscope? Yeah, it is. Yeah, the magnification is 2 to 5 times, and we have a real and inverted image. We have a real and inverted image. The magnification is 2 to 5 times, and the field of vision is up to the retinal periphery. So this is something we have discussed many, many times. This I don't think. Which of them is the correct statement? Which of them is the correct statement? So see, out of this, you can understand the magnification is 2 to 5 times. It's a real and inverted image. The view is up to the retinal periphery. So इसमें से I think ये वाला option जो है वो सही है. ये this is what the others were probably wrong. They have probably given that the magnification is around 3 times or 4 times, something like that. 2 to 5 times option में नहीं था, I know that. I think 3 times, yeah, something like that was there in the option. Magnification is 3 times or something like that was there in the option. But I think ye to, I don't think there is anything to discuss in this. It was not like that. 3 times tha. So one of you is saying 3 times magnification was there. Okay. See, I don't think anybody of you would have got anything on indirect ophthalmoscope wrong, because I am sure that you're just too tired now. Chalo. Now, the last question was the only one which was a little tricky. There was a question which is on proptosis. There was a question on intermittent proptosis, I guess. It said that there is a patient who's getting intermittent proptosis now, which increases when the patient bends Now there are three options which can be there. Now it can either be orbital varix, it can be meningocele, or it can be meningomyelocele, or it can be encaphalocele. So all these are possible options. Now it depends on whether they had said that it was pulsatile or non-pulsatile. Now I believe that very few of you will be able to recall this. So see, if the question says that there is a patient with intermittent proptosis and it increases on bending down, there are three options: orbital varix, meningomyelocele, encaphalocele. Now, agar they have said that it is non-pulsatile, then the answer is orbital varix. This is non-pulsatile. And if they have said that it is pulsatile, then meningocele या encaphalocele में से कोई एक रहा होगा option में. If they said non-pulsatile, then the answer is orbital varix. Orbital varix is non-pulsatile. Meningomyelocele and encaphalocele are both pulsatile. So abhi ye depend karta hai ki what the question was, whether it was said that it was pulsatile or non-pulsatile. And that it is an uncommon question. It's not something which is routinely asked. So I am not sure whether you would be able to recall this. The rest of the questions in Ophthal were actually pretty simple. So now I think that we can go over to the next faculty, and we will be coming forward with a booklet with all the questions in with a proper recall very, very soon. So over to whosoever is, I think it is Dr. Oishika who is going to take over after me.
Thank you, ma'am. Quickly just tell me if I'm audible and visible, and then we can start. I'm sure everybody is very tired and you guys just want to know the answers and go to bed without any explanations. So we'll do just that. Quick thumbs up if I'm audible and visible. Okay, great. So let us start with the recall. So OBG, as always, had a lot of questions, but most of them were pretty simple, I would say, if you had studied, for sure. Okay, so I believe this was one question. This picture was given to you and it was asked, what is the sign? If at any point you feel this question was not asked, or any of the options that I'm recalling is incorrect or missing, do let me know. So what did you guys... Hi, Dr. Shubham. Yeah, it has been a long time. Yes, so correct. So bluish discoloration of the cervix and vagina, very correctly, been covered in class. This is Chadwick sign. Chadwick sign. The other name for Chadwick sign is also Jacquemer sign. Jacquemer sign is also the other name for it, being covered in class. In the same vein, let's cover the next sign that was asked to you. I think another image-based question was asked where there was bimanual palpation being done. And what is this area that they are palpating? Very easily compressed, very soft. This is a sign that shows the softening of isthmus. Softening of isthmus, not the cervix. Cervix soft is Goodell sign. This is absolutely correct. Hagar's sign. Hagar's sign. Dr. Harshneil, Osiander sign में ना हम pulsations feel करते हैं in the lateral fornix. So they won't be pressing on the cervix. They will be pressing on the lateral wall of the vagina. So the answer here is Hagar's sign. ये isthmus है. देखो ये cervix का ये वाला part. This is the isthmus and this is easily compressed. This is Hagar's sign. All right, this has also been covered in class with the same picture, with the same pictures. Okay, another very, very simple test. Home-based pregnancy test is they are testing what hormone? What hormone is being tested? Quickly, very simple. Beta HCG, correct. So we are looking at beta HCG for home-based pregnancy testing. So far, so good. Everybody is with me? Okay. Earliest sign in pregnancy on TVS, again covered in class. Obviously, GSAC जब तक नहीं आएगा, GSAC के अंदर ही yolk sac आएगा, fetal pole आएगा, and in that you will have the cardiac activity. So the first to appear will be what? Dr. Shubham, absolutely correct. Dr. Tawfiq, correct. This is gestational sac. Gestational sac, correct. Okay. Moving on to the next one, again covered in class. Which of the following cardiovascular changes are not seen in pregnancy? What have you guys marked? Great. Yeah, Dr. Shubham, correct. What have you guys marked for this? Soft systolic murmur, diastolic murmur, S3 and loud S1. So typically it's the loud splitting of S1 that is heard, which is normal in pregnancy. S3 is also normal in pregnancy. Systolic murmur grades 1 and 2, which is a soft systolic murmur, is normal. Above that, 3 and 4 are abnormal. So yes, a diastolic murmur at any time if heard in pregnancy is abnormal and warrants कि आप ढूंढो what is the cardiovascular problem or disease this woman has. Okay. Yes, correct. Diastolic is always pathological. Couldn't have put it better myself. Diastolic is always pathological in pregnancy. Next, moving on to, this was physiological signs in pregnancy, all the questions covered. Next, we are moving on to antenatal care questions. So what are the vaccines contraindicated in pregnancy? So remember, pregnancy is an immunomodulated or immunocompromised state. So the vaccines that we avoid are the live vaccines. So live vaccines are avoided in pregnancy क्योंकि immunity थोड़ी कम होती है, तो the mother and fetus can actually get infected. So live vaccine इनमें से कौन सा है? I don't know what the fourth option was. What was the fourth option? Can anybody tell me? Correct. So the answer over here was varicella. अगर MMR दिया होता, MMR is also contraindicated. The only, okay, yellow fever was another option. So remember, yellow fever and Japanese encephalitis are also live vaccines. But again, this has been covered in class in vaccines under special circumstances. The only exception of live vaccines that can be given and should be given is JE and yellow fever. क्योंकि अगर ये मम्मी को हो गया, then the morbidity and mortality to mother and fetus is very high. इतना high that it is more than the risk of the vaccine itself. So the answer over here will be varicella. The answer will be varicella. One more option was Tdap. Okay, so yellow fever was not given. Tdap हमें पता है हम routinely देते ही हैं. Right, so the answer over here will be varicella. Okay, so I believe there was a picture of a baby with craniorachitis, and this is a neural. Okay, it was not there in the options. Okay, my bad. So I believe this was a picture that was given. So what have you guys marked for this? Open neural tube defect. So this is craniorachitis specifically, and if they have not given that option to you, then you can see the entire neural tube is open. The neural tube has not closed. This is an open neural tube defect. Moving on to another very frequently asked question, again covered in class, antihypertensive that is contraindicated in pregnancy. What have you guys marked? D, correct. So remember, ACE inhibitors and ARBs are contraindicated in pregnancy. So the rest, all of these plus hydralazine can be given. Enalapril, ACE inhibitors and ARBs are not to be given. All right. Then another question, fetal anemia is monitored by, I did not get the options in this. Can anybody tell me what were the options? Fetal anemia is monitored how? Yes, it can cause renal problems in the fetus. Exactly. That is why ACE inhibitors and ARBs are not used. Correct. Can anybody tell me how do you monitor fetal anemia? Can anybody tell me what were the options? Correct. So the answer will be MCAPSV, which is middle cerebral artery Dopplers. उसमें peak systolic velocity देखते हैं हम. तो we know adults में भी anemia जब होता है तो खून पतला हो जाता है, the blood becomes thin, the velocity is high. Similarly in the fetus, the velocity of blood becomes very high if the baby is anemic. So we look at the peak systolic velocity. So if the baby is anemic, the velocity increases and it becomes more than 1.5 MOM or multiples of median. Correct. So this was the answer. I did not get all the options. If you can tell me what the other options were, that would be very helpful for us to make the booklet. All right. So I believe there was another hand-drawn question on CTG and they had asked you what is the CTG pattern. Was it something like this or was it a little different? I mean, only you guys can tell me if it was this or something else. Okay, so जो picture मैंने दी है, the question that I have given, उसमें it is early decelerations, but only you guys can tell me what. Okay, it was the same picture. तो अगर ये यही picture था, it is early deceleration, but let me use a different color. If it was a little like this, कि ये contraction अभी आ रहा है, contraction जब गया तब deceleration शुरू हो रहा है, then it would be late. right? So if it is exactly जो मैंने दिया है वही दिया था, तो the answer is early decelerations caused by head compression. Same like kind of pick. Okay, so variable deceleration, Dr. Jay, अगर variable होता तो the picture would be something like this, कि कॉन्ट्रैक्शन अपनी तरह आए जा रहे हैं, इनको कोई मतलब नहीं है, कभी कॉन्ट्रैक्शन के साथ आ रहा है, कभी कॉन्ट्रैक्शन के बाद आ रहा है. दैट वुड बी वेरिएबल. सो लाइक आई सेड, ओनली यू गाइस कैन टेल मी व्हाट वाज द पिक्चर लाइक. तो अगर ऐसा था कि ये जो कॉन्ट्रैक्शन की पीक है दैट इज कोइंसाइडिंग विद द लोएस्ट पॉइंट ऑफ द फीटल हार्ट, देन इट इज अर्ली. ओके, ऑल राइट, early deceleration ही था. Then if the picture was like this, then it is early, right? Okay, moving on to the next one. This instrument, first of all, what is this instrument? So the question is in two parts. First you identify the instrument and then you tell us where is it not used. Exactly ऊपर नीचे था तो early decels होगा. Okay, this is not Piper forceps. This is actually Wrigley's forceps. Piper's forceps looks kind of different, which I have shown you a picture in class. This is Wrigley's forceps or outlet forceps. Piper आपने बोल ही दिया है, तो अब मेरे को बताओ Piper कौन से उसमें यूज होता है. What is the use of Piper? Piper का यूज होता है in aftercoming head of breach, which is option C. Wrigley's is not used. So the answer is not C. Remember, vertex position में अगर sutures आपके directly AP में होते हैं या within 45 degrees होते हैं, तो you can use forceps, which means you can use it अगर हमारा occipito anterior है directly and also in direct occipito posterior. So definitely in direct occipito posterior, you can use it. Right. Then we have the other two options. Cesarean section में कभी-कभी head निकालने के लिए हम use करते हैं. Sometimes we use it to take out the head. Now we are left with two options, options B and C. Now the problem with this picture is they have given you Wrigley's forceps, but मोटा-मोटा अगर हम देखें Wrigley's भी ना देखें, this is a forceps. Right. तो अगर हम देखें Wrigley's forceps के हिसाब से, then you cannot use it in both B and C. But if we just look at it from the point of view of a forceps, then remember, चाहे forceps हो, vacuum हो, vaginal delivery हो, the baby has to come out from the vagina, which means if there is any cephalopelvic disproportion या फिर अगर आपका labor obstructed है क्योंकि pathway छोटा है, वो नीचे से आ ही नहीं सकता, the mode of delivery will always be a cesarean section. So the answer over here is obstructed labor. So the answer is obstructed labor. So the best answer is obstructed labor. But remember, ये जो इन्होंने आपको picture दी है, this is Wrigley's outlet forceps. Outlet forceps are not used for breech delivery. Piper's forceps are used for breech delivery. So the most appropriate answer over here in all seasons, remember, obstructed labor का mode of delivery will always be a cesarean section, whether or not the baby is alive or dead, because this baby cannot come out vaginally. Okay, so the answer is 100%. Yes, absolutely correct, Dr. Shubham, Dr. Alam Noor, Dr. Prasanna, all of you are absolutely correct in this. So the answer is obstructed labor. तो I am guessing जब उन्होंने question बनाया था, उन्होंने इतना नहीं सोचा था कि बच्चे इतना आगे तक पहुंच जाएंगे और Wrigley सोचेंगे. What they wanted you to understand was कि forceps, the question that they wanted to frame was forceps cannot be used for what? Right? तो उन्होंने Wrigley's forceps दे दिया. आप लोग उसी में थोड़ा अगर उलझ गए हो कि उन्होंने Wrigley's है या Piper's है, the answer will be obstructed labor. Okay. Okay, now next. Again, simple question. Baby's head has been delivered, but shoulders haven't. After how much time will we call it shoulder dystocia? Aajkal shoulder dystocia is one of the favorite topics across all segments of exam. So all of you who are going to prepare for further exams after this, please read this topic carefully. So the answer is yes, 60 seconds. 60 seconds. Shoulder dystocia is a hot topic. Har session mein aa raha hai aajkal. Okay, all right. So what surface of placenta is this? Again, very, very simple. So remember, maternal plate or maternal surface, decidual surface and basal plate all mean the same thing. And remember, जो maternal side का होता है, that has a lot of cotyledons that looks red and shaggy and rough and dull. This is shiny. And how do you identify this is the fetal surface? क्योंकि बेबी यहाँ पे आएगा अम्बिलिकल कॉर्ड के इस एंड में, दिस इज फेसिंग द बेबी. सो इफ यू सी द अम्बिलिकल कॉर्ड, इट इज द fetal surface. Correct. Okay. Now, what is the procedure being done? What is the procedure being done? तो हमने यूट्रस के अंदर एक बलून घुसा दिया है. किस चीज के लिए? फॉर पीपीएच, फॉर पोस्ट पार्टम हेमरेज. तो दिस इज इंट्रा यूट्राइन बलून टैम्पोनाट, जिसमें हम कॉन्डम कैथेटर, बकरी बलून कुछ भी यूज कर सकते हैं. एनी ऑफ द बलून्स कैन बी यूज्ड. ठीक है, तो दिस इज इंट्रा यूट्राइन बलून टैम्पोनाट. सो वी हैव मूव्ड ऑन टू द पोस्टपार्टम नाउ. ओके, नाउ patient had a forceps delivery following which she had severe pain in the episiotomy site, and on examination there was swelling and bluish discoloration. Hypotension and tachycardia were present. Which of the thermal ablation was present? Yeah, endometrial ablation is thermal ablation. Ablation heat से ही होता है. So this is not that. जो ablation वाला जो instrument होता है hysteroscopic, that has like a small roller ball. It's not a balloon. Thermal ablation वाला जो होता है. Okay. So basically ये क्या situation बोल रहे हैं? Forceps delivery हुई, उसके बाद patient had a lot of pain. She was in shock and there was a bluish swelling. What are we talking about? What are we talking about? What is the diagnosis? नीचे क्लास में क्या डिस्कस हुआ था वो भी मैंने बता दिया है. दिस पेशेंट हैज अ वल्वार हेमाटोमा. और ये क्यों बना है? बिकॉज द इंटरनल प्यूडेंडल आर्टरी हैज गॉटन इंजर्ड ड्यूरिंग द एपिजियोटमी, और वो हमने ढंग से सिला नहीं है, कोई ब्लीडर छूट गया है. एज अ रिजल्ट ऑफ विच द ब्लड हैज एक्यूमुलेटेड एंड दिस स्वेलिंग हैज हैपेंड. एंड इतना ब्लड एक्यूमुलेट हो गया है, इतना ब्लड लॉस हो गया है कि दैट द पेशेंट इज इन शॉक. सो व्हाट डू वी डू नाउ? वी नीड टू ड्रेन दिस and we need to stitch the episiotomy properly. तो क्या गारंटी है पहली बार आपने इतने खराब से किया था लेबर रूम में, वार्ड में, और अब आप ढंग से करोगे? Because you will do it under proper visualization and under anesthesia in the OT. So you will not resuture this in the ward. So the thing that you will not do is remove the suture in the ward. You will arrange blood definitely because she is in shock. You will inform your senior and you will take to the OT and repair. यही चीज अगर पेशेंट शॉक में नहीं होती तो कोल्ड कंप्रेस से भी we could have managed. Okay. Okay. Dr. Sivai, I did not get this. So if this was not the option, can you tell me what the other option was? But most definitely, this is something that you will take to the OT and repair. You will not start doing it in the ward. The only postpartum complication जो आप then and there वो करना स्टार्ट कर दोगे आर पीपीएच एंड यूट्राइन इन्वर्जन, की यू विल नॉट वेट कि ओटी में जाया जाए, तब तक पेशेंट खत्म हो जाएगा. ठीक है, ओके. नाउ मूविंग ऑन to urogynecology. Again, postpartum complication. Woman had a difficult labor and cesarean section. She had complaint of dribbling of urine on day 7 after surgery. What is the diagnosis? Very, very simple question. I did not get the options, but we all know what we are talking about. Obstructed labor था. Obstructed labor में बच्चे का सिर बीच में आया. ये pubic symphysis था. The bladder was over here. ये बहुत देर तक अटका रहा, तो this bladder wall got necrosed, and after 7 days this sloughed off, and what started happening? The urine started dribbling from the vagina. What are we talking about? Vesico-vaginal fistula. Correct. So we are talking about VVF. So Dr. Shubham and Dr. Shivai, I think there was some other option in the previous question, so just tell me what was it? So resuscitation was there an option. तो resuscitate भी आप करोगे ही definitely because the patient was in shock. So you will resuscitate. The only thing that you will not do is start removing the sutures in the ward. You will take the patient to the OT. You will start the resuscitation. You will inform the senior if you have to. You will arrange blood. You will take the patient to OT and repair the hematoma, open the episiotomy site. सारा ड्रेन करके फिर वापस सूचर करोगे. जो आप एक चीज नहीं करोगे वो है वार्ड में सेम काम करना. ठीक है, तो vesico-vaginal fistula was the answer. Do let me know what the other options were if you remember. Okay, moving on. Again, a very, very simple question. What is the hormone responsible? So the infant is suckling and let down. मैम सही ऑप्शन थे, मेरा गलत है. ओ अच्छा, ओहो गलत हुआ. Okay, कोई बात नहीं. You can afford a couple of questions that are wrong in every subject. Overall अगर ठीक हुआ है तो एक दो क्वेश्चन की हर उसमें there is a leeway. Okay, so this is very simple. Milk ejection reflex or let down reflex. Milk formation is by prolactin and the letting down, जिसका हमारा stimulus है infant suckling, is due to oxytocin. So very simple question, could have been done in physiology also. तो इसका मुझे सवाल नहीं मिला है. Do let me know, help me out a little. How was this question framed? There was a question जिसका सब लोग बोल रहे हैं मोलार प्रेगनेंसी था, मोलार प्रेगनेंसी वाज द आंसर एंड 46XX कैरियोटाइप दिया हुआ था और P57 KIP2 नेगेटिव दिया हुआ था. तो व्हाट वाज द क्वेश्चन लाइक, हाउ वाज इट फ्रेम्ड? यही क्वेश्चन था बस. दे डिड नॉट गिव यू एनीथिंग एल्स. देयर वाज नो क्लिनिकल सिनेरियो गिवन टू यू. ओके, सो ऑलवेज रिमेंबर, ये मैंने क्लास में भी बहुत बार बताया है कि P से पार्शियल P57 KIP2 will be positive in partial mole. And remember, in partial mole, there will always be triploidy. Right, so 46XX karyotype P57 KIP2 negative is characteristically complete mole. Characteristically complete mole. All right, okay, moving on. Moving on. Correct ultrasound characteristic of ectopic in pregnancy. तो ये भी हम क्लास में कवर कर चुके हैं कि एक्टोपिक प्रेगनेंसी है तो प्रेगनेंसी ही, तो हमारा एंडोमेट्रियम लाइनिंग जो है हॉर्मोन्स की वजह से विल बी थिक. सो देयर विल बी नो थिन एंडोमेट्रियम, देयर विल बी अ थिक एंडोमेट्रियम. इंट्रा यूट्राइन अगर जीसैक हो गया तो इट इज अ नॉर्मल प्रेगनेंसी, इट इज नॉट एन एक्टोपिक. बट यस, अगर आपके यूट्रस में कुछ नहीं है और अडनेक्सा में मास दिख रहा है, दैट इज अ साइन ऑफ एक्टोपिक प्रेगनेंसी. Okay, something like they had given after abortion. Okay, so do try to frame, and if you guys can text me on Instagram, if you can DM me on Instagram, that will be great. That will help me really frame the questions properly in the booklet and we can get some more clarity. All right, okay. Now, again, very simple question, overlap between anatomy and gynae. What is this structure? What is this structure? Very simple. Pouch of Douglas. Fluid and pouch of Douglas can also be seen, Dr. Taufik, if it is a ruptured pregnancy. Okay. So 35-year-old, what were the symptoms? This question was not there, Dr. Taufik? Okay. All right. So 35-year-old female was there and she had some symptoms. All right. And what else? Okay. So do let me know. Do let me know. Okay. All right. Okay, very simple question, very simple. I think no, does not need any explanation. Necklace sign looks like a string of pearls arranged in the periphery. Same question, but male pelvis. Okay, all right. Okay, all right. Okay, thanks guys, understood. What is this image? Very simple, string of pearls or necklace sign. This is PCOS. This is PCOS. So this is the PCOS picture. And I think the question on management was first line management for female with hirsutism and obesity. So the first line, remember, always before going to drugs is going to be lifestyle modification. This is number one. This is first line, followed by second line, which is oral contraceptive pills. Oral contraceptive pills. All right, again, been covered in class. Okay, now this was a question. I don't know if this was the picture that was given. Just help me out over here. Was there anything else? So initial management will be the first line management, Dr. Odin. So the first line management or initial management will always be weight loss, diet control. If she has impaired glucose tolerance, so uska diabetic management, all of that will be the initial. Lifestyle modifications will be the initial. Okay, so the same question was given and the question was asked, what is this? So what you can see over here is, यहाँ पे कोई chocolate cyst वगैरह कुछ नहीं दिख रहा है. जो pathology है, that is not at the level of the ovary. That is at the level of the tubes. So these tubes are adhered, they are stuck together, but they seem to be normal in caliber. कोई बहुत सूजी हुई tubes या ballooned out tubes we cannot see. So definitely it's not hydrosalpinx, it's not endometriosis. And remember, genital TB में the most commonly affected organ is your fallopian tubes. So this is genital TB. This is genital TB. Fibrinoid type option. So can anybody tell me what was the fourth option for this question? Okay, so I'll wait if you guys can Tobacco bag appearance was given. Okay, so do let me know what the fourth option was. See, tubal endometriosis is a very, very uncommon site of endometriosis. Endometriosis हमें पता है सबसे commonly ovary followed by pouch of Douglas and uterosacrals. Whereas genital tuberculosis में सबसे common है हमारा fallopian tubes affect होना. Right, and you can see characteristically both the tubes, they are sort of close to each other and they are stuck and they're adhered. So this is most likely a tuberculosis. The fourth option is fibroid. तो fibroid तो ये definitely नहीं है. Fibroid अगर ये होता तो fibroid अगर subserosal होता हमें यहाँ पे एक गोलू सा दिखता. We would see a bulge over here. The problem would be at the level of the uterus and not at the level of the tubes. Right. एक जो अलग हमें चीज दिख रही है वो यहाँ पे दिख रही है. That is, this person has had a, it seems to be maybe like a tubal ligation या कुछ कराया है इन्होंने. ठीक है. Okay, moving on. Which hysterectomy has the least chance of ureteric damage? तो remember, जब भी हम कोई भी surgery ऊपर से करते हैं, पेट से करते हैं, तो that has more chances of ureteric injury, whereas vaginally. So the answer over here is vaginal. तो open laparotomy का मतलब है we are doing a total abdominal hysterectomy, robotic, laparoscopic, all of them are done through the abdominal route and all of them have a chance of ureteric injury more than that in vaginal hysterectomy. Normal was there in question. Normal तो है ही नहीं है. You can see the tubes are like sort of like this and they're stuck together. This is not the normal anatomy and they look fibrosed. ये देखो fimbrial ends also look coagulated like there is a tubal block. Okay. Okay, moving on. After how much time of a vasectomy can we advise not using an alternate method of contraception? So remember, spermatogenesis हमारा लगाता है minimum of 74 days. ठीक है. तो 74 days तक अगर मैं आज वेसेक्टमी करती हूँ, जो 3 महीने पहले का जो सामान पड़ा है या कल का जो सामान है वो 3 महीने तक आगे क्लियर नहीं होगा, 2.5-3 महीने तक. राइट. सो एटलीस्ट 3 months वी विल एडवाइज कि आप ऑल्टरनेट कॉन्ट्रसेप्शन यूज करो. And after that, we will get a semen analysis done. And if that shows azoospermia, only then we can certify this guy as having had a successful vasectomy. So the answer is 3 months. When do we need to resume? Resume what? So, no, what I'm saying, Dr. Tawfiq, is कि 74 days लगता है पूरा spermatogenesis और वो tubules में पूरा. Okay, so follow up with semen analysis. If it was there, then it is 3 months and follow up with semen analysis. So remember, 2 months is near about 60 days, right? 74 days से मतलब 74 days लगता है spermatogenesis और वो पूरा ट्यूब्यूल में पूरा जो है वो भरा रहता है. तो ऐसा नहीं है कि मतलब अगर मैंने आज किसी की वेसेक्टमी करी तो उसका एपिडिडमिस वास डिफरेंस पूरा जो है the sperms that are contained in it are sperms that were created up to 3 months back or 74 days back. तो आज अगर मैं वेसेक्टमी करूंगी, कल जो स्पर्म बनाया और ट्यूब्यूल में चला गया है उसको निकलने में ऑलमोस्ट 3 महीना लगेगा. सो 3 months तक ऑल्टरनेट मेथड ऑफ कॉन्ट्रसेप्शन, उसके बाद एक सीमेन एनालिसिस करेंगे. उसमें अगर हमारा एजोस्पर्मिया आया, देन वी आर गुड टू गो. देन दिस पर्सन नो लॉन्गर नीड्स टू यूज एनी अदर कॉन्ट्रसेप्शन. ओके ओके ठीक है. आइडेंटिफाई द इंस्ट्रूमेंट. I believe this was the picture that was given, या फिर थोड़ा glassy top था इसका. Yes, so that is the answer. 3 months and visit again with semen analysis. That was the answer. Yeah, so this is very correct. Varies needle. Varies needle is used to create pneumoperitoneum in your laparoscopic surgeries. Correct. OCP does not prevent which cancer? Again, I gave a very silly mnemonic for this in class कि diaphragm के ऊपर वाले सारे cancers जो हैं वो बढ़ाता है या controversial है और नीचे वालों के against protective है. Right. So ऊपर why it was a silly mnemonic was क्योंकि मैंने cervix को cervical I said remember neck cervix. So cervical cancer breast cancer का थोड़ा सा it does not lower the risk. बढ़ाता है या नहीं, that is a little controversial. Definitely cervical में it increases the chances of adenocarcinoma. Right. So the OCP does not prevent which cancer. So the answer over here will be breast. The answer over here will be breast. Okay. What is the drug of choice? Moving on to oncology. What is the drug of choice for endometrial hyperplasia? So remember, endometrial hyperplasia is caused due to unopposed ईस्ट्रोजन, और ईस्ट्रोजन को हमारा कौन काउंटरएक्ट करता है? अगर हम प्योर फॉर्म में प्रोजेस्ट्रॉन दे, प्योर फॉर्म में प्रोजेस्ट्रॉन, सो प्योर फॉर्म में प्रोजेस्ट्रॉन, ईदर वी कैन गिव ओरल प्रोजेस्ट्रॉन और द फर्स्ट लाइन विच इज LNG-IUS or also known as Mirena. So somebody is asking 4 months, no need for semen analysis, and 3 months should come for semen analysis if vasectomy was successful. See, the only way to know if the vasectomy is successful or not is कि आपने एक semen analysis किया और उसमें azoospermia आया. अब हम उस azoospermia देखने के लिए उसे कब बुलाएं? If I call him before 3 months, he is definitely going to have sperms in his semen, right? So we call him after 3 months और 4 months. If the vasectomy is not successful, अगर वो ढंग से नहीं हुआ है lumen obliterate, तो आप 4 months बाद भी उसे बुलाओगे तो भी उसमें sperm दिखेगा. So HSA is compulsory for telling this person that you no longer need to use a contraception. But वो HSA कब करना है? After 3 months. ठीक है? इस चैट में सारे टॉपर हैं क्या? बताओ यार, वो तो तुम ही लोग बताओगे. ठीक है. So oral contraceptives, Dr. Shubham Pandey, it's not used. Unopposed estrogen का इलाज है unopposed progesterone, तो हम estrogen plus progesterone नहीं देंगे. We will give pure form में progesterone, जिसमें LNG-IUS has a local action, better action, less profile of side effects. So LNG-IUS is preferred to oral progestins. No, danazol is not correct, Dr. Prasanna. See, remember for आगे के exams, modern gynecology में danazol is not being used for anything. So danazol कभी भी option में आए, unless of course all are used except तो danazol option में आए, तो danazol हम किसी भी चीज में use नहीं करते. We don't use danazol for anything in modern gynecology. The side effect profile is very, very high. It makes a boy out of a girl. There is hoarseness of voice, there is hirsutism. It has a very bad side effect profile. ठीक है? Already bleeding in patient, how LNG-IUS? हाँ, तो drug of choice in endometrial hyperplasia may or may not be. जब actively bleed नहीं कर रही आप तब डाल दो, या फिर हम कई बार क्या करते हैं कि हम DNC करके then we put it inside. But definitely अगर आपका LNG-IUS is not in the options, then the next best option will be oral, continuous oral progesterones. Okay, next, and I think this is the last question. In cervical cancer, which radiotherapy is given? This I have discussed on YouTube also and in the class also. There is a particular chemotherapeutic agent that sensitizes the tissues to radiation, and that is platinum-based compounds like cisplatin. So platinum-based radiotherapy is the correct option. So do let me know कैसा गया आप लोगों का. So 3 गलत होना, Dr. Shubham, is not. See, I think I discussed 27 questions. 24 out of 27 is actually a very good score. So बाकी और how many do I have any full marks over here? किसी के आए हैं full marks? Full marks is actually asking for a lot. Anybody who is above 22 on 27? There was one question regarding feedback mechanism between estrogen and FSH. So 5 wrong is still 22 out of 27. That is a good score. That is a good score. But definitely remember, for your आगे के एग्जाम्स जो आप नीट दोगे, आगे आईएनआई दोगे, आई एम होपिंग एंड प्रेइंग कि आप सबका हो रहा है. ठीक है, एंड डेफिनेटली आप लोगों का होगा द वे इट्स बीन गोइंग. ठीक है, बट डू लेट मी नो द रिजल्ट्स. आगे के एग्जाम के लिए कुछ चीजें याद रखनी है. एक है कि ओबीजी से बहुत क्वेश्चन आते हैं एंड द क्वेश्चंस आर यूजुअली सिंपल. So keep focusing on your concepts that you have already made. 2 wrong, that is amazing. 23, very good. 22, 25 right. Wow, wow. So all of you guys have done very well. Ma'am, last option was mifepristone and misoprostol. Okay, so for this endometrial hyperplasia, so mifi and miso are given for abortion. They're not given for endometrial hyperplasia. And there was one question somebody is saying regarding feedback mechanism between estrogen and FSH. So do let me know what was the question. If you can let me know right now, then I can answer it. So estrogen जो है, that will inhibit your FSH. That will inhibit your FSH. But I don't know what was the exact question. So if you can tell me, that will be very, very helpful. ओबीजी ने बचाया इस एग्जाम में. ओबीजी बेटा हर एग्जाम में ओबीजी ही बचाएगा. ठीक है, बिकॉज इट्स अ सिंपल सब्जेक्ट व्हिच हैज अ लॉट ऑफ क्वेश्चंस. इन टेस्टिस, नॉट एस्ट्रोजन, इनहिबिन बी. हाँ भेज दो voice memo. Okay, all the best, guys. So I'll hand it over to the next faculty, okay? And it seems like you guys have done very well. And all the best. Or please, I will be very happy if you can let me know the results on Instagram DM. ठीक है, all the best. And hopefully अब हम सीधा NEET की preparation के लिए मिलेंगे. FMG is over and done and dusted for you guys. Okay, so I'll hand it over to the next faculty.
Vinish sir, you're next.
Yes, sir. I'm visible and audible, everyone? Guys, am I visible and audible?
Yes, sir.
Okay. So I'll be discussing the recall from anesthesia. और somehow there is, but anesthesia के questions pick up करने में बहुत time लगा. It took us a lot of time, and even now I'm not sure what were the questions and what were the options from anesthesia. So I will need all you guys to help me to frame the questions and form the answers, but still I'll do the recall. I'll hardly take about 5-10 minutes. Okay. So we'll just start. The first question that came was very simple. And this was: a patient developed malignant hypothermia after inhalational anesthesia, and what was the treatment? I could not get the options, but we know the correct answer there was dantrolene sodium, right? People with any other answer, guys? What were the other options? Anyone? If you can recall. Yes, anyone? What were the other options? So this has been covered in all the classes that we take every time we discuss malignant hypothermia. This was expected question always, and it was easy. Dr. Sivai says potassium. It's a direct question nahi tha. Correct. I agree. It was not direct because anesthesia I found very difficult to find the questions. I'm still not sure. Okay. Dr. Shubham says only 3-4. Yes, 3-4 के आसपास मुझे भी मिले हैं, but I just want to confirm with you guys. So one was regarding malignant hypothermia. I'm sure this was exactly not the words which you people are telling me. If you can correct it, it's fine. But yes, the question was related to malignant hypothermia, especially after the use of inhalational anesthetics, and the treatment was dantrolene sodium was the answer. Okay, so other things you're saying, present options given were adrenaline, calcium, history was given. Okay, so patient's history of malignant hypothermia was given, and you're saying dantrolene, adrenaline, calcium, and potassium were the other options. So this was the question that was framed. Good, guys. So thank you so much. So this question has been framed. As we said, we have discussed that we'll come back with a proper recall within 1 or 2 days. Here we are just trying to have a fast recall. So this was the first question. The second one, this is again a pharmac and anesthesia question sort of combined, which some students have told me. Question mark. You have to correct me whether I'm correct or wrong. Which of the following is not reversed with atropine? I think there were 4 options given. One was bradycardia, other was muscle weakness. So of course, when you give atropine, it increases the heart rate. So therefore, bradycardia gets reversed. But atropine is not used for the reversal of muscle weakness. Okay, it cannot be reversed. For example, I mean, for me, the point was they are discussing basically if you're using a reversal is done with neostigmine, and along with neostigmine, you add atropine. But that atropine is not for the muscle weakness. That atropine has been added to take care of the muscarinic side effects, right? So if you are discussing about reversal with a muscle block, which I could understand, you please correct me if I'm wrong with the question or the options. But from what I could gather, if they are talking about the reversal of muscle block, in this case, what you're going to use is neostigmine. Ideally, the drug uses neostigmine, and then along with that, you use atropine. But this atropine is basically used to counteract the muscarinic side effects. So therefore, the correct answer would be muscle weakness is not normally reversed with atropine, right? So this was my point. I may be wrong with the questions or options. You guys please correct me. You can DM me as everyone, like in my Insta account, and then we can have this question correctly done. Okay. The next one. Here again, I could not find all the options. But what is the last link in the ACLS chain of survival? So therefore, the last link which has been added is recovery. And this recovery is basically both emotional as well as physical recovery. Emotional and physical recovery. In fact, a question related to this recovery was even asked in the INI-CT exam, which was held the last time around. Okay. So other options, if anyone can recollect, please let me know. I don't know the other options, but all I could gather is that ACLS chain of survival was the question. And the answer option given, one of them was the recovery. Dr. Shubham says 100% recovery, And Dr. Kritik Patel says one option was post-operative care. Very nice. Very nice, guys. You guys really have remember the points, huh? Not very easy to remember. Because anesthesia was difficult. Not difficult, I'll say, but anesthesia questions were not the ones which usually come. So this was again one question we know they ask about recovery, but not in this manner. So one option was post-operative care. Very nice. So let's put it over here. Post-operative care. Another was post-cardiac arrest care. Post-MI care. So post-MI care हो गया. 100% recovery हो गया. Post-cardiac. 5 ऑप्शन कैसे आ गए यार? Post-cardiac arrest. Post-cardiac arrest care. Okay, so let's put it this way. One option was post-operative care. Post-op नहीं होगा ना यार? Post 100% recovery. So anyway, so let's put it this way. The 100% recovery has been added as the last link in the chain of survival. And post-operative or post, this can be, one option was activation of emergency response. Dr. Shubham says, sir, post-cardiac arrest ही था. सारे गलत हैं. Post-cardiac arrest. Post-cardiac arrest था. So according to you, the recovery was not there then, Dr. Shubham? This option recovery was not there? Right? Activation of emergency response. So activation of emergency response. Agreed. Activation of emergency response will not be the last link. Okay. So again, we need to frame this question correctly. That's what I said. Anesthesia ke questions, it's very difficult. I could not find the options, neither the proper questions which are there. Dr. Kritik Patel says, I don't remember recovery. You may be right. You may be right. So that's what Dr. Shubham is also saying. Sir, post cardiac arrest ही था, सारे गलत है. Please, anesthesia में, I am very sure. Don't think which is correct or wrong because I was not able. None of us were able to find the proper questions and options from anesthesia. So guys, don't worry about the anesthesia part. You must have done correctly. Okay. Dr. Prasanna says, yes, activation of emergency response is one option. Good. So that point is there. Sir, Google pic ACLS pic was given, says Dr. Sivai. Okay. So ACLS picture was given. Was it like this? That one like this? 1, 2, 3, 4. This chain, something like this. 1, 2, 3, 4, 5, and 6. Was something like this given, guys? A picture like this. Was it given like this? So if an image was given like this, 1, 2, 3, 4, 5, and 6. If they are given an image like this, then the answer is recovery. If this image has been given, guys, then the answer is recovery. It's as simple as that. Okay. If this is the image given, then this is the answer is recovery then. Whatever be it, if this image has been given, then this is the last link of survival. And here the answer is recovery. Okay. So right. So I mean, our question is correct. The framing is wrong. Didn't know that the image has been given. But this is the answer then recovery. So as I said, INI-CT also, they asked this question about the after CPR, what is being done? They are asked about the recovery. So correct. So this is that question. Let me take another one then. Fine. Thank you, guys. Thank you, guys. They had given order last added update. Okay. So they have given that in ACLS, they've given last update. Okay. So instead, it can be like this. What has been the last in the ACLS chain of survival, the last update added? Maybe something like this. Last update added in the ACLS chain of survival. Right? Maybe something of this sort. They're given order last added update. Sort of like this. Basically, the point is what has been added in the last, and that is recovery. That recovery has been given in 2020 guidelines, ACLS 2020. These guidelines, they had added the recovery part where they had mentioned specifically about the emotional and the physical recovery. So this is that option. The sixth part is then basically recovery. Okay. So hopefully this is the question, this is the answer, and most of you must have marked it correctly. Okay. Next. Okay, so this again, as ma'am had discussed, I think the option given was Very's needle, but some students had told me, sir, one of the options given was Tuhi needle also. So my point was, in case if the needle had 1 centimeter markings, then the answer was Tuhi needle. But as Dr. Oshika ma'am has said, maybe the question given to you was Very's needle. So the correct answer here is Very's. Okay, Dr. Odin says where to share. You can share it on my Insta ID. My Insta ID is dr.vinish. You can DM me there. Okay. So try to share it over there, guys. Okay. Correct. It is Very's needle, guys. But as I said, a lot of students had told me one of the options given were 2He needle. So that my point was, if it is 1 centimeter marking given in the needle, then it becomes a 2He needle that is used for epidural. So one of the options was 2He needle. And of course, Very's needle is, as Dr. Oishika ma'am said, which is used in gynec surgery laparoscopy, right? Very's needle. So I've given my Insta ID also to you guys. Let me take the next one. Right, now this question I could not get, but most of the students said there was a question like this, which had mentioned that neck vein is dilated, cord-like structure palpated, and something related to anesthesia. And the options that they had mentioned was regarding external jugular vein. I could not find the proper question. I could not get the other options. If you can guys help me with this, then yeah, we can form the question and the answers. Okay. So Dr. Shubham guys says thrombophlebitis answer tha, and image based question, great auricular nerve option was given. Okay, so this was an image based question. This was thrombophlebitis. So good, yeah. I was listening. Actually, I listened to everyone. No? We were listening to all of them. I know all of you have answered so well. If just by knowing your answers, I know all of you have cleared. Huh? So don't worry. We don't know the questions, we don't know the answers, but you guys are giving us the correct answers and correct questions. Image had hand drawing, and greater auricular nerve was an option. So greater auricular nerve. Greater auricular nerve. Thrombophlebitis. Right, something of this sort was there. Route through we can give. One option was auricular nerve. Correct, that's what I put, na? Greater auricular nerve. Ek answer dal diya, thrombophlebitis we have to put there. Image was there. So right, we put an image over there. Image based question. So correct. So here the answer, as you people are saying, the answer was thrombophlebitis, right? Neck node chain was given. So basically, they've given an image of thrombophlebitis, right? They've given an image of thrombophlebitis in the vein, and they've asked you what is the structure that is felt and palpated. So whether the structure is a nerve, whether the structure is the inflammation of the vein which is seen, or if it is a neck node chain, right? This is what I gather. Neck node chain. So this was one of the questions, with options that we didn't expect. And as you must have seen this time paper, the questions were the same, PYQs, PYTs, but the wordings have changed, the questions have changed, and they have framed it in a very different manner. Dr. Shubham says, chain of cervical lymph node. हाँ, correct. तो यही हो गया ना, neck node chain मतलब ये chain of cervical lymph node हो गया. Chain of cervical lymph node. Correct. This was one of the options then, chain of cervical lymph nodes. Sir, I have photo I'll send. Please, Dr. Odin, please send it. My Insta ID is dr.vinish. You can send it. Please DM me. Right. So we'll come up with a good and a proper, recall after about in a day or two. Once we get the questions, once we have the answers, we'll frame it. Till now, this is what I could gather. So you could see there are these 3 or 4 questions which I could gather from anesthesia. And of course, as you have seen, most of the questions and options we have formed while discussion with you guys, right? Otherwise, we didn't know the proper stem of the question, the correct options which were there, and you guys have helped us. There was one more question, guys, which was related to aspirin and anesthesia, where I don't know what option was given, but some students says it was regarding aspirin when it is stopped. But most of the students said, sir, this question was not there, but something was given regarding aspirin. So anyone, was it related to aspirin and pre-anesthetic checkup or something of that sort? Or when is aspirin stopped before surgery? Something of this sort. Maybe it's not related to anesthesia. I totally agree. It might be related to pharmac also. But because when students were recalling it, this was another one question that they said when I kept on asking them about anesthesia, someone said, sir, aspirin bhi tha. Okay. It was regarding surgery. Dr. Sivai says. Okay. Bleeding related question was there regarding surgery. So it was not regarding pre-anesthetic checkup. So probably it was what drug is to be stopped before surgery? Okay, there we get one question. So which drug? So guys, what were the options then? Very nice. So I'm now getting the question. So this was question related to pre-anesthetic checkup. Which drug is to be stopped before surgery. Very nice. Which drug is stopped before surgery? Very nice. So what were the 4 options then? Very nice. So if we can put one option as aspirin, what were the other options if anyone can recollect? Pril. Very nice. Pril means you have yours, all those ACE inhibitors. Very nice. So ACE inhibitors normally are stopped 1 day prior to surgery. इसको बंद किया जाता है. Other is clopidogrel. That is also stopped. Clopidogrel. Very nice. Clopidogrel is normally stopped 5 days prior to surgery. 5 to 7 days. तो यहाँ पे सभी ड्रग बंद हो रहे हैं यार. 5 to 7 days prior to surgery. ACE inhibitors stopped, correct. Clopidogrel, aspirin, and the 4th option, guys. So the question can be like this: all the drugs are stopped before surgery except something of this sort can also be there, na? Because ACE inhibitors normally are stopped 1 day prior. Clopidogrel is definitely stopped 5 to 7 days prior. Normally they say aspirin nowadays has 2 things. Aspirin is not stopped for some surgeries, but if a patient is on a high dose of aspirin, you stop it almost 72 hours prior to surgery. Okay, the question was asked 1 day prior. Okay, very good, very good. Which drug is stopped 1 day prior? Very nice, guys. Very nice. You guys have made me recall this question with your options. Perfect. Which drug is stopped 1 day prior to surgery? Very nice. And here the answer is ACE inhibitors. ACE inhibitors. If this was the question, अरे यार फिर एक और point आ गया. Sir, it was regarding whether to increase the dose of aspirin. Okay. One more question. Okay, yes, Dr. Shubham, this was question also there. Left endobronchial intubation. Then I thought it is related to congenital diaphragmatic hernia. ये देखो, आ गया मैं question पे भी. I had put it, but I was thinking it is congenital diaphragmatic hernia. So this is also one question which I gathered. Okay. Anyways, so this question probably, guys, is which drug is stopped 1 day prior to surgery? So again, please send me the options, DM me, as I said, on Instagram, and we'll try to frame the question, get the options, and come with a proper recall. So remember, aspirin normally 72 hours पहले बंद होता है, clopidogrel 5 to 7 days, ACE inhibitors is stopped 1 day prior. 4th option अपने को पता नहीं चला, right? And if it is a dose of aspirin, again, maybe we'll have to frame the question correctly and have more options. If the dose of aspirin has to be reduced. So normally dose of aspirin is not reduced. Dose is not reduced nowadays, guys. Okay. Dose is not reduced. And the last thing, as Dr. Shubham says, this is another last thing which I put out, one X-ray was given and probably the X-ray was congenital diaphragmatic hernia. I'm not sure. And one more question was there: inserted endotracheal tube in the left lung, respiratory distress in the other lung. Right. So again, Dr. Shubham, this is one thing which I don't know exactly. So I just thought that X-ray has been given from what I gathered. And the X-ray was maybe what I thought was congenital diaphragmatic hernia. That is what I thought from what the student said. And I thought it is not a left endobronchial intubation and not tracheal foreign body. But if anyone can help me with this. It was something cardiac surgery. Cardiac surgery. Okay, so the question was related to cardiac surgery. Then, someone says D-benzodiazepine. Okay, I got the answer. Thank you. So let's put the D-benzodiazepine. And remember, benzodiazepines are not stopped. So this finishes off this aspirin question. Very nice, guys. Thank you for helping me out. And tube was placed. There's the other option. बच्चे पागल हैं. अरे बच्चे पागल नहीं, हम भी पागल हैं यार. सबके सब, all of us are the same thing. We are sailing. All of us are sailing in the same boat. We're just trying to have a small recall. Don't take too much tension. It is for our thing only. Now it's nothing. हम अपने लिए कर रहे हैं बस. ठीक है? तो ऐसे recall से हमें अच्छा लगा. Don't worry. All of you have given very good answers in all the subjects. I heard all of you. Okay? Don't think that there's one question here and there is going to make a difference. Case scenario था of left bronchial intubation. Case scenario of left bronchial intubation. Right sound can't be heard on the right side, but left side is normal. Okay, so left bronchial intubation, sound not heard on the right side. Sound not heard on the right side, and left side is normal. हाँ, तो in this case अगर तो आंसर यही हो गया ना, left endobronchial intubation हो गया. Okay, so anyways, guys, DM me. It is difficult to frame the question. Plus, Dr. Jazir is also waiting, the faculty over there. So please DM me the question and option. So this is another question which we have found out might be there from anesthesia. So please help me out with these the question and the options, and then we'll come back with a complete recall. In 2 days, we'll just try to get the complete recall, 2-3 days, right? Give us that much time. So guys, thank you. I'll continue and give it to the next faculty. This was the last question from my side. And please DM me, as I said, on dr.vinish. That's my Insta ID. Sir, over to you. And that was from my end, anesthesia. Thank you so much, sir. And thank you, guys. Thank you so much. I know it's quite late. So thank you, guys.
So you can start, sir.
Yeah, shall I start?
Yes, sir.
Okay, almost it is the next day right now. We don't have much of any difficult questions as far as pediatrics is concerned. And I don't think any new questions or new topics were added. Majority of them from old questions only, and majority of them they had covered only core topics. So if at all the question stem choices, everything is based on the options given by you based on your recall. As our previous faculty said, if you have any other issues with respect to options or STEM, you can directly message us to either Insta or PW Telegram channel. So going back to our first question, right? A child with a mid-arm circumference of 10.5 centimeter and eating food well disease. And as you all know that the mid-upper arm circumference is less than 11.5 centimeter here. So it comes under severe acute malnutrition. Right. Since the child is having severe acute malnutrition, we need to treat the child. The child can be treated on OP basis or on IP basis. So which makes you to treat them based on OP or IP basis? This is again discussed in our PW MedEd channel. Look at this. Whenever you have complications such as severe edema, low appetite, failed appetite test, in the presence of other medical complications like severe anemia, hypothermia, hypoglycemia, infections, in all those instances, you need to admit the child. And you have any associated systemic illness like HIV, TB, or any other danger signs as per IMNC. What are all the danger signs? Not able to take fits, vomiting everything, cyanosis, convulsion, lethargy, and refusal of fits, all come under danger signs as per integrated management of neonatal and childhood illness. So remember, whenever any one of these complications are present, the child has to be admitted, and treatment should be based on inpatient management, because you need to treat the complications and you need to expect a morbidity as well as mortality in the presence of these complications. But in the absence of any of these complications, a home-based supervised treatment is more often enough to treat the child. So as far as this question is concerned, definitely it doesn't come under normal nutrition, and we don't have any much points to add other things with respect to severe acute malnutrition. And as far as the recall pattern is concerned, there were no other things mentioned with respect to any danger signs or any other associated complications associated with SAM. So probably the choice should be an uncomplicated severe acute malnutrition, because the child is able to take feeds well. Whenever any child, whether it is severe acute malnutrition, pneumonia, diarrhea, or anything, as far as IMNC is concerned, the latest treatment regimen is, as far as possible, don't admit the child, and any child who can eat and who can pass motion or urine on their own need not be admitted. So this is a case of an uncomplicated SAM. Right. Let's go to the next question. A child with increased upper segment and lower segment ratio, what is the best diagnosis? You all know that upper segment to lower segment ratio at birth is 1.7:1. And yes, very good. Who is this Prasanna? Yes, you are correct. If you find any other options, different options or anything with respect to stem of the question, please message me in YouTube. I'm watching your comments too. All right, so upper segment to lower segment ratio is usually 1.7:1, and gradually it is reduced to 0.1 per year. So what happens by about 7 to 10 years, it becomes 1:1. So this is the normal upper segment to lower segment ratio in pediatric children. Whenever you come across any child with a short stature, etiology can be determined by measuring upper segment to lower segment channel. We have some condition in which upper segment to lower segment increases, some conditions in which upper segment to lower segment decreases, and some conditions in which upper segment to lower segment remains the same, otherwise known as proportionate short stature. Let's come to the first point, upper segment to lower segment. Upper segment is nothing but your spine, whereas lower segment is nothing but your limb. So what does it mean? Whenever your upper segment to lower segment ratio increases, means invariably you are dealing with a case of short limb, okay, dwarfism. What is that? Short limb dwarfism. Whenever your upper segment to lower segment ratio increases. So when upper segment to lower segment ratio increases, means it is usually short limb dwarfism. So what are all the conditions that are associated with the short limb dwarfism? So again, it was discussed in our channel, HART. So what are all the 4 options or 4 things that you can remember? Hypothyroidism, achondroplasia, rickets, and Turner's. These 4 things are associated with short limb dwarfism. But when your upper segment to lower segment ratio decreases, it means your spine is affected. Example, it can be a mucopolysaccharidosis or part spine or spondyloepiphyseal dysplasia. In these conditions, your upper segment to lower segment ratio is decreased. Whereas in one particular condition, such as growth hormone deficiency, in which your upper segment and lower segment are proportionately decreased. So by just measuring the upper segment to lower segment ratio, it will be easy for us to find out the etiology behind short stature. So here, increased upper segment to lower segment ratio, what is the best diagnosis? So, okay, whatever it might be, you need to know the basis behind the question. The conditions associated with upper segment to lower segment ratio increased are hypothyroidism, achondroplasia, rickets, Turner's, whereas reduced means short limb dwarfism, mucopolysaccharidosis, rickets, and then spondyloepiphyseal dysplasia. Proportionate short stature means growth hormone deficiency, spondyloepiphyseal dysplasia, reduced upper segment to lower segment ratio, Alagille syndrome again associated with some vertebral issue, TB spine, part spine is associated with the destruction of the vertebral body. So very good. As such, someone of you had mentioned B, definitely it's an odd man out. In achondroplasia, it is a short limb dwarfism and not short spine dwarfism, as a result of which upper segment to lower segment ratio is increased in achondroplasia. Apart from that, hypothyroidism, rickets, and Turner's, if it is mentioned, can be an option too. Right. So let's go to the third question. 2-year-old child. Okay, you can interrupt me in YouTube if at all my options on stem of the question is wrong. Right. 2-year-old child came with the fever, cough, and fast breathing, along with a respiratory rate of 48 per minute without any chest indrawing. Again, this is also discussed in our channel in recorded videos. So very simple. You need to know 3 things: respiratory rate, as well as retractions and presence of any danger signs. When rate is increased, retractions are not there, danger signs are not there, we call it as fast breathing pneumonia. Whereas when you have tachypnea, no sir, 3-month-old child, 55 respiratory, okay, then we will change it. No issues, my dear, we will change it. So when rate is increased, retractions are there without danger sign, we will call it as chest indrawing pneumonia. Whereas when you have danger signs, we will call it as pneumonia with danger signs. As far as the new IMNC is concerned, we classify pneumonia into two things. One is non-severe pneumonia, another is severe pneumonia. Under non-severe pneumonia, you have two things. One is fast-breathing pneumonia, another is chest-indrawing pneumonia. Pneumonia with the danger signs will come under what is that? Severe pneumonia. Right now, we don't have any classification such as very severe pneumonia. Right. Many of you have been giving, okay, whatever it may be. Right. So this non-severe pneumonia, why it is called so? Because both fast-breathing pneumonia and chest-indrawing pneumonia without any danger strain can be treated on home-based management or otherwise known as domiciliary management. So what is the treatment of choice? The treatment of choice is amoxicillin, 3 days in case of fast-breathing pneumonia and 5 days in case of 3 days in case of fast-breathing pneumonia and 5 days in case of chest-indrawing pneumonia. Remember the dosage is 80 mg per kg per day in 2 divided doses. 3 days, as I told you, fast-breathing pneumonia. 5 days in case of chest-indrawing pneumonia. But pneumonia with the danger signs means it is usually ampicillin at 200 mg per kg per day, along with the gentamicin 7.5 mg per kg per day for about 7 days. Since many of you had told, what is that 4-month-old child? So let me come to you. 4-month-old child, and the child's respiratory rate is 55. Thank you, my dear. So less than 2 months, 2 months to 1 year, and then more than 1 year to 5 years. Less than 2 months, more than 60 per minute. 2 months to 5 years, more than 50 per minute, and more than 1 year, more than 40 per minute. So here you have rate is 55 per minute. So it comes under pneumonia. It comes under pneumonia. So the answer, as far as your statement is concerned, your choice is concerned, it is pneumonia. It is no pneumonia, no, the respiratory rate is high. Severe pneumonia means neither chest-indrawing nor danger signs are mentioned, provided the options are correct given by the recall group. And very severe pneumonia, I repeat, there is no such entity called very severe pneumonia as per the latest IMNC guidelines is concerned. So it is just either no pneumonia, pneumonia, or severe pneumonia. As per the choices given by you, it is pneumonia. I hope it is a very easy question, and I hope you have answered well. Yes, options are simple. Yes, okay then. Intradermal IPV injection schedule is, I am also really not comfortable with the neither the stem nor with the options. We all know that initially IPV, intradermal IPV is given at 6 weeks and then given at 14 weeks. Am I correct? Given at 6 weeks as well as given at 14 weeks. But 3 years back, so this is called primary series. This is called primary series. I hope you all know that oral polio vaccine, which is a live vaccine and can produce vaccine-induced poliomyelitis, as a result of which OPV is going to be withdrawn from the market soon. That's why an injectable killed polio virus, intradermal IPV, injectable polio given intradermally at 6 weeks and 14 weeks. This is very good guy, very good guy. Okay, this is before, but 2 years before, they had also added intradermal IPV booster at 9 months. 9 months. The same is for PCV vaccine too, at 6 weeks, 14 weeks, primary series, followed by booster at 9 months. So the answer for this question is someone, Sivai. Sir, if chest-indrawing present means Chest-in drawing present means also at present it comes under non-severe pneumonia or pneumonia only. Even if chest-in drawing is mentioned, pneumonia will be the correct answer. Only in the presence of not able to take feeds, vomiting everything, saturation of less than 60 per minute, convulsions, lethargy. Even one of these points were mentioned, it should come under pneumonia with the danger signs or severe pneumonia. Rest, your fast breathing as well as chest in drawing comes under pneumonia only. You will be correct only. Even if chest in drawing is also mentioned, they would have mentioned, your answer will be B choice only. That is pneumonia. Okay? Right. So again, this is a easy answer. Probably 6 weeks, 10 weeks under 9th month booster. Okay, right. Yes, Guy. Danger signs are present. I hope in your question it was not mentioned, I think. Right. Again, this is also a very, very easy questions. Easy question. And we regarding that, some more thing also I would like to mention. It was mentioned in our class. Okay, IPV at 6 weeks and 14 weeks, they are giving intradermally in right arm. Whereas IPV at the 9th month, you are giving intradermally in the left arm, because in the right arm, you will be giving measles and rubella vaccine 1, MR1. So right arm in case of 6 weeks and 14 weeks, left arm in case of vaccine given at 9th month. Right. A 2-year-old child with a metallic cough and stridor, X-ray, I think they had given a steeple sign. They had given steeple sign, and you all know that. You all know that steeple sign indicates that it is group. But remember, my dear friends, almost each and every question, whether it is FMGE or INI-CAT or NEET, definitely they are concentrating on questions with respect to ALTB. So I would like to mention some few points, because each and every time, almost each and every year, there is a question on group. So let me add some 5 points which might be new to you, and it was covered in our class. So what are all those new points? Point number 1, any virus can cause. Point number 1, any virus can cause. It is not only para-influenza. It can be called by influenza. It can be called by COVID. It can be called by human metapneumovirus. It can be called by RSV, adeno. Any virus can cause this ALTB. Point number 1. Second, the only non-viral infection, I repeat, only non-viral infection that cause croup, non-viral infection that cause croup. Can you tell me what is the answer? Only non-viral infection that can cause croup. I'll give you a gift. So it is nothing but mycoplasma, the only non-viral infection that produces croup. Second point, steeple sign. Very good. Steeple sign, biphasic stridor. Why biphasic stridor? Because subglottic area is involved. Second point. Third point, I would like to mention some points with regarding to steeple sign. It is neither sensitive nor specific. So what does it mean? Even children with the croup symptoms, biphasic stridor, can have a normal X-ray. In the same way, okay, you can have a steeple sign, but child can be a normal one without any stridor or metallic cough. So remember, steeple sign is neither sensitive nor specific. And last point I would like to add is the drug of choice is not adrenaline. I repeat, the drug of choice is not adrenaline. The drug of choice is dash, steroids. Either it can be a Dexa, yes, guy. But the drug of choice is not adrenaline. Even in mild cases, adrenaline you will give in cases of moderate to severe croup associated with severe hypoxia. But steroid is the drug of choice. Either it can be a dexamethasone, or it can be a nebulized budesonide, or it can be a oral prednisolone. But whenever you diagnose croup, your next thing should be any steroid in any form, nebulized form, Oral form, IM, IV, anything. Even in mild cases of metallic cough or croup, without any spider at rest or exertion, you need to give a single dose of steroids, whatever the route is, whatever the steroid it is. But you need to give a steroid. That's all. That is a great carry-home message. And one more MCQ. Once it was asked, when they say you will get less fever in case of croup, less toxicity in case of croup, but when the child becomes highly toxic with the febrile, you need to rule out what? When your underlying case of croup, if the child develops high-grade fever, always think in terms of bacterial tracheitis. Bacterial tracheitis, which is usually caused by Staph aureus. Usually caused by Staph aureus. All right. And this is also very easy one. What is the deficiency associated with? I think they had given a question with respect to acrodermatitis enteropathica, and you all know that acrodermatitis enteropathica is associated with zinc deficiency, congenital zinc deficiency. It can be okay, congenital zinc deficiency. Right. Can anyone tell me what is the manifestation of a copper deficiency? Copper deficiency usually associated with microcytic hypochromic anemia, like iron deficiency anemia. But another clue that is associated with copper deficiency is presence of neutropenia. Presence of neutropenia. So one cause for IRIDA or microcytic hypochromic anemia that is not associated with that is not responding to iron but associated with the neutropenia is copper deficiency. And Subham Gai and what is that cinema sickness? What is that cinema sickness? I don't know. They had mentioned Wilson and Menke. See, it is not associated with what happens. It is associated with copper transporter. The body has excess copper that cannot be transported inside the cell. So ATP 7B in case of Wilson, whereas copper toxicity you will have, whereas ATP 7A in case of 𝐒𝐿𝐴 hair disease. 𝐒𝐿𝐴 hair disease. And as Subhash Ghai told that selenium is associated with Keshan's cardiomyopathy. Zinc is associated with acrodermatitis enteropathica. You need to give a minimum of 50 milligram of zinc per day lifelong. So what are all the other questions that can be asked with respect to zinc deficiency apart from this skin manifestation? Look at this. You can have hypogonadism. Because of reduced cell immunity, you are prone for recurrent infections, diarrhea, and acrodermatitis enteropathica, which is given in your stem of the question, right? Then 2-year-old bowing of legs. So I really don't know what is the exact stem of the question. Someone had mentioned parathyroid hormone level increased and calcium level query, and they had given a bow legs and what is the diagnosis. People are thinking in terms of rickets. Is it really so? My dear boys and girls, is it really so? I really don't know what is the real stem of question. X-ray was given. Okay. Is there any mention regarding phosphorus or parathyroid hormone with respect to this question, or any other question they had asked apart from this image? Might be one more question with respect to parathyroid and calcium. Is there any question low phosphorus, low calcium mention? Okay, then. So whenever you have, so a 1 minute approach to rickets. So let me complete a 1 minute approach to rickets. Rickets around. Okay, rickets. Let me complete 1 minute approach. So when you have a case of rickets, the first and foremost thing is you need to do serum phosphorus. So when phosphorus is low or phosphorus is high. When phosphorus is high, invariably you are dealing with a case of chronic renal failure. So you need to take urea and creatinine. When serum phosphorus is low, the next thing is you do pH. So when pH is low, either it can be proximal renal tubular acidosis, in which there will be phosphorus loss, or distal renal tubular acidosis, in which there will be a calcium loss. When pH is normal, then you need to look for parathyroid hormone in the presence of a low phosphorus. So now you have a combination of low phosphorus and PTH. The value of calcium, I don't think you need to solve a case of rickets. I repeat, you don't require values of calcium to solve cases of rickets, because it can be normal due to secondary increase in parathyroid hormone level. So when you have a low phosphorus and a high parathyroid hormone, you can have one combination. Either it can be nutritional rickets, or VDDR type 1, or VDDR type 2, vitamin D resistant rickets type 1 and 2. When you have a nutritional rickets, you will have reduced to 25 hydroxy D3. Whereas 125 will be dihydroxy D3 will be reduced in case of VDDR type 1, and 125 dihydroxy D3 will be increased in case of VDDR type 2. So these are all the nutritional rickets, and this is associated with alopecia. Which one? VDDR type 2. Another option is when you have low phosphorus and a normal parathyroid hormone, means you are dealing with a case of hypophosphatemic rickets, in which you will give Julie solution or phosphorus supplementation. But right now it has been replaced by bevacizumab. Okay. It is replaced by fibroblast growth factor antagonist they had given. So this is replaced. So bowing of scurvy, you will get painful scurvy. Scurvy means you, instead of bowing of legs, you will get pseudo paralysis. You will get pseudo paralysis in scurvy because of subperiosteal bleed. Again, you will get pseudo paralysis in case of syphilis. Okay, in rickets, you will have delayed motor milestones. I really don't know what is the correct stem of the question and option. If you send us to our channel or to our Instagram, definitely we will make a perfect question and with a perfect answer. And finally, the last one, do you have any such question like this? Which of the following parameters is affected in chronic malnutrition? You all know that when weight is affected, it is called wasting. And it is acute malnutrition. When height is reduced, it is chronic malnutrition. Chronic malnutrition when height is reduced. Okay, chronic malnutrition. So what is this? This is chronic malnutrition. That is called stunting. And finally, when weight for age is reduced, what we call it as undernutrition. And again, we really don't know what is the exact stem of the question as well as the choices. And I hope when you say this is the correct stem and options, then B is the correct answer. So with this, I am finishing my pediatrics topic, as well as we are finishing this marathon session started yesterday and we are finishing it today. Thanks for the patient listening, first of all, to you as well as our convener Ranjit. Okay, over to you, Ranjit.
Thank you. Thanks a lot, sir. So guys, thank you first of all for you to stay till 1:30, close to 1:30 in the next day. And I'm sure that few of you have been very, very consistent and contributing. First of all, if it comes to my mind, Shubham has been constantly helping us with the options, cinema sickness, why, and many other
There
people.
also mentioned one question, a question on para-pneumonic effusion. If you say so, definitely we are here to complete the question as well as answer, provided Ranjit allows me.
Sure, sir, definitely. Shubham, if you can give us the questions, I'll definitely give you the answer. And if you're not able to, just ping us there. We will definitely put up in a compiled version and give it to all of you guys. So this marathon session will not end without thanking everyone behind the scene. We have all the students who have been helping us with the recall, Dr. Arshad, Dr. Vijay, and Dr. Anto, Dr. Mamu, Dr. Hara, everyone who's been orchestrating the recall and the entire smooth process of the studio team, headed by Aditya, and handling the teachers, handling everything happens perfectly. Kanchan was there, and Raman, who is helping us with the entire thing, overall viewing everyone. And special thanks to all the faculties, and especially with Suraj sir as well as to Dr. Sandeep, who went to the place and also talked with you in the exactly in the exam hall and got lots of inputs to us. And this doesn't end here. You will definitely clear the exam, FMG exam. Maybe in a couple of weeks, you will know the answer results. Once the results are there, we'll definitely celebrate once more again. Shamlal, we're not sure about it. It's with NB. You know NB. Dates will be announced by NB whenever they feel like and whenever the result comes. We'll definitely celebrate the results and hope that all of you will join your internship in the coming year. And let's see, let's keep the make a flag fly high, and see you soon, guys, on the other side. Thanks a lot very much for your patient listening. And it's close to be 1:30, right? You started today around maybe 7, 8 a.m. till 1:30 is an amazing feat. Hope you have the same energy throughout your life and career. Bye-bye. Thank you, guys. Aditya, you can